Thank you, sir. Any occasion has to start. Now it is the time for us to light the Kuttuvelakku. I request that all the dignitaries to come forward to light the lamp. I invite Dr. Dhanamendran sir, founder and president D Club, Dr. P. Parandaman sir, organizing chairman, Dr. G. Jayakumar sir, scientific chairman, Dr. U. V. Mohan sir, joint secretary, and Dr. Swami Kannu sir to join the dais. It is now time to formally begin the scientific program. I welcome Chairperson Dr. P. Parandaman sir, former Professor and HOD Department of Medicine, Government Kilpak Medical College. Dr. G. Jayakumar sir, Consultant Physician and Diabetologist. Now we invite Dr. Srinivasan Paramasivam sir.
Very good morning to President Ronaldo present here. It's a warm welcome to DCCON 2025. To begin with, we have the first session, the clinical recognition of acute stroke and its management. Time is brain. Time lost, brain loss. Every 1 minute of stroke, 1.9 million nerves are dying. If time is wasted, brain neurons are wasted. To talk on this, we have very eminent surgeon, neurosurgeon, neuroendovascular surgeon, Dr. Srinivasan Paramasalam. He is going to enlighten us about the stroke management, how to be fast, how to be accurate. And he has published more than 30 peer-reviewed journals, and he has authored more than 12 books in neurology and interventional neurology. He is a consultant neurosurgeon and neuroendovascular surgeon. Over to the speaker.
Good morning, everyone. Thank you, dear organizers, for giving me this opportunity and especially having me as the opening batsman to start the D-Club meeting. Thank you, sir, for your kind introduction. Let me just go straight to the topic. Stroke, as we all know, is a disease that has been there for ages, but our treatment for stroke has significantly evolved. Following the interventions that has significantly improved the quality of life in cardiology, the neurological outcomes after interventions have significantly improved, and it has changed the way we look at strokes and we treat it. We all know that stroke is a sudden dysfunction of the affected part of the brain. It may be due to a blockade of the blood vessel that is called an ischemic stroke, or a hemorrhagic stroke, which is due to the bleeding either within or just at the base or outside the brain that causes a dysfunction of the brain. Today we are going to highlight predominantly on the stroke and especially the ischemic stroke part of it, because this treatment has evolved over the last 2 to 3 decades. The ischemic stroke may be a small vessel stroke where a small vessel in the distal part of the cortex is affected, or maybe a large vessel occlusion. The significant change in the last 2 decades have been in the treatment of these large vessel stroke, and together with the small and the large vessel, they constitute about 80% of the stroke. For example, somebody has a large vessel occlusion. What exactly happens? Each minute the neurons are dying, and they are dying faster than we think. Each minute about 2 million neurons die, in an hour about 120 million neurons, and the brain ages really, really fast. Each hour battles between different these collaterals sustained for more than 24 hours. These collaterals are the ones which are sustaining the brain, and the tissue is at a penumbral zone. This is what our target is. We are trying to reverse the blood supply to the brain before this penumbra dies down. And that's what we are exactly looking at. For example, when we do an angio, when middle cerebral artery here is occluded, if there is a good collateral circulation like this, and the patient has a neurologic deficit, we know that this patient is going to really, really do well. This is the concept behind stroke treatment. Let me look at the penumbra. You look at this, the penumbral pattern. For first 6 hours, the penumbra is pretty good for most of us. Not everybody, but for most of us. But as time passes by, up to 24 hours, the penumbra gradually goes down. We will not be able to help the patients who are here, but we will be able to help these patients. How do we identify this? We identify by advanced imaging. See, for a patient who comes within the first 6 hours, we do the basic imaging, like a CT angiogram or like a regular CT. We see no obvious infarct, we go ahead and try to revascularize those patients. For a patient who comes in this period, we do more advanced imaging, that is perfusion, either a CT perfusion or MR perfusion imaging, to pick up the the patient who has the penumbra who will be able to sustain and survive the stroke are the patients whom we are trying to help. So a patient comes within the first 6 hours. We do either a CT or a CT angiogram. The CT predominantly rules out a hemorrhagic infarct from a ischemic stroke. You will not see any change at all in the CT scan in the first 6 hours. Whereas if you do a CT angio, you will be able to pick up the vessel occlusion. In CT, what we commonly see is this hyperdense MCA sign may be visualized. You may have an established infarct in few selected patients. You may have the subtle changes, like you can see there is some hypodensity here. Predominantly what we are trying to look at is the gray matter and white matter differentiation that we see in the CT scan that will be lost. That is the earliest sign in the CT scan before an hypodensity develops. So we need to look for this gray-white differentiation, which is more important. And based on this, there is a score which has been established that's called the aspect score. Aspect score of 10 is good, which means there is no obvious infarcts. As aspect score comes down, which means more and more tissue are involved. We've been treating only good aspect score, but today we have moved on to treat even lower aspect score. CT angiogram tells you exactly where the block is, and it also gives you a lot more information about the carotid, about the aortic arch. It gives you a lot of information for you to plan the treatment as well. But for a patient who comes beyond 6 hours, we do more advanced imaging, either a CT perfusion or an MRI perfusion. These perfusion imagings are extremely useful because they calculate a lot of factors like the cerebral blood flow, blood volume, mean transit time. The most important is that time to Tmax is extremely important. When Tmax is longer, which means there is a significant slow flow in that region and we need to intervene. And MR perfusion, this actually we have made a protocol which only takes about 20 minutes. We have a concept that if MRI is going to take 1 to 2 hours, no. With the stroke protocol, if you are doing the essential sequence, it only takes about say 18 to 19 minutes to do the entire sequence, and we get a lot of information like the ADC map, mean transit time, flare, gradient echo, perfusion imaging, as well as the bowl sequence. So with this, we make a decision on patients who will benefit with endovascular treatment. We also have this rapid AI, which is an automated software, AI based, artificial intelligence based. It's automatic identification in a plain CT scan. It identifies the aspect score. It also identifies a large vessel occlusion. It gives a beep on the phone. We have an app. It gives a beep on the phone stating that there is an LVO, you need to intervene. The entire team is alerted and everybody gets on toes. And then it treats the perfusion scan in a much shorter time. For us to understand the perfusion scan, for example, a CT perfusion is done, it has to be reformatted, it has to be read by the radiologist. It takes about 20 to 25 minutes, whereas this software does it in less than 5 minutes. So immediately it is recognizable, and it gives us a very clear, detailed information for us to categorically talk to the patient. It gives us the volume. It gives us the volume of tissue that has been dead and gone. It gives us the volume of tissue that is in penumbra. So we are able to talk to the family in a more categoric manner, telling them that this patient will benefit with mechanical thrombectomy. So there is a lot of advantage with this rapid artificial intelligence system. And where do we stand now with regards to revascularization? I will just take you through. The patient comes within the first 4.5 hours. What do? We can give thrombolysis. There is also multiple papers on doing thrombolysis beyond 4.5 hours, but they have not come into clinical practice as a standard of care. We also do mechanical thrombectomy for every patient that comes with a large vessel occlusion within the first 6 hours. For patients who are coming beyond 6 hours, up to 24 hours, for selected patients based on the CT perfusion or MR perfusion, we offer mechanical thrombectomy. So today, what this has changed is that we have just moved on from blind time window, saying 6 hours, 8 hours, to more of a tissue window, selecting patients who will benefit with mechanical thrombectomy and offering treatment for them. So how this evolution has happened? IV thrombolysis in 1994 to intra-arterial thrombolysis in 1999. We have moved on to mechanical thrombectomy, which became the standard of care in 2008. But then we have extended the window to 24 hours based on the imaging perfusion scan. We have also moved on to do thrombectomy for even smaller vessels, like more distal vessels like M2, M3, like ACA, distal ACA, PCA vessels as well. And today, there are a lot of studies across the globe which has become positive for large vessel occlusions with established stroke, like in myocardial infarction. Even for strokes, even if the stroke is established, say 10-20% of the brain tissue is still remaining, we can still reperfuse because the outcome at 3 months for these patients are much, much better than the patients who have not been offered a mechanical thrombectomy. So we have moved on. We have come a full circle with regards to this treatment. Luckily, I have lived through this evolution and we have been intravascular access to the brain is predominantly femoral, though we do few cases through radial, but femoral access is much easier and quicker because the brain vessels are at the top, so easy to go from the bottom up rather than going from the radial. And the most common mechanism we use is a stent retriever. This stent retriever is a small stent stuck to the stick. You can't deploy it completely, but you can deploy and pull it out. This is how it works. I'll show you a short video how it works. Here is a clot, a wire is passed, microcatheter is passed across, the stent retriever is deployed. This stent retriever is made of nitinol, which with the body temperature opens up and expands to its predetermined shape. As it expands, it grabs the clot within the stent. And then we arrest the flow in the vessel so that there is no forward push on the clot. We are able to pull it back, and then we pull the clot out. This is how it works. Retriever mechanical thrombectomy. I'll just show you an example. This is a 74-year-old male with hypertension, dyslipidemia, MI 8 years ago. On Plavix, found down at about 8:30 a.m. Came to the ER with an NIH stroke scale of 18. Initial CT was done, IV thrombolysis was done. Patient did not improve. Patient was taken to the cath lab. Initial angiogram done. You can see the MCA territory hypoperfused. The stent retriever was placed. You can see the stent retriever today are quite visible, and we are able to see it clearly. This is after thrombectomy. Patient made a dramatic recovery. Though there was a small established stroke in this patient, patient made a good clinical recovery. The other technique we use is a direct aspiration. This is a technique where we put the catheter directly at the clot. We put it at the clot, and then we do a direct aspiration suction. This is a phenomenal improvement because this has made the procedure very, very simple. These catheters are very soft, subtle catheters which can be put across even in a tortuous vessel like this. You can see in this vessel there is a tortuosity, and then you need to climb all the way up to get to the MCA. Even in these vessels you can climb quite easily, and today this procedure or this direct aspiration has made mechanical thrombectomy much, much faster and quicker and more efficient. We also combine the two, the direct aspiration with the stent retriever. That's called the Solumbra technique, where we put the stent retriever on the clot, we have the direct aspiration right behind it, and together we pull it out. In that way, the recanalization or the first pass, one time you pass and do the recanalization, is much, much more efficient. With intubated, we did a CT angiogram. This is the initial CT scan. The CT angiogram showed a basilar artery occlusion. Because this posterior circulation doesn't present with the classic symptoms. They may present with some disorientation, lethargy, and all of a sudden they will just go down in no time. In these patients, we need to act quickly. So this is the clot before recanalization. This is after recanalization. Just to show you how these catheter climbs quicker, I just want to show this video. Here is the catheter. You can see we are just pushing the catheter. This is called the snake technique, wherein we are able to get the catheter up in a quick time. The catheter is going up, placed at the clot level, and we are able to do a direct aspiration. With this, we can do a very fast recanalization, and the fast recanalization I have done is like in 13 minutes. From the time of puncture to recanalization is 13 minutes. There are people across the globe who have done it in less than 10 minutes. So this particular patient with the basilar stroke got extubated the next day and then discharged a week later, and 1 month later he comes to the clinic without any deficit. So this is the change we can make in these patients. Without such treatment, this patient would not have survived. So what exactly this has done is faster recanalization. Today we have moved on from these recanalization to recanalize more distal vessels. These were the vessels we were recanalizing before, and today we are able to recanalize more and more distal vessels as well. For example, in the left hemisphere there is an M3 occlusion. Patient may be left with comprehensive deficit for the rest of the life, which is significantly disabling. A PCA stroke patient will be left with hemianopia, where he cannot drive, he cannot read properly. He'll be left with such significant deficit. So avoid them with such deficit. We are able to do recanalization for more distal vessels as well. What has happened from the industry side is we have longer microcatheter to reach this, especially design microcatheters, low profile, which are easy to access these distal vessels, low profile aspiration catheters, very small stent retrievers, as small as 2.5 to 3 millimeter. We are able to deploy distally and selectively do the thrombectomy. These distal aspirations are very tricky and difficult, but with experience, people who have done more than 100 thrombectomies should be able to do safely these kind of thrombectomies. So I'll just show you an example. This, you can see the occlusion, very, very distal. And on the left hemisphere, so here we went ahead with the thrombectomy. Here is a stent retriever. Here is a clot that is retrieved. And this is a vessel that is recanalized. So likewise, aspiration as well, very small microcatheters, you can aspirate from the distal locations as well. And then moving on, patients, we usually analyze these stroke patients with NIS stroke scale. Like we do the Glasgow Coma scale for a patient with a trauma, for stroke we do with the NIS stroke scale. There is a dilemma, a patient with a low NIS stroke scale with a large vessel occlusion, the collaterals are quite robust. They are the patients who are very, very, very difficult to make a decision on thrombectomy. Where do we stand today in these patients? We assess them very, very carefully. This is a polyphasic CT angiogram. You can see the collaterals are quite robust. If they are quite robust, then we are happy. We will like to sit and wait. This patient kind of moderate in the late phase. In this particular patient, you can see the collaterals are not so great. We know that these patients are going to go down. These are the patients whom we will offer thrombectomy, even if their NI stroke scale is low. As well as the perfusion scan, either the CT perfusion or MR perfusion will help us to make a decision in these patients. And we make decisions based on what we see in the CT and MR perfusion, which is a more accurate way to analyze these patients. I'll just show you a couple of examples. This is a 73-year-old man who presented with a stroke initially. He was clinically stable. We waited and watched. Patient came to us. He was stable. We waited and watched. But through the night, he deteriorated again. A follow-up MRI showed a significant stroke. So we took him up for thrombectomy. This is a M1 occlusion. His collaterals were kind of okay collaterals. You can see here, not so great. So we went ahead with the thrombectomy. So here is a stent retriever. We did a thrombectomy to remove the clot and reperfuse the MCA, and the patient made a good recovery. So these are very, very dicey patients where you have to be very careful in making decisions. That's why a system of care where you have junior level doctors, mid-level doctors and senior level doctors who are involved in stroke care should be available to take care of such patients and making decisions and quickly reacting to them. And this is extremely time sensitive and we need to act immediately. So this is another patient who had a large vessel occlusion, but the collaterals is quite robust. In such patients, we did not offer thrombectomy here, and this patient did well. So you can make a selection based on what you see with the collateral circulation. As far as the low NIH stroke scale, that is, a patient in a good clinical condition is concerned, there is no concrete evidence to do thrombectomy in every patient, but we need to make judicious decisions in making an effort to watch them carefully, and if they deteriorate, we need to do a thrombectomy. One last thing I want to cover before I finish is that mechanical thrombectomy in a large core. Sometimes patients come with already established significant amount of stroke. Large core is more than 1/3 territory of the MCA, which is already involved. When we take an aspect score, as I told you, lower the aspect score is bad. For patients between 3 to 5 aspect score are considered already established strokes. In those patients, we do offer thrombectomy because there are multiple trials which has become positive in offering thrombectomy for these patients with an aspect score of 3 to 5. So this is a 44-year-old male with a hypothyroidism, came to the hospital with already kind of an established stroke. A young guy, 44-year-old, breadwinner for the family, and this was the stroke that was already established in the MRI. You can see that. So this particular patient, we went ahead, did a thrombectomy. He had complete legia to begin with. He was on the cath lab table in quick time. This was a clot which was sitting there with a low flow. We went ahead, did a thrombectomy. This is after the first pass, the vessel occluded, then we opened up the vessel, pulling out the clot. So this patient made a good recovery. So this is the perfusion that was achieved, and on day 3, he started lifting his arm. So such is the outcome of these patients. So large core is not a contraindication today. We can do thrombectomy for these patients, and in various trials, the number needed to treat is as low as 5. And that is a significant benefit in these patients. And patients with the low aspects, patients with the large core, also we offer thrombectomy. Sometimes in an acute situations, we do carotid stenting. This is one particular patient, you can see significant carotid stenosis. We went ahead with the carotid stenting in the acute phase. This is more like a cardiology colleagues just going in, crossing the vessel and putting a stent. Sometimes they come with a carotid occlusion and a tandem occlusion. You can see the carotid right side is occluded here, and there was an occlusion distally in the MC as well. In that situation, you need to do an angioplasty, get through the vessel, and then do a thrombectomy more distally, and then when you do the thrombectomy, then as you come back, if the vessel stays open, fine, or we need to do a stenting on the way out. So that's what we do for tandem occlusions. In patients, in Indian patients, we have a lot of intracranial atherosclerotic disease. That is a primary disease in the MCA or the distal ICA itself that is causing the occlusion. In such patients, we make our decisions differently. Though in these patients, medical management is a preferred management when they present in a non-acute situation, but when they present with acute situation, we have certain options like doing just angioplasty or do a self-expanding balloon or a balloon-mounted stent or cardiac stent we use. A semi-compliant balloons we use, or we use a self-expanding stent like the Credo stent or the Wingspan stent or the Enterprise stent, or a balloon-mounted stent like the Onyx Frontier or a bare metal stent is what we use. Whenever we do a thrombectomy, the vessel stays open for some time and then closes again. We know that the primary disease is in the MCA. In such situations, what we do is we try to infuse GP2B3A inhibitor initially. Then, if it doesn't stay open, we try just balloon angioplasty. If it doesn't stay open still, then we do the intracranial stenting. This is a patient with a basilar occlusion who had an basilar severe stenosis. This is after thrombectomy. You can see that severe stenosis. We waited for about 20 minutes, the vessel shut down again. In that situation, what do? We try the GP2B3A, we try the balloon angioplasty. If nothing works, we go ahead and do a rescue stenting. This is what we call it as a rescue stenting. And there are situations when patients with multiple TIAs, if they are going down, there is no access. We as a neurosurgeon also offer ECIC bypass in a very selected patients. This is again a salvage, very useful procedure in selected patients. So in conclusion, acute stroke, the landscape of treatment has been constantly changing, and today we have evolved a lot in the last 2 decades. We go all the way out to offer the treatment. We have moved on from time window to tissue window. Today, one need to remember that up to 24 hours we can offer thrombectomy. Time is not the criteria today. Imaging plays a pivotal role. Imaging, predominantly the CT perfusion and MR perfusion, plays a pivotal role in selecting these patients for thrombectomy. The new dimensions have been doing thrombectomy for even small vessels and large core established infarct as well. And in selected patients, we do rescue stenting and intracranial stenting as a salvage measure. Thank you. Thank you all for your time listening.
Thank you very much, sir, for a great presentation. Really, the very innovative technologies. Very amazing to see the small vessel thrombectomy. We never heard of small vessel thrombectomy. We had a large vessel thrombectomy. And using the artificial intelligence, your rapid sequencing, and we have moved from the time window to the tissue window by analyzing the images by the artificial intelligence. And a lot of innovations have been taken place very nicely, and your patients are improved immediately. Very nice to see. Thank you very much for a great presentation, sir. And one query is that when we thrombolize, why don't you restrict the time to 4.5? If you thrombolize after 4.5 hours, the reperfusion edema will be more. So dangerous will be more. That's why we restrict our time to 4.5 hours. But if you do thrombectomy, especially a large vessel thrombectomy, if you remove it, the same principle applies there. So if you do after 6 hours of the insult, that is stroke, if you do large vessel thrombectomy, probably the reperfusion edema will be more. So how many of you are seeing that persons are deteriorated after thrombectomy, and how many people have improved after thrombectomy? Just like to know, because when I suggest for them for interventions, we should know, we have to advise the patient.
Absolutely, that is the most valid question. See, all these trials were done before all the perfusion imagings were available. Even when I started doing thrombectomy, I was practicing in the US. We used to do thrombectomy just based on regular plain CT scan. We did not have CT angiogram or CT perfusion scan at that time, even in advanced centers. It was not a routine standard of care. In those times, they had only time window, and based on these criteria were laid down. Today, we have moved on to tissue window. That is, we do perfusion scan, and based on the perfusion scan, if the tissue is preserved, which means there is no blood-brain barrier breakage. When there is no blood-brain barrier breakage, then the chances of reperfusion injury is extremely low. In patients with an established infarct where the blood-brain barrier is broken and the tissue edema is already established, you reperfuse into those vessels, the brain starts swelling. And that is when the reperfusion injury happens. In our sequence, our experience of reperfusion injury with mechanical thrombectomy is in the range of about 10 to 15%, which is kind of acceptable in any standards, and across the globe it's been documented to be somewhere between 10 to 20% in properly selected patients, especially coming beyond 6 hours up to 24 hours. That is where the perfusion plays a key role in properly selecting the patients. If you are randomly doing in those patients, then your reperfusion injury will be significantly higher, your decompression numbers will be significantly higher.
Oh, great. Thank you very much, sir.
Thank you, sir.
Thank you, sir, for this excellent presentation, sir. Particularly, you told 1 hour after the stroke, that is a 3.6 hours, around 3.6 year brain damages. So you have explained excellently about both the without the balloon and with the balloon. What are all the indications for all those things? Thank you, sir.
Thank you, sir.
Now floor is open for discussion.
If the patient is having stroke before and when he comes back as a wake-up stroke protocol. Thank you, sir. Sir, we had a case where the patient had before stroke also, and again he presented with stroke and he came up with wake-up stroke. We don't know the time delay. So in that cases, how can we know about the tissue preservance, sir? Because if we went for MRI perfusion scan also, but the problem is he had before stroke also. In that case, how to proceed, sir? We had a doubt.
Yeah, that is a very valid question. See, when the time window was the criteria, we always took the time as a last seen normal time as a time of onset of stroke. For example, patient seen normal at about 8:30 in the night. He went to bed, he wakes up with a stroke. We took 8:30 as a time of onset. Today, we do perfusion scans in these patients. When we do perfusion scans, we can clearly differentiate with the various parameters I just told you, the cerebral blood volume, the cerebral blood flow, the time to peak. This will clearly differentiate an already established infarct dead tissue from a recently infarcted tissue, as well as the tissue with the low flow. With these parameters, we will be clearly able to differentiate the tissue at risk which can be salvaged. So that's why the perfusion scan is really helpful. Multimodality MRI imaging as well can clearly differentiate an old established infarct from a recent infarct, because the appearance in diffusion weighted and ADC maps will be significantly different in a recent stroke compared to the old established
Yes,
stroke.
sir.
So that way we can differentiate and offer treatment.
Thank you so much, sir.
You're welcome.
Thank you very much, sir, for wonderful discussion. And we'll move on to the
Sure, sir.
I am
next session.
practicing very near to a medical college of Tamram. A few days ago, I had a stroke. The patient was seen by a local practitioner at home. It was more than 6 hours. By the time I came, I saw the patient. The dense stroke has already set in. When I accompanied the patient to medical hospital, the transportation took a lot of time. The neurosurgeon who examined the patient, retrieval is very difficult. Thrombol is also very difficult. The recovery is also difficult. A lot of neurons would have been lost in the process.
Correct.
In this procedure, do you think thrombolysis will help, or retrieval of thrombus is helpful? Which is the most convenient method by which the patient can be, the reversal process can be attempted? Can you please
As far as the scientific evidence goes, beyond 6 hours we don't offer thrombolysis, because there is not enough evidence to prove it, to back us up if a reperfusion happens and the patient goes to a court of law. Unfortunately, we don't have enough evidence to back us up beyond 6 hours. In that case, a patient should have been done a perfusion imaging, and a thrombectomy could have been offered for that patient. Yes, sir. Clinical hemiplegia does not mean it is irreversible. We have to look at the tissue that is salvageable, because even in the penumbral zone, the neurons will not work and they will have hemiplegia, but that does not mean they will not recover. Once we reperfuse, there is a chance that those patients can recover. Thank you, sir.
Thank you very much, sir. We'll move on to, now we request Dr. A. Natarajan, sir, to hand over. Moment, sir. Okay, sir. Since we are running short of time, we'll go for the next. From the neurology, we'll go to the cardiology. We have the most popular, eminent cardiologist, interventional cardiologist, a senior consultant cardiologist, and interventional cardiologist, Professor M. Chennappan, sir. everyone knows across the country, so popular and so elegant lecture, especially specialized in the ECG, and he never let any point in ECG. Such a great person. He is going to talk on the precious 10 seconds in diabetes. So with the 10 seconds, we find out everything what's happening in the ECG. So we welcome our professor and to deliver lecture on precious 10 seconds in diabetes.
Good morning, and I thank Dr. Parandaman, Dana Mitran, and Dr. Narajan and Jai Krishnan for this wonderful opportunity. So, first of all, one correction, sir. I'm not an interventional cardiologist. I continue to remain as non-interventional cardiologist throughout my lifetime. So that's why I'm not considered as cardiologist today. And second thing is, we are having every day, every week, diabetic conference. I'm surprised to find no topic on diabetes in this conference. So I used to talk non-diabetic topic on diabetic conferences and diabetic topic on non-diabetic conferences. So that's why I selected this topic of 10 seconds. So many of you may be wondering what this 10 seconds mean. When you record an ECG on a standard ECG machine, and also you have in the A4 size paper, you have 50 big squares there. And that 50 big squares translate into 10 seconds. So in the electrocardiogram, what you see is 10 seconds of patient's electrical activity. With that, you make so much of diagnosis, so much of decisions regarding interventions. So that's what I'm going to talk about, the 10 seconds. That 10 seconds means an electrocardiogram and the electrical activity of the heart in 10 seconds. So whenever we talk about a heart disease, we think of three things. One is the pipe, that is your arteries. Second is the current, that is electricity. And third is the pump. Ultimately, the pipe and current problems can affect the pump, or the pump can be independently can be affected. But when you look at the diabetes, it can affect all the three issues of the heart. So what you are going to see is whether the ECG is going to give the information about all these three systems, namely the pipes, the current, and the pump, and how to detect these changes at the earliest, so that we do the interventions at the earliest time frame, so that we'll halt heart disease in diabetes. So the core of the talk is to how to halt the heart disease by this 10 seconds of ECG. So first we look at the pipe problems. The pipe problems is the coronary artery problem. So don't be late like this. Don't ever, a diabetic patient of yours come with this huge ST elevation of ST elevation MI, or also don't be like this, allowing the patient to go for a silent myocardial infarction. That means you have to detect the pipelines at the earliest and do the interventions. Many of your patients may be asymptomatic, or they may be coming with all type of atypical presentation. That's why we miss the pipe problems in diabetes mellitus. So they come with breathlessness, they can come with a cardiac arrhythmia, they can be a diaphoresis, emotional disturbances. The fatigability is a very important presentation of acute coronary syndrome. A sudden extreme fatigability for the last 2 days. We used to think it is hypoglycemia. I keep on looking at sugars, but do ECG. The gastric complaints, hiccups, and also the during surgery and anesthesia. So we are going to see a lot of ECGs here, and we can see that any pointers there. So you can see that here this patient comes with a completely asymptomatic patient. You do an ECG, and the patient has got what is known as a non-progression of R wave. So what is the definition of non-progression of R wave is whenever your R wave in V3 is less than 3 millimeter. That is the definition of the non-progression of R wave in, so the slides are non-progressing. So that is a non-progression of an R wave. So many of us think the non-progression of the R wave is likely to be anteroseptal myocardial infarction. But please remember, there are a lot of conditions which can actually, this will not work. So many times it can be due to just abnormal positioning of your chest electrodes, and also it is due to the COPD, skeletal abnormalities. So many of these things can produce a non-progression of R wave. So that's why it is very, very important to correlate your symptoms with this, and of course you can detect an old septal MI. So many times these patients can, I have the pant. The problem is the patient is coming with a T-wave inversion. Many of your patients will come with a T-wave inversion. So what is a significant T-wave inversion? A significant T-wave inversion should be having a depth of 3 millimeter or more. So minor T-wave inversions, many patients, especially ladies, may have a minor T-wave inversions. So whenever the patient has got the T-wave inversion, always compare with the old ECG. So whenever you compare the old ECG, if the T-wave inversions are fresh and it is more than 3 millimeter, you have to give a lot of importance. And especially when the patient has got a chest pain yesterday and he comes a deep T-wave inversion, it can be a Valence syndrome of proximal iliac disease. And of course, when the patient comes to the dyspnea, he will mimic an Valence syndrome, but he will also have a T-wave inversion in L3. And always compare with the ECG. Anything new, give importance, and always investigate for coronary heart disease. So this patient is completely asymptomatic. You take an ECG, you think this ECG is normal. But unless you concentrate on V5 and V6, you see that horizontality of the ST segment. ST segment is a gentle fellow. He will go up gently upwards with a gentle concavity. Whenever the ST hugs the baseline more than 3 small square, that is the earliest sign of coronary heart disease. When the patient comes to the multiple risk factors, it may indicate a coronary heart disease, or when the patient comes to acute chest pain, this horizontality will tell you the patient will subsequently go for ST segment depression or a non-ST elevation ACS. So yesterday you would have said this ECG is normal, but you can find this horizontal ST segment is the earliest sign of coronary heart disease. But what is the earliest sign of an ST elevation? This patient comes with acute chest pain. There is some ST segment depression in V2 and V3 and V4. So you think there's a mild subendocardial injury and so on, unless you concentrate on L2, L3 AVF. You can see that the concavity is lost. Whenever the concavity is lost and the ST is convexity upwards, that is the earliest sign of ST elevation. The earliest sign of ST segment depression is horizontality. Convexity upwards is the earliest sign of ST elevation. So this is an acute inferior myocardial infarction and a reciprocal depression on V2, V3, V4. And this patient immediately requires a PCI or a thrombolysis. Unless you think this is a small acute coronary syndrome of non-ST elevation ACS, give heparins and antiplatelets, and the patient would have had a huge myocardial infarction. So how to detect the earliest sign of a ST segment depression and ST segment elevation? Whenever your ST is, usually you can see that it's a gentle concavity upwards. Whenever this concavity is the problem, it becomes horizontal in the earliest sign of ST segment depression, and it becomes convexity upwards, which is called slope elevation. That is the earliest sign of ST segment elevation. And of course, you can see this patient has got, the adult patient who has got the 59 years old. What is the problem here? He has got a sinus arrhythmia, a very simple sinus arrhythmia. Sometimes the heart rate is faster, sometimes his heart rate is slower. And if you relate to respiration, it's a non-respiratory sinus arrhythmia, which means this slowing and quickening is not related to respiration. So whenever an adult patient has got a non-respiratory sinus arrhythmia, you have to suspect an RCA disease, because RCA supplies the SA node in 60% of patients, and LCX disease in 40% supplies the SA node. An adult sinus arrhythmia, always think of an RCA disease because of the ischemia. The sinus node is spontaneously firing quickly and also slowly. So a very simple, subtle problem of non-respiratory sinus arrhythmia. Then you have a premature beats. Here you think it's a ventricular premature beat, and the basic sinus beats are not showing any ECG changes. But what is the peculiarity of this particular ventricular premature beat? What you expect in a ventricular premature beat is the upright QRS and downsloping ST, and the T wave is opposite. Whereas here you can find the ST is horizontal and the T wave is in the same direction of the QRS. So this is called the homophasic STT changes in the ventricular premature beat. Although your sinus beats are not showing ischemia there, the homophasic STT change of a ventricular premature beat tells you you have an ischemia in that region. Before the sinus beats develop ischemia, if you intervene at this point in time, you will have a great benefit. So sometimes if you find a ventricular premature beat which has got a predominantly upright QRS has got a Q wave. A predominantly upright VPD is not supposed to have a Q wave. If any Q wave in front of an upright VPD, it indicates infarct at that site. Although your sinus beats are not showing infarct there, this ventricular premature beat preceding a Q wave tells you there is a scar there. So here we can utilize the ventricular premature beat to detect the earliest problem of diabetes mellitus. So look at the normal classical VPD, downsloping ST T wave inversion, which is a secondary STT change. If you look at this VPD with a horizontal ST, with upright T wave, with a homophasic T wave, that is the earliest sign of ischemia, even though your sinus beats are not showing. If you have a predominantly upright QRS preceded by even a non-pathological Q wave, it may indicate a scar in that region. So here the VPD is exposing the ischemia in that region or infarct in that region, although your sinus beats are normal. So VPDs are not necessarily a nuisance. So VPDs can give you valuable pointer of information. So valuable, that's why I call the VPDs as valuable pointer of diseases, the VPD. Then of course, when you have a VPD, don't be concentrating on the Q, not only concentrating on the IC segment, concentrate on the post-extrasystolic sinus beat. So I find this post-extrasystolic sinus beat has got a T wave inversion when compared to the T wave which is upright in the next sinus beat. So this is called the post-extrasystolic T wave inversion, very subtle sign of coronary heart disease, and this is called the poor man's exercise test by Levin, when test tests are not available. So this is called the post-extrasystolic T wave inversion. Once again, this patient does not require a stress test because he has already exposed, he has got a coronary heart disease by producing a VPD and showing a post-extrasystolic T wave inversion. And of course, when the patient has got a left bundle branch block, concentrate on the QRS and the AC segment. It's a classical left bundle branch block where once again you have a secondary STT change. Your J point is depressed, downsloping ST, and the T wave is opposite to the QRS. But in the presence of a left bundle branch block, if the patient has got a Q wave, you should have never a Q wave in a left bundle branch block. You should not have the initial Q wave because the septal depolarization in left bundle branch block is from left to right. So that's why you will never have a septal Q in a classical left bundle branch block. Whereas look at this patient, in the presence of a left bundle branch block, he's got a Q once again. Even though this Q is non-pathological, any Q in front of a left bundle branch block, QRS in V5, V6 indicates infarct, especially anteroseptal myocardial infarction there. Once again, these are the subtle signs we miss and allow the patient to go for a massive myocardial infarction. So in addition to that, you also concentrate on the ST segment, the T wave. So although you don't have a Q, if your ST segment, the T wave, are in the same direction as the QRS, this is once again called the homophasic STT change in left bundle branch block. You can see it's a left bundle branch block, but your ST is horizontal and the T wave is in the same direction as the QRS. Once again, a homophasic ST change in the L bundle branch tells you there is a coronary heart disease. So this is once again a subtle sign of coronary heart disease in the presence of the left bundle branch block. So concentrate on the Q wave in front and concentrate on the ST segment and the T wave at the back. And of course, what happens in a right bundle branch block? So this is a classical right bundle branch block. What you have to concentrate on right bundle branch block as far as the pipe is concerned is the initial Q wave, initial R wave. Usually, in a right bundle branch block, the initial R wave is very sharp and very small, very sharp and small. But when the patient has got a post-wall infarction, the post-wall infarction, you are supposed to have a tall R wave in V1. Right bundle branch also will have a tall R wave in V1. How to diagnose when both are coexisting? You have to concentrate on that initial R wave. If that initial R wave is broad and tall, it indicates an associated post-wall infarction, although you don't have an inferior wall infarction here. So the initial R wave becoming tall, you can compare that the previous ECG here. So you can see that initial R wave which is so sharp and small. And that initial R wave becoming tall and broad is an indicator of an associated post-wall MI here. And you have the T wave. Once again, in a left bundle, classical right bundle branch block, you don't have the upright T wave along with the QRS. You'll have a secondary STT change here once again. So just like I told you in left bund branch block, you see the T wave is in the same direction as the right bund branch block. So what happens is that whenever you have a classical right bund branch block, the initial R wave is small and sharp. When you have an isolated post-wall infarction, there is a tall R wave in V1 without QRS widening. But when you have a QRS widening and the initial R wave is tall and broad, you are supposed to suspect an associated post-wall infarction in the presence of a right bund branch block. Then, of course, when you have this patient has got a chest discomfort, superficially the ECG is absolutely normal. So there is no ST problem, there is no ST elevation and so on. So now we are going beyond the QRS, going beyond the ST segment, going beyond the T wave, that is a U wave. So what you have is an inverted U wave here. So the inverted U wave is the earliest sign of coronary heart disease, and when the patient comes with acute chest pain, beyond T wave, you have to look at the U wave. The U wave inversion is a very important sign of unstable angina. So a patient may not have a classical ST segment depression or elevation. They may have just an inverted U wave, which may tell you this patient is developing an unstable angina or a future acute coronary syndrome. So don't be looking at T wave alone. Don't end your ECG interpretation with the T wave alone. Go beyond the T wave also to see this very important sign of U wave inversion. So these are the very subtle signs of a pipe problem where you are supposed to miss your pipe problems in diabetes mellitus. So whenever you have a pipe problem, what we are going to do? You have to control all the risk factors meticulously, not diabetes alone. And antiplatelet drugs should be there, especially in acute coronary syndrome or post-PCI, dual antiplatelet drugs. Patients should have a high dose statin, and the LDL goal should be 55 to 70 in these patients who got the acute beta blockers, preferably carvedilol, the AC inhibitors, preferably ramipril, and the DM treatment, the most important goal is to prevent hypoglycemia. So that will definitely tilt the balance in a patient with coronary heart disease. Now we have very good drugs, not only treat diabetes, but also protect heart and kidney in the form of empagliflozin, GLP-1 receptor analogs, and of course they have a CV benefit. So definitely if you are able to identify these subtle signs in the ECG, you will halt the pipe problems in diabetes mellitus. So I'm going to show you some of the ECGs which are very dangerous pipe problems where you have to send these patients immediately to coronary angiogram. No thrombolysis, no heparin, no antiplatelets. So these are the killers, dangerous pipe ECGs. Of course, this patient comes with acute chest pain. You think there is a small elevation L2, L3 AVF. You think the small ST elevation MI, and you tend to take things up easily. But what is very important is you see that ST is elevated in V1 and the ST is elevated in AVR and the ST is depressed in V5, V6. Here, the ST vector is going up and right, indicating a very proximal LAD lesion, very critical proximal LAD lesion before the septal 1, diagonal 1. Huge myocardium is at risk. Your entire conduction system is at risk. So this is a proximal LAD. Although you don't have a 10 millimeter elevation, 2 to 3 millimeter elevation, V1 elevation, AVR elevation, AC segment depression dropped, you know it's a proximal LAD. This patient should go for a coronary angiogram immediately. And this sign is well known. Many of you would have very, very famous ECG sign. Whenever you have a patient with AC segment depression and the anterior leads, always look at the lead you hardly see. What is the lead you hardly see? Because we interpret electrocardiogram as a 11 lead electrocardiogram and not 12 lead electrocardiogram. And what you have to see is lead AVR. So the lead AVR showing ST segment elevation. So this patient came with chest pain. With a sublingual nitrate, the chest pain disappeared. The patient's ECG became normal. The patient wants to go home. But we said this patient goes to cath lab immediately. So when we did the cath immediately, the patient had a critical LMCA lesion, and the patient was revascularized within 3 to 4 hours of this particular electrocardiogram. Otherwise, if that critical lesion goes for a total lesion, the patient will have straight away go for a cardiogenic shock and die. So very subtle sign, but the very important interventional advice. This patient had chest pain yesterday. Today, completely all right. He came for a routine evaluation for a chest pain he had done yesterday. But the ECG showed a deep symmetrical T-wave inversion in V2, V3, V4, which is called Valence sign. Once again, a proximal LAD lesion. This patient also should go for a cath lab immediately because this is an aborted STEMI. The patient had a total occlusion yesterday. Spontaneous thrombolysis has opened some 10% or so, which has produced a reperfusion pattern here. And the patient may not have chest pain now. But the ECG chain tells you this is an aborted STEMI, critical LAD, the patient should go for a cath lab immediately. So this is a valence sign, and this is a STEMI equivalent. The patient is coming with a chest pain, upsloping ST segment, very tall symmetrical T wave. Upsloping ST with a tall symmetrical T wave is called De Winter's sign. Very, very dangerous sign where a very serious blockage in your LAD, it can produce a total death and permanent death of a significant chunk of myocardium. If you don't thrombolyze here, don't give heparin here, so do an immediate coronary angiogram and open an LAD here, because I can see the good R wave tells you still the myocardium is viable. So you open the artery at this point in time, you keep the myocardium viable throughout the patient's life. So once again, the patient comes with 2 to 3 days of chest pain, an intermittent chest pain, and you do an electrocardiogram. There is a mild SC segment depression, V2, V3, and there is nothing else. So you think it's a sort of a non-ST elevation ACS. Your thing is you do your troponin, you do your heparin, and so on. But once again, this patient should be sent for cath lab immediately, especially when there is an ST depression V1 to V3. Always look at the inferior leads. You can see although your inferior leads looks normal, but see that loss of concavity there. Now you can pick up the sign. So the loss of concavity is there. What is happening is an inferior wall infarction with a reciprocal depression of posterior wall in V2, V3. Many of these patients, your attention will be taken by V1 to V3 ST depression and not the inferior wall infarction. Whenever this pattern happens, this is a total occlusion of LCX. This pattern is a total occlusion of LCX. When you did the coronary angiogram, you can find that is a total occlusion. What is coming out is the obtuse marginal of the total occlusion of LCX, and the patient was immediately opened, and he had no infarct at any site after the revascularization. Otherwise, he would have had a massive inferior wall infarction and a massive posterior wall infarction here. So this is a very critical sign of total LCX occlusion. And once again, this patient comes with a chest pain. You think the ECG is normal because there is no SC segment depression, there is no SC segment elevation, there is no upsloping SC segment depression, but the T wave is abnormal. So it is not only dangerous for a human being being fat, it is also dangerous for the T wave to be fat. So it's a fat symmetrical T wave. Most often missed sign of critical LAD occlusion. So when you find this tall symmetrical T wave inversion, T wave, upright T wave, the definition of tall T wave is T wave more than 40% of the preceding QRS. We can say the T wave is taller than your R wave. So it is a tall R wave to a tall T wave. So whenever the tall T wave is present, the normal T wave is asymmetrical. It will have a gentle concavity upwards, and the ascending limb will not be equal to descending limb, and usually the T wave is narrow. So when you have a broad T wave, that concavity is lost, and the patient has got a broad-based tall. It is not only tall, it is wide. So fat T wave is once again a sign of critical LAD occlusion. So once again, this patient should go for an aortic coronary angiogram. And the pattern is called the Aslanger pattern. The Aslanger pattern once again comes with the subtle ECG signs. So to diagnose an inferior wall infarction or an anterior wall infarction of STEMI, you need ST elevation at least in 2 consecutive leads. But in this ECG, the patient has got ST elevation only in L3, not in L2, not in AVF. So you hesitate to diagnose inferior wall infarction here. But otherwise, what you have is an ST elevation in V1 more than V2, and also anterolateral V5, V6 SC segment depression. So this is called Aslanger pattern. The Aslanger pattern is classical acute inferior wall myocardial infarction, but because of the multivessel disease, what is happening to the ST is that it is transferring to the right side and producing less changes in inferior wall, and also producing the multivessel disease of the ECG changes, overcoming the classical inferior wall ECG changes. And this Aslanger pattern also, the patient should go for a coronary angiogram immediately, because it is not only acute inferior wall infarction, but it is also a severe multivessel disease. So once again, this patient has come to, we can diagnose not only coronary heart disease by ECG, we can also diagnose peripheral vascular disease by ECG. This patient has got significant low voltage QRS in the limb leads. He does not have edema, he is not obese, the standardization is normal. So whenever you have but the definition of low voltage in limb leads is entire QRS voltage in limb leads is less than 5 millimeter. So when you have got a 5 millimeter, when you have no edema, when you have nothing else, it is an important sign to suspect your peripheral vascular occlusion or peripheral ischemia is actually, because the electrical activity is not transmitted to the peripheries because of the significant peripheral vascular disease. So this is why these are the dangerous pipelines. Then we go to the electricity, the current. So not only you look at the pipe problems, you have to also look at the current problems, which may also produce sudden cardiac death. The first important thing is a bundle branch block. The right bundle branch block will have a terminal delayed slurred positivity in V1, and left bundle branch block will have a terminal delayed slurred positivity over V5 and V6. If it has got a right bundle branch block which is recent onset, it may indicate coronary heart disease and the fibrosis of the conduction system, whereas the left bundle branch block may indicate hypertension, myocardial disease, or a coronary heart disease. So whenever you have a right bundle branch block, don't be concerned only about bundle branch block. Whenever you have a right bundle branch block, always look at the limb leads. Whenever the limb leads have got the left axis deviation and you have a small terminal R wave and a deep S wave in L2, L3 AVF, where all your inferior leads are looking similar with a left axis deviation, you have additional left anterofascicular block. Having diagnosed left anterofascicular block, don't be happy again. Look at the PR interval. The PR interval is prolonged. So when the right bundle is blocked, left anterofascicle is blocked, the only fascicle which is conducting is the left posofascicle, and that is also conducting with a delay. That means you have a partial block in the third fascicle. This is the patient who will go for a complete heart block, Stokes Sadam, and this is the way you have to prevent that by giving a pacemaker when the patient is symptomatic at this point in time. So don't be concentrated only on right bundle branch block. Look for advanced conduction disturbances. Any new right bundle branch block give importance. Coronary heart disease, myocardial disease, fibrosis. What is the importance of bundle branch block? It is a proximal first septal branch which supplies RBB. So when the patient got a fresh RBB, you have to rule out an LAD disease. And look for the subtle signs. I told you how to detect post-wall infarction in the presence of a right bundle branch block. Don't be happy by looking at the right bundle branch block. Look at the fascicular block. Look at the additional PR interval prolongation. So whenever you have a left bundle branch block, we also told you we can now pick up easily the homophasic STT sign of a left bundle branch block here. Look at the axis. Whenever a left bundle branch block has got a left axis deviation, mimicking a left anterofascicular block, it is looking like a left anterofascicular block, but the patient has got a left bundle branch block. So this is called the parietal block or the arborization block. Whenever the left bundle branch block has got a left axis deviation, it indicates a significant myocardial fibrosis, and this is a high-risk left bundle branch block. So whenever the left bundle branch block is happening in diabetes mellitus, coronary heart disease, myocardial disease, fibrosis, and hypertension, and fibrosis here is a muscular fibrosis most often, rather than a conduction system fibrosis in right bundle branch block. QRS of more than 60 milliseconds and the left atrial enlargement is the best predictors of adverse prognosis. So LBB, even the absence of LVH, it can have more systolic and diastolic dysfunction, high rate of clinical events, and new onset of left bundle branch block indicate advanced and advancing disease and difficult to diagnose CAD. We told you how to diagnose CAD in left bundle branch block. So now we come to the patient who has got a respiratory sinus arrhythmia. So you can see the quickening and slowing, but this quickening and slowing is related to the respiration. In inspiration, the heart is quickening, and expiration, the heart is slowing. Good news for the patient. If a non-respiratory sinus arrhythmia, bad news for the patient. If it is a respiratory sinus arrhythmia, good news, it indicates intact parasympathetic system. So that means he does not have a significant autonomous nervopathy. So respiratory sinus arrhythmia is a good news. Non-respiratory sinus arrhythmia is a RCA disease or an LCX disease or a sixth sinus syndrome. When the patient has got a persistent sinus tachycardia, this is a very bad sign in diabetes mellitus. Even during sleep, persistent tachycardia indicates the withdrawal of your parasympathetic system. So here what you must do is a Holter. So look at the heart rate at night in Holter, continuous increase in heart rate, and we have a parameter called heart rate variability in Holter. That tells you patient has got a high sympathetic activity, and these are the patients can go for a sudden cardiac death unless you interfere what is happening in the sympathetic activity. So as far as the atrial fibrillation is concerned, that diabetes itself is an independent risk factor for atrial fibrillation. It can produce atrial fibrillation because of many pathologies, vascular damage, atrial myopathy, autonomic dysfunction, and also the advanced glycation products. And these three things are associated with the atrial fibrillation. One is the age and diabetes duration, and also poor glycemic control, HbA1c, can produce atrial fibrillation. How will you diagnose atrial fibrillation? Three criteria. Absent A wave. There is no well-formed A wave. The RR interval is irregular, and it is replaced by fibrillary wave. And of course, whenever you diagnose atrial fibrillation, decide whether you need a rate control or rhythm control. Always look at the pipes and the pump, which can produce atrial fibrillation. To prevent stroke, the patient should be on oral anticoagulant. When you detect and manage atrial fibrillation properly, you will prevent. We frequently see ventricular premature beats. How to decide this ventricular premature beat is malignant or benign? So once again, look at the width of the premature beat. Very broad, multiple notches VPDs are very dangerous. Short, broad fellows are very dangerous. Tall, lean fellows are less dangerous. I am telling about the VPDs. So short, broad fellows are very, very dangerous, and short, tall, lean fellows, you can see this VPD is a very malignant VPD. Broad, multiple notches VPDs are very dangerous. Whenever the VPD and the sinus beat are loving closely one another, very, very closely loving each other, it is dangerous. So it is called R on T. Whenever the R wave of the VPD is falling on the T wave of the VPD, so it's once again a very dangerous VPD, which can, especially in the presence of an acute coronary syndrome, it can precipitate ventricular fibrillation. Whenever you have the run of VPDs, or what is known as the repetitive forms of VPDs in the form of couplet, or three VPDs in a consecutive form, once again a very dangerous VPD, which can precipitate ventricular tachycardia and also ventricular fibrillation. So in a given single lead, you find one VPD is like this, one VPD is like this, and another VPD is like this, which means multiple areas in your ventricle are irritable. So this VPD is called multiform VPDs, once again dangerous, because multiple sites are the irritable. So as far as the ventricular VPDs are concerned, especially in acute coronary syndrome, if you have more than 6 per minute, it may be dangerous. R on T, couplets, 3 VPDs in a run, multiform VPDs, short, broad notches. Whenever you have an acute coronary syndrome, during ST elevation or during ST segment depression, if you have a VPD dangerous, in the presence of a sinus tachycardia, which tend to suppress VPD, still the VPD is coming out, means highly irritable ventricular focus, and also with the signs of LV dysfunction. And we told you about the homophasic STT changes in VPD, and we give drugs, it is not suppressible, it can be a dangerous VPD. Then we hardly look at a QT interval in diabetes mellitus. It's a very, very important interval in QT, because QT interval can be independently affected by the age, HbA1c. Ischemic heart disease and neuropathy can affect the QT interval, and it can also produce, I told you about the HRV, impaired heart rate variability, which indicates increased sympathetic system. And the most important message is all hypoglycemia, you must do an ECG. The most important is hypoglycemia. So we become heroes by giving a shot of glucose, and the patient becomes all right, we send them home immediately. Nobody does an electrocardiogram after hypoglycemia. The hypoglycemia can produce significant increase in QT interval, and the patient can develop a dangerous arrhythmia and die at home if you don't do the ECG. Hypoglycemia can produce ACS also, it can produce. So although I don't have the parameters like this, how to diagnose from the ECG itself, it's long QT, apply the rule of half. The rule of half is whenever your QT is more than half of your RR interval, your RR interval is 4 squares here, if your QT is more than 2 squares, it is prolonged. The absolute measurement of QT is more than half a second, 500 milliseconds, it is prolonged. So the rule of half is if it is more than half of RR interval, and also the absolute measurement is more than half a second, QT is prolonged. In all hypoglycemias, do an electrocardiogram before you discharge the patient, because a long QT can produce this, very dangerous polymorphic ventricular tachycardia, and the patient may have a sudden death. So as soon as you give glucose, you are happy, patient is happy, patient becomes all right, but the important problem, we forget the heart. We always worry about the brain, but we forget the heart in hypoglycemia. Remember the heart in hypoglycemia. So electricity in heart, how to halt the heart disease. So silent electrical problems, what are they? New onset of right bundle branch block, new onset of left bundle branch block, trifascicular block, QT prolongation. So all this, and a malignant VPD, all these things, this electrical problem is going to produce a problem in that particular patient, and the best drug to be given is a carvedilol when you have a tachyarrhythmia. Last, we come to the pump problems. So how to detect, although the echocardiography is the best investigation to detect pump problem, there are certain important clues in the electrocardiogram to detect pump problem, and the important clue here is the deep P wave negativity in V1. So in all diabetic, you look at the deep P wave. The P wave negativity in V1 should not exceed 1 small square in depth and 1 small square in width. Whenever you have a deep, broad, negative component P wave, it indicates either systolic dysfunction or a diastolic dysfunction in that particular patient. So here, the deep T wave inversion tells me this patient has got the definitely elevated LA pressure and has got a left heart disease, and the low voltage QRS in this patient, especially when the patient has got dyspnea, the low voltage QRS tells me the patient has got edema. So from the ECG alone, I have decided can diagnose a biventricular failure. Systolic dysfunction there on the left side and a systemic venous congestion on the right side. So without echo, you can diagnose a biventricular failure with these signs. So whenever the patient has got a normal ejection fraction, it comes with a dyspnea, but when you have a left ventricular hypertrophy, concentrate once again that deep negative P wave force. This is a classical sign, even without echo, heart failure with a preserved ejection fraction. You think the EF is normal, dyspnea is non-cardiac. But today, the common heart failure is heart failure with the preserved ejection fraction. That is more common in diabetes mellitus. So even though your EF is normal, look at LVH and left atrial abnormality in electrocardiogram, and still you have to do an electrocardiogram and especially look for this very, very important parameter on a tissue Doppler to diagnose heart failure with the preserved ejection fraction. So we talked about the high voltage. What about the low voltage in diabetes mellitus? That low voltage is defined as less than 5 millimeter in limb leads and less than 10 millimeter in chest leads. So suspect obesity and the pericardial effusion, mixed edema, and also biventricular failure. Whenever you have obesity, always look for obstructive sleep apnea in these patients. So ECG will give a clue when to look for an obstructive sleep apnea. Whenever you have a left bundle branch block, once again look at the deep negativity. Very broad, multiple notches left bundle branch block is very, very dangerous. So this indicates once again a left axis deviation left bundle branch block. So in a left bundle branch block, what indicates the pump problem is this. Whenever you have a very wide notches left bundle branch block, whenever you have the left atrial abnormality and also left axis deviation and the presence of a Q in left bundle branch block, all these things tells you this left bundle branch block is also having a pump problem. Not only the pipe problem, not only the current problem, it has also got the pump problem in left bundle branch block. Now we have a very important sign. Here the QRS is widened, but not a classical right bundle branch block, not a classical left bundle branch block. You have multiple notches there in this particular R wave. You can see multiple R waves there, and this is called the fragmented QRS or fractured QRS. So whenever you have this type of QRS, it indicates two things. Whenever the patient has got a LV dysfunction, this is an indicator of LV dysfunction. It also indicates that it is a scar which is responsible for an LV dysfunction. These are the patients who are prone for sudden cardiac death because this sign will have very dangerous ventricular arrhythmias like ventricular tachycardia and ventricular fibrillation. So most of the time when you have a myocardial infarction after 2 to 3 months, you will expect the T wave to become normal. So first ST gets elevated, ST settles down, T wave inversion, T wave also becomes normal in the course of time. After 2 to 3 years of your infarction, when there is a persistent T wave inversion, itself an indicator of adverse remodeling due to the myocardial infarction, a very good sign of LV dysfunction here. Majority of these patients will have LV dysfunction. So look for the persistent T wave inversion after myocardial infarction. So whenever the pump problem is there, what you are going to do to halt the heart disease, always do an echocardiogram, correct the basic cause like coronary heart disease, valvular heart disease, hypertension, significant control or very good control of diabetes mellitus. We have good drugs now, ARNI, SGLT2 inhibitors, the beta blocker, preferably carvedilol. Aldose inhibitor today in heart failure preserved ejection fraction is findrinone, a best drug in the heart failure preserved ejection fraction. Empagliflozin, dapagliflozin to prevent heart failure. serial studies, and once again, when you detect pump problem and treat appropriately, you will halt heart disease in diabetes mellitus through the pump. And halting heart disease by electrocardiogram is the core of my talk. ECG should be done at the first diagnosis of diabetes mellitus and do it serially. So don't be happy with a single day ECG. When the patient has got fatigability, do an ECG. Every year you do a ECG along with all the other things. Always compare with the old ECG. That means the patient should have the record of the old ECGs. ECGs will disappear after 1 month. Let him have a photo or let him have the Xerox copy of that. Whenever atypical symptoms appear, take ECG after hypoglycemia when the patient undergoes surgery. Detect early pipe current and pump problems so that you will halt the heart disease. Look for obvious is obvious. Everybody will be looking at the obvious signs. So if you want to be better than others, you have to look for inobvious. What is inobvious? So how to look at the ECG is, in this ECG, what changes others will miss. That is the way to look at the ECG. Not like what others will diagnose. In this ECG, what changes the others will miss. So that will make you better than others. Basic ECG knowledge is very, very essential, although you may be a specialist of any type. Then the most important drugs we have today, beautiful drugs to protect the heart. But only thing is, you have to detect the disease early and get these drugs on board to prevent heart disease. So this 10-second wonder serves us as a poor man's stress test, poor man's echocardiogram, poor man's Holter, poor man's coronary angiogram, poor man's EP lab, poor man's biochemical lab, and also a poor man's test which gives you very rich information regarding the heart disease and diabetes mellitus to halt the heart disease. For this most cost-effective and precious 10 seconds, we have to pay tribute to this man, Willem Einthoven, 1902 and 1924 Nobel Prize. The most cost-effective investigation in the world, 10 seconds of patient's electrical activity will give you so much of information on the heart pipe disease, current disease, and the pump disease, where you can definitely halt the disease. And not only you become a hero in your patient's community, you will become a hero in your doctor's community. Thank you for your patient listening.
Thank you. Thank you.
Thank you, sir. Thank you. Thank you.
Thank you very much for wonderful deliberations, amazing presentation, sir. Really, we have learnt a lot. And what all we miss by subtle signs, you elaborately discussed. I think one who follow all the points in the ECG right from the diagnosis, no cardiac events can occur throughout life till maybe more than 100 years. Such a great point you have given. Really, hats off to you, sir. Wonderful presentation, professorial talk. I can't explain by words.
Thank
so
you.
much of information you have delivered to us. Thank you very much, sir.
Thank you. Thanks. Okay. Any questions? Yes, sir. Ventricular aneurysm will have a persistent ST segment elevation, not the T wave inversion. They will have a persistent ST segment elevation. Ventricular aneurysm and dyskinesia will have a persistent ST segment elevation, not this T wave inversion. So I apologize to my fellow speakers and also the faculty and also the organizers. I have to go immediately for an important personal as soon as possible. Thank you.
Thank you very much, sir.
Thank you, sir. That hypoglycemia and fatigue, very good take-home point, sir. Every hypoglycemia and fatigue, do ECG. Thank you, sir. Next topic is management of migraine in clinical practice. For this, we have eminent speaker, Dr. Prabhash. He is a director and senior consultant neurology, SIMS Hospital, Vadabalni, Chennai. He is a senior consultant, director, founder, Kriyan Clinic, Porur, Chennai. He is a founder, trustee, and CEO, Sparsham Foundation, Chennai. Was a former HOD and senior consultant of Apollo Hospital. and his field of interest is vertigo and balance specialist. Over to you, sir.
Good morning. I thank the organizers for giving this opportunity. So I'm going to talk on a common topic, migraine. So without question, this is one of the most important symptoms that a neurologist evaluate. And if you look at it, around 300 types of headaches are there. So what we are going to discuss is address the red flags, review simply diagnostic criteria, understand the clinical spectrum of migraine, differentiate migraine from other headache types, discuss acute and preventive treatment strategies, and highlight why the patient education and lifestyle management is important. This is what we are going to talk. So I'll start with the red flags. So remember SNOOP, SNOOP. That should be the word that anyone with a headache, we should be remembering this. S stands for systemic symptoms. Look for fever, weight loss, malignancy, and HIV. Look for neurological symptoms, confusion, seizure, focal signs. Sudden onset headache, very, very important, because the sudden onset means the headache has come, within 1 minute it has peaked. It's very important headache that you should be asking for. Any headache above age of 50, first and worst headache, should be very careful with. And P stands for pattern change, progressive worsening, positional change in headache, and post-trauma. And also, worsening with Valsalva maneuver is an important one, which it can be this one, divided into 3 types. Part 1, primary headache, 4 types and 57 subtypes. Part 2, secondary headaches, 8 types and 117 subtypes. And Part 3, painful cranial neuropathies and other facial pains and other headaches, 2 types, 29 subtypes. And there's a supplement which has 17 subtypes. You don't have to worry much. 90% of the headache is migraine and tension type headaches. Remaining 10% is the all other things. So, pathophysiology, just a few slides. Cortical spreading depression. This is the point now. So there's a wave of neuronal and glial depolarization that moves across the cerebral cortex, followed by a period of suppression. So this is not causing the headache actually. So it starts in the occipital cortex and moves towards the parietal and frontal lobes. It is believed that aura is due to cortical CST. And if it is, which area is involved, symptoms will be there. If occipital lobe is involved, there will be visual aura. If parietal lobe is involved, there will be sensory aura. So it doesn't cause pain. CST doesn't cause pain, but it triggers the trigeminal-vascular activation and promotes the release of CGRP, which is the villain in most of the case. Second is activation of trigeminal-vascular system, which releases CGRP, which causes vasodilatation and neuroinflammation. Also, there will be plasma protein extravasation and mast cell activation and peripheral. These are all too many things, but then the thing is CGRP. That's the clue. It also causes central sensitization, brainstem dysfunction, and serotonin levels are low in people who are having headache during migraine. So, the key molecules are these 4. CGRP, which is a potent vasodilator and causes headache, serotonin, nitric oxide, and glutamate. So how do you approach a patient with headache? We'll make it pretty simple. So detailed history and examination. No need for any scans. It's all about history and examination. If you find any red flag, yes, it's a secondary headache, needs immediate diagnostic testing. If there is no red flags, you don't need to be in a hurry. You can do the preliminary diagnosis and treat. If you find any atypical features, then you can investigate later. I'm just adding one more slide, that is patient presents with headache, you are excluded or sinister headaches. Now, the question should be, what is the impact of headache on the sufferer's daily life and activities? If it is low, it's going to be tension type headache, nothing much to worry. If it is high, it can be migraine or chronic daily headache. Question 2, how many days the patient has headache in a month? If it is less than 15, it can be migraine with aura or without aura. If it is more than 15, it can be chronic daily headache. And question 3, if there is a usage of pain medications, at least more than 2 or less than 2. If it is less than 2, don't worry about that. If it's more than 2, you have to consider medication overuse. Also in CDH, you have to consider short-acting headaches also. So these are the three questions that you should be asking. In simple, in GP, we can do that. So this slide is important. So the cause or type of most headaches can be determined by a careful history and physical examination. The clinical imperative is to recognize the warning signs that raise red flags and prompt further diagnostic testing. In the absence of worrisome features in the history or examination, the task is to then to diagnose the primary syndrome based upon clinical features. If atypical features are present or patient do not respond to conventional therapy, the diagnosis should be questioned and the possibility of a secondary headache should be considered. Migraine and tension type headache accounts for more than 90% of primary headaches. So 9 out of 10 times you will be right if you treat migraine or tension type headaches. So how will you differentiate? So migraine more than 5 attacks, tension type more than 10 attacks, and there's a difference in duration. In migraine, it should be mostly unilateral, at times bilateral. It will be pulsating. That's the most important difference. Tension type headache can be bilateral and non-pulsating. And it is a moderate to severe headache in migraine, little moderate intensity in tension type headache, and migraine aggravates with physical activity and tension type headache doesn't aggravate with physical activity. And nausea is common in migraine, nausea is uncommon in tension type headaches. So when you call aura, it should develop over 4 to 5 minutes. And the aura will not last more than 60 minutes. And usually the headache follows aura within 60 minutes. There will be an interval cannot be more than 60. So aura is a reversible phenomena. So additional features of migraine, it's predictable, timing around, for example, timing around menstruation. It's a stereotyped premonitory symptoms. A patient will have a set of premonitory symptoms. It will not vary much. Characteristic triggers, abetment with sleep, positive family history, childhood precursors, motion sickness is a close relative of migraine, episodic vomiting, episodic vertigo, osmophobia. These are common. But you have made a diagnosis of migraine, still be aware that there are multiple types of headache in a similar patient. Studies have shown that 70% migraine then can have a tension type headache and probable migraine also. So be aware of that. And it can be frequently misdiagnosed as tension type headache or sinus headache. So how will you improve the predictors? The strongest predictors of migraine diagnosis, you have seen a patient and you suspect migraine. Now the important questions are 3. Nausea. If the patient feels nauseated or sick, you are sick to the stomach when you have a headache. Disability, has a headache limited activities for a day or more in last 3 months. And photophobia, does light bother you? If 2 out of 3 are there, the positive predictive value is 93%. And 3 out of 3 positive predictive value is 98%. And medication overuse, intake of more than 10 days per month on a regular basis or more than 3 months. That is more than 15 days for simple analgesics can be medication overuse headache. So when you have a sudden onset headache, it can be primary or secondary. In primary thunderclap headache, sexual headache, exertional headache, cough headache. In secondary, all these things. When a new onset headache, always evaluate. Don't delay. A CT scan for a headache is really wasting money on a patient. So better to do an MRI directly. If CT is normal, except for a trauma. In trauma, CT is helpful. But in other cases, it's rather do an MRI rather than subjecting the patient to radiation, also wasting money. So migraine treatment involves abortive and preventive therapy. The idea is to improve the quality of life. So this is not a guideline, this is the general practice wise. If the frequency of attack is more than 2 per month, you can consider. Duration is more than 24 hours, and it does cause disruption in patients' daily activities, or the abortive therapy fails or overused. Use of and migraine variants like hemiplegic migraine, or there are red flags. Then you can be using prophylactic therapy. So it's all about the group. When you talk about acute therapy, the triptans are really effective. We should know when not to use. I will come to that. And antiemetics as well as NSAIDs. Naproxen is a good So naproxen with domperidone is a good combination because you're mixing up 2 medication. It's really effective. And when you come to prophylactic therapies, the antiepileptic drug valproic acid, topiramate has good efficacy, and gabapentin has secondary. Antidepressants, amitriptyline is really effective, and propranolol is effective. Though we use lot flunarizine, there is less evidence to flunarizine. I consider it as a bad drug because it can cause depression, weight gain, and a lot of interactions. So it's valproic acid, topiramate, propranolol, and amitriptyline. So when there's no one size fits all here. You see a patient, a woman has come with a headache, you will not be using valproic acid. Someone who has depression, you will be avoiding topiramate. Someone who has a history of kidney stones or glaucoma, you will be avoiding topiramate. Someone who has a sleep disturbance and coming with a headache, amitriptyline. And when you look at older age group, you try to use propranolol if he is not a diabetic. So there is no one size fits all. The main drug will be valproic acid, topiramate, propranolol, and amitriptyline. You need to select correct patient. It's very important over here. So when should it be given? The guideline says 6, though we discussed 4. So duration, almost all guidelines says at least each drug you should be giving 2 to 3 months time to have a good effect in a good dosage. So goals, at least 50% of headache should come down, the quality of life should be better, and stable headache pattern for 3 to 6 months, never stop, slowly taper. So the pitfalls are incorrect diagnosis. The one point is tension type headache doesn't respond to propranolol, and excessive dosage can cause problems. 9 to 12 months is a good time. I think you should give a break after 9 to 12 months. And patients' expectation should be matched. Patients expect cure. Tell them clearly, it will take time. You have to wait. So the location is pretty important. Cluster headache is strictly unilateral. Tension type headache is bilateral. Migraines begin unilaterally, go for bilateral. And pain along the temporal artery can be temporal arteritis. Eye pain can be glaucoma. And severity also does matter. And recent trauma is pretty important. We should ask history for trauma every time. And this is a classic headache. So where prodrome symptoms can be yawning, excitation, depression, lethargy, craving, or for several foods. And then it can be aura, flashing lights, then headache symptoms, anorexia, and prodrome. You should ask the history for each patient. It can be same. The reason is good to document. If the patient might have had a migraine now, but after 10 years he come with a new onset headache, it's not fit into his fixed one, then it can be a different one. Triptans, good drug. The contraindication is it causes vasoconstriction, so shouldn't be used in someone who has cardiac or stroke. Pregnancy, you should be relative contraindication is there. When to take triptan is important. Take at the onset of headache, not during aura. Early administration increases effectiveness, and best results is if taken within 1 hour. Ditans are good. It can be used in patients who cannot use triptans because it doesn't cause vasoconstriction. And monoclonal antibodies in migraine, these are big now. This can be used if there is 4 or more migraines day per month. If the oral drugs have failed, the erinibab is available in India. It is monthly dosage, subcutaneous. 19,000 is for 1 vial. So 3 vials, if you get for 3 months, 1 vial is free. So 38,000 for the course of 3 months. Usually does work. Botulinum toxin, not for episodic migraines. If for chronic migraines, botulinum toxin is indicated. It works pretty well. And greater occipital nerve block. It's also local lidocaine, bupivacaine, or Dexa use. It's really workable. And wearable devices like Cephali, Nervio, these are all coming up. And there are FDA approval for these. And the big drug which is on the way is GPANs. So differential diagnosis, I'll stop with this. Red flags present or not. If no, if it's yes, it's a secondary headache. If no, it's a primary headache. Atypical features there, again go back to secondary headache. Atypical features are not there, then look at more than 15 days or less than 15 days. More than 15 days, more than 4 hours migraine. Look for side locked, then it can be new daily persistent headache, which is little difficult to treat, or SUNCT. I can take 2 minutes or 3 minutes max. So if it is less than 15 days per month, look for more than 4 hours or less than 4 hours. If it is more than 4 hours, it can be episodic tension type headache. If it is less than 4 hours, the other types. So SUNCT and SUNA is important. That is pretty easily treatable. You cannot miss that out. These are types of, I'll go for that. The cluster headaches, where cluster headache, there are multiple types. This is very classical. Wake the patient up from sleep, suddenly the headache, and it's unilateral. They can be associated with redness of eyes, nasal blockage, running nose, and tearing. It can be mostly diagnosed as sinusitis because people might miss out on that. Easily treatable. Prevention is verapamil, and you can use indomethacin for prevention. And the best is oxygen therapy. Give the patient 10 minutes, 10 liters oxygen. If you see a redness, headache, unilateral, redness of eyes, or tearing, it works pretty well. And we cannot miss out on secondary headaches. The CSF pressure. Increased pressure can cause IAH. Low tension headaches in post-lumbar puncture headaches can be there. Brain tumor, precipitation of headache by Valsalva maneuver or bending over warrants investigation for neoplasms. Toxic carbon monoxide poisoning, hypoglycemia, hypothyroidism can present with headaches. So it's about sleep, stress management, dietary triggers, environmental factors, dehydration, hydrate well, skipping meals is a problem, and physical exertion can be a problem. So one case, 38 years old male presented with left supraorbital pain. She had mild ptosis. And there was anisocoria which increased in the dark. In the light, it is not much visible. What's the diagnosis? That's it. A 38-year-old female came with an acute onset left frontal pain. There's an anisocoria on the left, and which increases in the dark. Vascular. It's actually dissection. So very simple, but it can, because it has involved the carotid artery where the sympathetic fibers are running. Thank you.
Excellent presentation, sir. You started with the red flags and then discussed about the pathophysiology and the importance of MRI in all cases except when trauma to prefer CT, otherwise MRI to prevent. And you have discussed about all types of headache and the drugs in brief. Thank you, sir.
Thank you very much, sir, for wonderful deliberation. Actually, managing a patient headache in OPD is a real headache for a physician because most of them come again headache. And you said very simplified where to choose what drug, which condition you have to choose. So, but we have come across commonly that a headache in migraine, a typical classic migraine, most of them associated with sinusitis. If there no sinusitis, less headache. More sinusitis, more headache. Is there any association of sinusitis and migraine headache?
Sir, sinusitis, usually there is a seasonal variation. There should be a seasonal variation. And it cannot be that during summer, the frequency will be the same as the winter. So it's frequently, migrainer can have a sinusitis and sinusitis patient can have migraine. But if it is chronic and then more than, if it fits the criteria, it should be a migraine. And also, many times the cluster headaches are being misdiagnosed as sinusitis because there is rhinorrhea. During headache, we might tend to move towards sinusitis.
Great. Thank you very much, sir. And now we are moving from the just pain to the neuroinflammation. And that relates to the inflammatory pain may occur in migraine. So that steroids also sometimes may be used for treating migraine because of the neuroinflammation. So everything, sir, has elaborately discussed. Thank you very much, sir, for your wonderful presentation.
Thank you, sir. We will now begin the next session in our scientific agenda. I welcome Chairperson Dr. S. Venkatraman, sir, Senior Consultant Diabetologist, Apollo Hospital, Dr. A. Natarajan, sir, Senior Consultant Diabetologist.
So good afternoon, and it's really a great honor to be part of this wonderful program. I think Dr. Natarajan, Dhanmitran, and Parandaman and team, periodically, I would say that they connect with the academics, and then once in 6 months or once in a year, arrange for a, what shall we say, knowledge enriching program. I think the best part of this edition of DCCON is the topics chosen. Absolutely relevant to the day-to-day practice, with so much of relevant theoretical details that have been covered, at least in the last two speakers that I have noticed. So again, we are going to have one more topic which is of extreme contemporary interest for the clinicians. I think in pregnancy, it's not just the, what shall we say, undisturbed purview of the obstetrician alone. The physician plays a vital role, especially if there is going to be associated diabetes or hypertension. And in the context of hypertension and pregnancy, certainly there are various aspects. Somebody develops hypertension during pregnancy, induced hypertension, or a pre-gestational hypertension, chronic hypertension with impact of pregnancy, so many issues. I think always the doubt is, what is the target? And what are the molecules? So we know that certain molecules are not to be used, but which are the molecules to be used, and how aggressive we can go? I think to do this, I have great honor in introducing Dr. Swamikandu. In fact, before I introduce him formally, I think presently he is the head of the department and the director of medicine in MGM, and he has started a wellness and obesity clinic as well. That's what he shared with me the other day. The other point of interest is, I was in SMF from 95 to 2002. I think towards the later part of my innings in SMF, Swamikandu joined. So I did have a brief stint with him to work as a colleague, and it will be a great honor to invite Dr. Swamikandu and his CV lectured here. You can go through that in greater detail. I think a lot of academic accolades, and then a lot of lectures. As I told you, recently I think the MGM healthcare has been enriched with the inculcation of masters like Professor Swamikandu. So let us listen to Dr. Swamikandu with respect to hypertension and pregnancy, target and treatment. Now the honors are being done by Dr. Dhanmitran.
Thank you very much for the opportunity. Before I begin my talk, those who have migraine feel happy, because my teacher, C. Vel Murugendran, used to say, only outstanding and very intelligent people get migraine. So I went to see him in OPD one day that I have a headache. He said, everything is fitting in, but some history is not fitting, he said. Then I asked him why. Clinically you have migraine, but it comes to only intelligent people. I don't know how it came to you. And then finally he gave me some medicine, and while I was leaving the room, he said, exceptions will be there, don't worry, he said. So that is how the migraine history I thought of my teacher. Today I'm going to talk on hypertension and pregnancy. My disclaimer is I'm not a logician. So today I begin with my talk. As he rightly said, hypertension can be different types in pregnancy. Hypertensive disorders of pregnancy, largely it amounts to about 10% of the pregnancies. The triad of hemorrhage, infection, and hypertension is the deadly component in maternal morbidity and mortality. Preeclampsia alone, the lone entity or superimposed on chronic hypertension, is the most dangerous and contributes to about 7% of the maternal deaths in the USA, and in about 10% in India. The hypertension in pregnancy is diagnosed when the BP is more than 140/90. The mid-pregnancy incremental changes are no longer used as a diagnosed hypertension in pregnancy, though the BP monitoring in such patients is warranted. With that introduction, we'll go into the types of hypertension in pregnancy. One is called gestational hypertension, where your BP is more than 140/90 for the first time after the mid-pregnancy. That's usually after 20 weeks, and without proteinuria. with proteinuria, it becomes a different type of hypertension. Almost half of the affected women go on to develop preeclampsia with a gestational hypertension. 10% of the eclamptic seizures develop before the overt proteinuria is detected. So if you wait for the proteinuria, you may miss this. So you can get 10% of people even without proteinuria. The preeclampsia syndrome, pregnancy-specific syndrome that can affect every organ in the body. Appearance of proteinuria is a key diagnostic criteria and reflects a system-wide endothelial leak. Occasionally, neither proteinuria nor fetal overgrowth restriction are features of preeclampsia. The ACOG task force on hypertension and pregnancy suggests other diagnostic criteria in aid diagnosis. There are a lot of research currently going on to the markers for the eclampsia, which I'll briefly discuss in the later slides. So to classify this pregnancy in hypertension, we have gestational hypertension, BP 140 by 90, more than 140 by 90, after 20 weeks of pregnancy in a previously normotensive women. This is the definition for the gestational hypertension. Preeclampsia, this is hypertension plus proteinuria. Proteinuria is more, over 24 hours, more than 300 milligrams. Or if you are using a dipstick, 1 plus proteinuria, or one of the conditions associated with either with thrombocytopenia, renal insufficiency, creatinine more than 1.1, and platelets less than 1 lakh, and liver involvement with the increased transaminase levels, twice the normal levels, and the cerebral symptoms like headache and visual disturbances, convulsions, and pulmonary edema. So one of these plus. So definitions of preeclampsia syndrome, you have moderate symptoms and the severe symptoms. Moderate symptoms include headache and visual disturbances may precede the eclampsia. Generalized clonic seizure not attributable to any other causes if you have a eclampsia. The upper right upper quadrant pain, which often accompanies the hepatocellular dysfunction or necrosis or ischemia, or sometimes a hematoma, which may be identified and with the elevated liver enzymes. Thrombocytopenia represents platelet activation and microangiopathic hemolysis. If you have a severe preeclamptic syndrome, you can have a blood pressure more than 160 by 100, headache, visual scotoma, upper abdominal pain, serum creatinine more than 1.1, thrombocytopenia less than 1 lakh, transaminase levels, increased transaminase levels, and fetal growth restriction, pulmonary edema, and early gestation age. Definitions for chronic hypertension with the superimposed preeclampsia. Any patients who has pre-existing hypertension in which you developed a superimposed preeclampsia syndrome. Chronic hypertension is diagnosed when the woman has got more than blood pressure more than 140 by 90 before the pregnancy, before the 20 weeks of pregnancy. Women with the worsening baseline hypertension and new onset of proteinuria or any other severe features diagnosed with superimposed preeclampsia. This usually develops earlier in pregnancy compared to pure preeclampsia. Difficult to evaluate in women who are not diagnosed until mid-pregnancy, since signs of end organ damage may not be present at the time of diagnosis. There is an interesting factor about delta hypertension. This is a sharp and acute increase in arterial pressure that still lie within the normotensive range, less than 140 by 90. This may a marker or indicator of the eclampsia is going to come. So watch for delta hypertension. So if you look at this graph, you have a red line and the white line. The blue line is the normal patient wherein the BP raises, but it stays within the normal limit. But the red line which sharply raises and goes to the 75th percentile, that is called delta hypertension, which may a marker of the preeclampsia. So the epidemiology and the risk factors, preeclampsia is identified in 5 to 8% of the pregnancies. It's about 10% in India. Young and nulliparous women are most vulnerable, while older women are at risk of chronic hypertension with superimposed eclampsia. African American women are more adversely affected than the Caucasians and Hispanics. The risk factors for the eclampsia is advanced maternal age, nulliparity, obesity, and metabolic syndrome, CKD, diabetes, diabetes mellitus, chronic hypertension, previously history of preeclampsia and HELLP syndrome, family history of preeclampsia, autoimmune diseases like SLE and antiphospholipid antibody syndrome, and the multifetal gestations. To understand the pregnancy in hypertension in pregnancy, we have a lot of speculations. Most of them are speculations, but the cause may be attributed to the interactions between the maternal factors and the placental factors. So the maternal pathway, pre-existing maternal comorbidities like hypertension, diabetes, and chronic kidney disease, and the reproductive previous history of eclampsia and hypertension, and non-modifiable demographic characteristics and and genetic factors. The non-modifiable demographic characteristic may be the African American women and the Caucasians comparison, as I already told you. Placental pathway is related to the incomplete remodeling of the spiral arterioles in the decidua basilis, incomplete thromboblastic invasion, placental vascular atherosis. So if you look at the picture, you have a maternal pathway and the placental pathway. The physiology goes like this. The pre-existing hypertension, diabetes, and CKD, obesity can predispose to the pre-eclamptic syndromes, whereas the placental factors like, as I already alluded to, incomplete remodeling of these spiral arterioles and plus vascular atherosclerosis, which leads to decreased vessel diameter and impaired placental blood flow, reduced perfusion, and flat fetal hypoxia. The consequences of both the maternal and placental factors leads to defective placentation, predisposes to women to preeclampsia, preterm labor, and fetal growth retardation, and placenta abruptia. The placental symptom, the immunological factors also play a role. Loss of maternal immune tolerance to parental and fetal antigens. One is cited as a theory of preeclampsia. There are evidences to support this. One is the high incidence of early onset of preeclampsia seen in complete molar pregnancies. Fetuses with Bartter syndrome, which is trisomy 13, have 30 to 40% incidence of preeclampsia. That clearly proves there is a immunological. Women who have had previous preeclampsia are less likely to have preeclampsia in the subsequent pregnancies because of the immunity. The genetic factors also play an important role in preeclampsia. Strong familial history, it is associated with 20 to 40% of preeclamptic mothers. And ethno-racial predisposition, already we told the African Americans are more vulnerable for developing a preeclamptic syndrome. The maternal factors, there is a vasospasm and the systemic endotheliopathy, peripheral vascular resistance, and this is how the hypertension develops. And the endotheliopathy, anti-angiogenic factors plus cytokine release, endothelial cell activations, which in turn leads to thrombocytopenia, edema, and proteinuria because of the increased vascular permeability. The angiogenic and anti-angiogenic factors like the effects of VEGF and angiopoietin on placental vasculature have been studied extensively, and these are being studied as a treatment as well as the markers for the pre-eclamptic and eclamptic findings. I'll finish in 5 minutes. Though prediction of this preeclampsia and eclampsia, though many biological markers have been tested thus far, there are currently no individual tests for preeclampsia that are predictable, reliably valid, and economical. Uterine flow, artery flow velocity may indicate the increased incidence of preeclampsia. Uterine artery notching, as in the Doppler, it can indicate. It can be one of the important factors that will indicate the eclampsia and preeclampsia. So now we are going into the era of the machine learning and artificial intelligence. These more and more factors can be included in the diagnosis and prediction values for the preeclampsia and eclampsia. So we might, in future, we might have more markers for the eclampsia and preeclampsia prediction. There are two trials which talked about the use of aspirin, which decreases the incidence of eclampsia and preeclampsia. And the combined screening has increased detection rate, but the ACOG and NICE are yet to adapt this algorithm for early eclampsia risk stratification. So currently they are not used as markers. I'll skip these two slides. So WHO, what is the WHO recommends women with non-severe hypertension during pregnancy should have antihypertensive drugs as a part of antenatal care. Oral alpha agonist and like methyl dopa and beta blockers like labetalol are the effective treatment options in the management of hypertension in pregnancy. The choice and route of administration antihypertensive for severe hypertension should be based on clinicians' experience, drug cost, and the local availability. WHO acknowledges that the idolizine, methyl dopa, labetalol, and nifedipine have been extensively used and are reasonable evidence-based medications. Low-dose aspirin recommended for prevention of eclampsia in women at moderate risk or high risk developing in condition. Low-dose aspirin also prevention of eclampsia should be initiated by the 20th week of pregnancy. Daily calcium supplementation is required in third world countries, especially. And other considerations, BP monitoring is essential in hypertensive pregnancies. And your goal of BP is it should be less than 140/90 to minimize the maternal complications without compromising placental perfusion. Proteinuria can be assessed either using a 24-hour collection or urine PCR is just enough. Gestational hypertension and mild eclampsia can be managed as an outpatient basis. Severe features of warrants inpatient care and reduce the risk of stroke and other adverse outcomes. Monitor for magnesium toxicity during administration of magnesium sulfate, urine output, and the serum magnesium. Watch for absence of deep tendon reflexes. Keep calcium gluconate and ECG on hand. The maternal and fetal outcomes, women with hypertensive disorder of pregnancy are a higher risk of developing cardiovascular disease in future. They also have a higher risk of developing venous thromboembolism and impaired long-term cognitive impairment. Strong association with the adverse potential outcomes, the fetal growth retardation, placental complications, low birth weight, and neurological complications, and neonatal morbidity and mortality. Increased neonatal intensive care. The drugs that can be used as labetalol. The initial dose can be 20 milligram IV bolus followed by 20 to 80 milligram for every 20 to 30 minutes. It can be also used as 1 to 2 milligram per minute as infusion. Idolizine is another nice drug that can be used. Nifedipine is a best oral choice of medication, can be used up to 10 to 30 milligram. The methyl dopa is one of the best drugs that was available in the past. Now it's slowly disappearing from the market. I don't know what is the reason, but it's very difficult to get alpha methyl dopa current nowadays. The other drugs that can be used is the magnesium sulfate and sodium nitroprusside. With all these things, the best way to prevent hypertension in pregnancy is the lifestyle-based interventions to manage BMI. So that means obesity. Prior to the marriage itself, you should plan, pregnancy itself. I'll just finish in 1 minute. Prior to the pregnancy itself, you have to do the counseling and reduce the ideal body weight and before they conceive, and enough education should be disseminated. Even it should be included as a curriculum in the schools and the colleges so that they have a better idea of pregnancy, hypertension in pregnancy. So the emerging research is whether statin can be used. There are trials that indicates that statin has a beneficial effects in pregnancy, but a lot of bigger studies should be available to start using statin. And hydrogen sulfide is another drug that is being evaluated. It can be directly given to patients through nanotechnology. And folic acid already been in practice. We can use it in the 5-metho tetrahydrofolic acid can be used in pregnancy, people with hypertension. And another drug that can be used is C-peptide natriuretic peptide. That is in the research level. It has not been coming into the practice yet. So the best way to prevent hypertension in pregnancy, plan the pregnancy. Before you plan pregnancy, you get the weight reduction, screen for hypertension, and best way to prevent is best educate the public and catch them young and treat them at the school level and the college level so that we can prevent hypertension in pregnancy. Thank you very much. I would like to thank my student who is helped me to preparing this slides. Thank you.
Thank you, Professor Swamikandan. I think whatever you have learned during our undergraduate and postgraduate stays, plus whatever is recently available, I think the journey from the chronic hypertension, pregnancy-induced hypertension, and also highlighted the delta hypertension, which occurring probably in the late second and third trimester, and then the pre-eclampsia. What are the clinical parameters and the markers that could be useful, and how aggressive one can go, and what are the molecules which are there. I think it was a good revisit, plus superimposed with your own personal experience. Thank you for the brilliant presentation. Thank you so much. So maybe because of want of time, we'll go to the next presentation, and maybe if time permits, we can have a couple of questions at the end of the second talk. Thank you, Dr. Swamikandan. I think now we are going to listen to Dr. Oman. Before I introduce Dr. Oman, the topic, the hypertension to heart failure. I think it's a good link between pregnancy and hypertension, and then hypertension to heart failure. Welcome, Dr. Abraham Oman, and Dr. Dhanmitran has done the honors for you. Again, when we talk about diabetes and hypertension, and we always know there is a sequence of events which ultimately one of the manifestations is heart failure. Now, our understanding of heart failure, especially in the last maybe more than a decade, thanks to cardiologists like Abraham Oman, have made us sit in the podium and then maybe in a position to even discuss with them. To that extent, they have percolated the knowledge, because our understanding of heart failure, the interventions, and even at the physician level, of course, what was possible. I think we are going to have a discussion from Dr. Abraham Oman. Abraham is a colleague of mine in Apollo Hospital, enormously very sought after clinical cardiologist, interventional cardiologist, as well as the academics. I think the way he is associated with heart failure scenario in the national and international sphere, it's really a proud moment for all of us. I think Dr. Ram Subramanian is there. Even for the Apollo family, it's a great moment for all of us to realize that one of our family members has been recognized as a real worker who has contributed immensely in the field of heart failure, as attested by his CV. He is the president of the Heart Failure Association of India, and recently he has traveled abroad and then presented a lot of papers. One thing Abraham Oman, I'm really jealous of you is, you have been principal investigator for some 20 trials. I know about 4 or 5 trials in part. So I think that is one part of your CV in a lighter way. I think hats off to you, the way you have made your presence felt in the, not only the field of cardiology, but also in other intervention and the molecular aspects. So now we are going to listen to Dr. Abraham Oman from hypertension to heart failure, challenges, opportunities to break the vicious cycle.
Thank you, sir. Thank you for the kind words. So, where is my slide? Okay. So, my topic is hypertension and heart failure, challenges and opportunities. So, since we are a mixed crowd, we all should think what the patient wants, because ultimately our job is to treat the patients. We have a regular the patient's education program in a hospital, and I asked this question to the patients. And there is published data also on this. So what does the patient want? They want to live longer. Actually, the mortality part came third. They wanted to have a life without dementia. They wanted a life without heart failure or strokes. And they want to live longer. When the very same question was asked to doctors, they said they want to live longer. Then dementia came, then heart attacks came. And heart failure came a little lower, partly because of lack of awareness. So, but again, one note is that doctors live 1 decade lower than the general population. It has been shown in studies from UK as well as from Kerala IMA registry. So that's because we don't take care of the health. Again, a question to all of us is that, how many of us have blood pressure, systolic blood pressure, less than 120? How many have between 120 to 130? No need for raising the hands, because we consider more than 140 as normal, and that is not exactly the normal. So what are the opportunities in controlling the blood pressure? We fulfill the wishes of the patient as well as doctors. We make them live longer and lower the risk of dementia. That's something which we all do not want. Heart attack, strokes, and also heart failure. And heart failure is very important, but we do not give much thought to it. Even the patients do not give thought to it. So, very simple. We know about pack years. We know that the cumulative lipid burden, the cumulative glycemic burden, again, there's a lot of things Dr. Venkatraman can talk about it. And again, the blood pressure burden. And it is directly connected to all-cause mortality. So that is the main opportunity. Control the blood pressure, live longer, reduce or postpone death. So the question, again, the patients asked, like we all talk about mortality, but reducing the blood pressure, what is the extent of lifespan I get? So do you have any number? We have a number. So if the blood pressure is more than 130, which majority of us and our patients have, versus low 120, around 120-ish, how many years can you extend your life? Any other cancer has better mortality than that. 10,000 rupees per month. Cheapest way of prolonging life is controlling the blood pressure. And how it does? It reduces stroke, it reduces heart attacks, and it reduces heart failure. So, again, the second wish of the patient, the major adverse cardiac events, strokes and heart attacks, reduced by about 40%. So, and dementia risk is reduced by control of blood pressure. So, we all, my greatest wish is anayasa maranam, which is not easy to get, but a life without dementia as much as possible, because it will be a burden to ourselves and to people around us. And control the blood pressure, dementia will be reduced. And is there any data? Yes, there is data. There's a data from the publication. This is from China. But within 4 years, good control of blood pressure to less than 120 reduced dementia by 15%. So these are the opportunities, and with that, heart failure, the last one, which is not very, very, very well thought of, because people think that, okay, like they are two different things. And hypertension is a asymptomatic thing, and heart failure is something which comes very late. But one of the commonest cause of heart failure, especially heart failure with preserved ejection fraction, is hypertension. So that is the question, that heart failure in 21st century, is the coronary artery disease problem or a hypertension problem? But when you see heart failure, we majority have coronary artery disease and hypertension. And it's a chicken and egg, which beget the other? But my answer is both begets the other. So now going to the boring part of the pathophysiology, hypertension produces both volume overload and pressure overload, which increases the LV wall stress, which in turn produce mechanical stress. There is extracellular or intracellular signaling. The metalloproteinases are altered. There will be hypertrophy, myocyte damage and fibrosis, reduced coronary reserve, and leads on to heart failure. So all roads lead to Rome. Similarly, hypertension ultimately lead to four things: mortality, heart failure, heart attack, and stroke. And the speed is in our hands. And in fact, we can't prevent death, we can't prevent, we can postpone dementia, but we can prevent heart attacks, heart failure, and stroke. So these are stages of heart diseases. Degree 1 is LV diastolic dysfunction and no LV hypertrophy. If you see the echo of most of your patients, you see the LV diastolic dysfunction noted, but you don't give particular note to it. Everybody has it. But everybody has it, and they're on the road to heart failure. Then comes LV hypertrophy, then clinical heart failure with preserved ejection fraction. This is a huge chunk, and it's estimated that nearly 50% of the diabetic patients of India have HFpEF also. But we just do not look for it. It's looking for it, it's very cheap. It's like Dr. Chennappan said, it's again one of the cheapest thing. Look at the ECG, look at the echo. And what do you look? ECG, Dr. Chennappan has said, echo, please insist on few things, or look at few things. Left ventricular hypertrophy, left atrial enlargement, the RV systolic pressure of pulmonary artery hypertension. On top of it, make sure that your echocardiographers look for E by E prime and global longitudinal strain. This will give you a very good idea about present or impending heart failure, and you can literally save the patient, and this costs nothing. If your echocardiographer does not do that, send it back, and the patients will benefit. And last is eccentric LV hypertrophy and reduced ejection fraction. By the time the game is almost over. So in a different way, uncontrolled hypertension, concentric hypertrophy, which can lead to diastolic heart failure, myocardial insult, eccentric heart failure, hypertrophy, and systolic heart failure. And again, when you have hypertension itself, you reach stage A of heart failure. And they don't have symptoms, they have risk factors. But what is the mortality rate? It's about 3 to 5%. It's not a very stable or benign disease. So having hypertension, having diabetes, having LVH is stage A, or maybe even stage B heart failure if they're totally asymptomatic. They may be climbing Shabarimala, but still they may be having stage A or stage B heart failure. Now let's look at the challenges one by one. The challenge one is lack of awareness of the frequency of hypertension on heart failure. Hypertension is a major risk factor for development of heart failure. They coexist, and every 1 out of 2 Indian heart failure patients are hypertensive. And sometimes when they come, you check the blood pressure, it may look okay. But if they have left ventricular hypertrophy, you can do ambulatory BP monitoring and find that they have all kind of variation. They have nocturnal hypertension, they are non-dippers, and that can be well treated. Now, what are the population attributed fractions for 8 common comorbidities for heart failure? So heart failure, as I said, is worse than cancer. So which comes higher in the villains list? The number 1 for HFrEF, the blue is men, the blue are men, and the orange or brown are for females. You can see the number 1 villain is hypertension. You can look at diabetes down below. It is there, but majority of diabetics have hypertension. But diabetes for HFrEF and HFpEF, it is the biggest attributable comorbidity. And what do these comorbidities do? The comorbidities amplify risk. Insulin resistance, dyslipidemia, genetic factors, obesity will lead on to diabetes, hypertension, which lead on to atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling, macrovascular disease, microvascular disease, ultimately cardiovascular disease and heart failure. So that's what, like I said, all roads lead to Rome. Similarly, this is a famous quote from Thanos. We are little older people, but Thanos everyone knows. And so what Thanos says is, I am inevitable. Similarly, heart failure is inevitable with diabetes, hypertension, CAD, atrial fibrillation, CKD, obesity, age. So for all of us, it is said that our risk of developing heart failure in the general population is more than 25%. So 1/4 of people sitting here, including me, will develop heart failure and may die of heart failure in our lifetime. And you can see the numbers in India: diabetes 101 million, pre-diabetes 136 million, hypertension 315 million, abdominal obesity 351 million, dyslipidemia 213 million, CKD 17.2% of Indian population. So all of them, it's creating a perfect storm towards heart failure. Challenge 3 is lack of awareness of the impact of hypertension in patients with normal ejection fraction. So a person with normal ejection fraction, they have hypertension. We tell them, oh, everything is hunky-dory. But what is the risk of that person developing problems? Look, see there, heart failure is the number one, and followed by stroke, followed by a CKD, etc. So heart failure, again, EF normal, hypertension and diabetes, don't pat their back. The chance, what do they die of? It's heart failure. Then the impact of development of the heart failure, their awareness in patients versus the doctors, but this is from the HOPE trial. So in the patient's course of like in their disease course, if they develop heart failure versus no heart failure. So this patient had, say, hypertension, diabetes, etc. If they develop heart failure, the trajectory widens very fast and the mortality is very high. What is the target? Again, we say, okay, 130 is okay, 140 is okay. But 120 versus 140, there is a nearly 40% reduction in acute decompensated heart failure events. So that is something which you should aim for. If you aim for 120, keep it between 120 to 130 at least, then the chance of acute decompensated heart failure comes down. What drugs where is a challenge, but it's no longer a big challenge. There are specific indications, but get the BP under control. Whatever the way, like Deng Xiaoping said, whether he said, I don't care whether the cat is black or white as long as it catches the mice. As long as the medicines control the blood pressure, I don't like it matters. The way is fine, but whatever the greatest drug or renal regeneration, the BP is not controlled, it does not hold water. Challenge 7 is the questions on hypertension, HFpEF. This is a major thing, but this is what we all miss. And every day we miss HFpEF patients. So the question is hypertension a phenotype of HFpEF? Because we know that there are multiple phenotypes of HFpEF. Is it specific pathophysiology? What is the prognostic impact? Different treatment? What is the role of resistant hypertension in HFpEF? And which BP-related parameter is most informative? These two trials, the HFpEF trials, 90% had high hypertension. So in heart failure preserved ejection fraction, the hypertension is very, very common. And we said there are many clusters. We have obesity cluster, we have metabolic disease cluster, we have got the diabetes cluster, the different multiple phenotypes, age cluster, female cluster. But what is very common in all these clusters is that hypertension is predominant. And The link is development of left ventricular hypertrophy, arterial stiffening, renal impairment. And concentric hypertrophy is not mandatory. It can be eccentric hypertrophy. There can be normal in a patient with HFpEF and hypertension. So even if you do not have significant concentric hypertrophy, keep an eye on BP control. The ventricular arterial stiffness can be reduced by antihypertensive therapy, thereby reducing the chance of heart failure. Does hypertension cause inflammation? Yes, it causes inflammation. It can cause endothelial dysfunction. And which is on what aspect of heart failure hypertension has greater prognostic impact? Is it HFpEF or HFrEF? Answer is the same. Both in HFpEF and HFrEF, control of blood pressure reduces events. Should it be treated differently, hypertension with HFpEF? Answer is practically no. To control the blood pressure, there is no particular optimum treatment strategy. The strategy is control the blood pressure. And the drugs, beta blockers regress LV mass, ARB reduces LV mass. And again, a big question is that reducing the BP less than 120, does it increase adverse events? And this is from DELIVER trial. And you can see that practically no. It is all in the mind of the patient as well as the doctors. 120 or 110 systolic blood pressure is not low BP, it is optimum BP. And try to spend some time with the patient for that. Because 120 versus 140, the benefit is the reduction of acute decompensated heart failure by 40%. Does resistant hypertension, is it a separate entity? It's very common in HFpEF, but we see that we can treat them well with MRA, spironolactone, even the SGLT2 inhibitors that can be well treated. Which BP-related parameter is most informative? So we know the diabetology perspective, time in target. The lipid perspective, time in target. So PAC years, lipid years, hypertension years. Similarly, time in target range could be the single most important factor for control of or prevention of heart failure. So that is something which we have to remember. If somebody says that my BP is 140, I'm asymptomatic, tell them that still there is some amount of risk. So that is the questions, is hypertension phenotype? All phenotypes of HFpEF, hypertension plays a role. There's an interplay between hypertension and heart, HFpEF through LV hypertrophy, arterial stiffness, and renal impairment. Similar impact on HFpEF and HFrEF. And systolic blood pressure, try to reach less than 120. And so what are the parameters which are most important? Time in range is most important, systolic blood pressure and pulse pressure. So these are the three indicators which you should look at. So we have a lot of opportunities. The opportunities, and this is a paper from European Heart Journal very recently, that both in males and females, in HFrEF and HFpEF, hypertension is the key factor in development of heart failure and prognosis of heart failure. It is the IHD is there, smoking is there, hypercholesterolemia is there, diabetes is there, but hypertension is very, very important. Which 2.5 minutes spare, I conclude by the great saying of Wayar, Kattradu Kaimanalava, Kallardadu Ulagalava. It's very interesting is that this quote was attributed to Laplace, and he said, this is the last statement before he died. What we know is not much, what we do not know is immense, and this is quoted in NASA also. So we can be proud that this quote is from our own heritage. So we still need to know a lot of things about heart failure and hypertension. But in one sentence conclusion is that keep the blood pressure around 120. For most of the time, you can make a person live longer, make him have a life without heart attack, stroke, dementia, and most importantly, heart failure. Thank you very much for patient hearing.
Thank you, Dr. Abraham Oman. As expected, what a great talk in the limited time that has been allotted to you. I think the few points that I was thoroughly impressed was, in the prioritization of the diseases. I think you highlighted dementia as an offshoot of hypertension much above your MACE as well as heart failure. I think that's a point worth pondering, number one. And number two, how when you can shift the BP target, you improve the longevity, a single simple measure compared to the other avenues in various diseases, how they have been found wanting. And third point is, when it comes to the entity of heart failure with preserved ejection fraction, you nicely highlighted to the clinicians how you should insist on the GLS, global longitudinal strain, as well as the E prime ratio. I think a ratio more than 15 will be taken off as yes. So this is what we have learned from you. And of course, you did highlight the importance of hypertension to heart failure. So far, we've been talking about diabetes, hypertension, single risk factor, how either in the context of both preserved as well as reduced ejection fraction, how it has contributed. And then when it comes to the molecules, there's not much of a difference. Possibly when it comes to hypertension per se, beta blockers might have a backseat in the context of diabetes hypertension, but when it comes to heart failure, I don't think there is anything, even though we have a preferential beneficial effect of the various molecules. And you did talk about the sequence of events, which ultimately, whether you start with hypertension or coronary artery disease, I think ultimately, when it comes to the pump failure, the contribution is huge from either of them. So I think we had an excellent session, a very good overview from a Pandit who has spent most of his time not only in the nuances of cardiology, but also in heart failure. Now I request Natarajan to say a few words before we go to the next session.
Thank you so much, sir, Dr. Heyman. You also told us about time in target, which is a new concept which I learned today. We know about in hyperglycemia, time in range, but here in hypertension, this is something really wonderful which we have to look at more often with the self-monitoring blood pressure at home.
Sure, thank you so much. Both Professor Swamikandan as well as Professor Abraham will be with us for the lunch. So since we have slightly behind schedule, I was told by the organizers that we'll have these questions. I'm sure we'll have a lot of questions in spite of the clear-cut presentations or discussion or clarifications. So now we'll go to the next session. Thank you so much.
Thank you, sir. We now commence the oration of Professor V.T. Balaraman, sir. I request Dr. Dhanamitran, sir, founder and president D Club, Dr. Parandaman, sir, organizing chairman, Dr. A. Natarajan, sir, organizing secretary, Dr. G. Jayakumar, sir, scientific chairman, and orator of the session, Rama Subramaniam, sir, to come up on the stage.
I have great pleasure and honor in reading out the citation of DCCON 2025. The D Club, under the organizing committee of DCCON 2025, has immense pleasure in honoring the eminent physician, Dr. V. Rama Subramaniam. He is a specialist in infectious diseases, adolescent and adult vaccination, and also in tropical travel medicine. He is head of the Department of Infectious Diseases, HIV, and Tropical Medicine at Apollo Hospitals, Chennai. For delivering Professor V.T. Balaraman oration in DCCON 2025 on Saturday, 12th July at Ramadan Plaza, Gindi, Chennai. Dr. V. Rama is adjunct professor of infectious diseases at Sri Ramachandra Institute of Higher Education Research, Savita Medical College, Apollo Hospitals, Education Research Foundation, and Dr. MGR Medical University, Chennai. Dr. Ramasubramaniam is graduated from Madras Medical College and he did his post-graduation in internal medicine from the prestigious Postgraduate Institute of Medical Education Research, Chandigarh. He is trained in infectious diseases and HIV in United Kingdom and acquired his MRCP, a diploma in tropical medicine and hygiene from London School of Tropical Medicine, and also has received the genitourinary medicine from the Society of Hippocrates, London. He is a chair of the Hospital Infection Control Committee at Apollo Hospitals in India. He has played a pivotal role in establishing the infectious disease as a specialty and being the passion about the judicious antibiotic uses in the practice. It has been instrumental in laying down the principles of infection control and antibiotic stewardship in several hospitals. He is an advisor to the antibiotic stewardship in India and also in ICMR Research Institute. In 2008, he founded the Immune Booster, an adult vaccine clinic to spread awareness on adult vaccination and travel health. Decades later, is just for the common medical practice with a clarity in diagnosis and treatment. He co-founded Capstone Multi-Specialty Clinic in Nungambakkam, which has grown to be one of the topmost premier institute for the outpatient center. The COVID pandemic saw him in amidst of the enormous saving the lives, and while adding the state government to form policies to stem out the outbreak, to sense severe, he served as a director of medical sciences in Capstone Multi-Specialty Clinic, and he has recently founded a Capstone Care Foundation. Among the feathers in his cap, he also spearheaded the Infectious Diseases Educational Foundation and Forum for Adult Immunization towards Health, both in recognition of his meritorious services. Please accept.
Good morning, everybody. It's still morning. It's just about to be 12. First of all, I would like to thank Dr. Natarajan and his excellent team for inviting me for this conference in the first place. I always enjoy coming here. I wish I could spend more time here because I learn a lot. Last time I learned all about MASH, and this time HFrEF and HFpEF. Very, very interesting concepts which I miss. I continued in infectious diseases after my general medicine because I wanted to stay in medicine. So all these still fascinate me, whether it is cardiology or neurology or gastroenterology. The second reason I am extremely privileged to be giving the Professor V.T. Balaraman oration this morning. He was my teacher in Madras Medical College, and he was a quintessential clinician. I still remember the classes he used to take on typhoid. You know, his favorite was typhoid, and his classes were awesome. Even at times when most of us used to jump behind through the window and escape through the classes, we all stayed and listened to his class because it was phenomenal teaching from him. So I'm doubly proud to be here in front of you this morning and to talk about a topic which is very close to my heart. And I'm going to talk to you in the next 25 minutes or so about the approach to antibiotic therapy in 2025. All of us use antibiotics. It is something which all of us need to know, all of us do every day, whether it's heart failure or neurological issues, gastroenterology is secondary, but antibiotic is something, whichever specialty we are in, we continue to use. And we have a phenomenal faith in antibiotics. This is how we feel, whatever the situation, we use antibiotics, the patient will get better. And that was one of the reasons I took infectious diseases as a specialty. We have tremendous faith that if we use the correct antibiotic, whatever the condition, the patient will get better. But it was Maxwell Finland who said over 50 years ago, we know everything about antibiotics, but how much to give. And to add to that, in 2025, we have such a flood of antibiotics. Not only do we not know how much to give, we also don't know what antibiotic to give. Because every day we have a medical executive who comes and propounds the fabulous properties of a new antibiotic which will cure patients and get them all better. So if you are going to look at how we are going to choose an antibiotic in 2025, before we prescribe, there are 3 or 4 questions we need to ask ourselves and get some answers before we write the antibiotic down. The first question is the antibiotic necessary? As I said, we have faith in antibiotics, so when we don't know what the patient has, when the patient comes with a swelling, when the patient comes with an itchy skin, we still use antibiotics because we believe that they will help the patient. So the first question, is it an infection which is caused by a bacteria that you are treating? So ask yourself that question. If you don't have an answer and the patient is stable, don't use an antibiotic. The choice of the antibiotic, what is the most appropriate antibiotic? I will tell you subsequently how you can, to a certain extent, decipher, the choice of the antibiotic. The choice of the regimen, what dose, what route, what frequency, and what duration, that's a little more clear. There are enough evidence to point towards that. And lastly, monitoring the efficacy and adverse reactions. Is the treatment effective? So what do we do if we fail? So these are the questions we have to answer. But before we proceed with the lecture, I'm going to ask some questions which I've asked before also. So some of you may have seen these questions, but I find that this is very, very necessary. What do you think is the correct statement? Let me run through the statements. Once started, not completing the course of the antibiotic leads to resistance. Do you think this is correct? Yeah, it looks correct, but actually it is not correct. Because if you start the antibiotic, and the antibiotic is actually not indicated. Let us say a person comes to you with cough, cold, and fever, and you start the patient on coamoxiclav, and the next day the patient comes to you saying, I did a respiratory panel test and the report has come as influenza A. Would you continue the antibiotic? No, you'll stop the antibiotic because even though you have not completed the course, in that situation the antibiotic is not indicated. So if an antibiotic is not indicated, stop it immediately. It is more harmful to continue the course of an antibiotic which may not be necessary than complete the course, which is what we have been taught all along. Number 2, yellow or green sputum warrants antibiotic. Now you're all becoming wary, is this right or wrong? Because I was told in medical school that if they bring a white sputum, that's virus. If it's yellow or green, antibacterials. No. The yellow or the green color is because of the neutrophils which are in the sputum, and this is caused by the breakdown of the cellular products. It does not, or it need not imply a bacterial infection. So even in viral sinusitis, even in viral upper respiratory infections, you can have this. So don't decide to choose an antibiotic just because he says, "Enakku pacha pachaya chali varudhu." Not necessary. It may be a bacterial infection, but not necessarily. Third, antibiotics are indicated for viral upper respiratory infection as it may lead to bacterial superinfection. I was taught this. This is true, but not always. Viral infections can predispose to secondary bacterial infection. We know very clearly that influenza can lead to a pneumonia, strep pneumonia, or MRSA pneumonia, not necessarily. Again, which means not everybody who has a viral infection needs to be started on antibiotics. Because again, this is all my teaching, which I'm trying to sort of break down the myths. 4, a lower antibiotic dose is indicated for less severe infections to minimize the development of resistance. So if the person is not having a severe infection, giving amoxicillin 250 twice a day. Otherwise 500 3 times a day. 250 twice a day is enough. No. Suboptimal therapy can increase the development of resistance. So if you're using an antibiotic, use the correct dose, use the correct strength, irrespective of what the infection is. Do not compromise on the dose. Okay? Just because we are less sure doesn't mean we need to give a lesser dose. Last question. In renal failure, the patient has a creatinine of 5. No dose modification is indicated for the first dose, even if I'm using amikacin. Correct. You do not modify the first dose of any antibiotic irrespective of renal or liver failure. The first dose of the antibiotic remains the same. Subsequent doses are modified, not the first dose. So the correct statement is the last one. There are several fallacies about antibiotics. The more broader the spectrum, the better it is. If the person you are using an antibiotic on is not responding, change the antibiotic. Again, these are all not necessary. When in doubt, change or add. Sickness requires immediate therapy. This is something which our patients are culturally primed. So if they are not feeling better, they come to you saying, no, I want something now. I want to get better, you know. No, you cannot do anything. If he's having diarrhea, whatever you give, it takes a day or two to shut that unless you plug it with a cork. So you have to dispel your patient's, expectations. Sometimes things take time. A viral fever will last 3 or 4 days. You cannot clear it whatever you use. Response implies diagnosis, bigger disease, newer drugs, antibiotics are non-toxic. A question which is every day asked by a clinician. I'm going to start this patient on antibiotics. I tell them it is not indicated. Is there any harm in using meropenem? Is there any harm in using, quinolones? Maybe not immediately, maybe not that dose, but it does cause problems, which I will tell you subsequently. And antibiotics, remember, are not antipyretics. If a person has fever, give him paracetamol. Don't write an antibiotic in the first go. But why are we bothered about this? So what? If you use, Abraham Woman said, get your blood pressure down to 120. So you throw an extra antihypertensive to bring it under control. So why not we use an extra antibiotic if it may help the patient get better? It is because it is believed by the year 2050, the number one reason for people dying will be the direct effects of antimicrobial resistance. It is believed that 10 million people in the world, out of which about 5 million will be in the Asian subcontinent, will be dying due to the direct effects of antimicrobial resistance. So we need to be careful. But okay, antimicrobial resistance for that patient whom I'm using it on. No. If you look at the principles of resistance, given sufficient time and drug use, resistance is inevitable. It will emerge. Drugs which are brought in today, within a year, you will find that antibiotics become resistant because the bacteria develop mechanisms to resist in spite of the antibiotic presence. Resistance is progressive, evolving from a low level to a high level. So you'll find that 99.5% of salmonella in India are resistant to quinolones. Quinolones was the best antibiotic 25 years ago. Not anymore. Organisms resistant to one drug are likely to develop resistance to others because they share plasmids. So one bacteria can pass the plasmids to another bacteria, and that will cause transfer of resistance. And once resistance appears, it declines slowly, if at all. Cotrimoxazole was not effective for salmonella 25 years ago. Now cotrimoxazole is one of the best drugs for salmonella. I still use it for salmonella because almost 98% of salmonella respond to cotrimoxazole. And lastly, which is the most important point, the use of the antibiotics in one person affects others. And that is the reason why we have to be careful when we write an antibiotic for a patient, because it is not only for that patient, the microbiome of this patient changes when you use an antibiotic. So his fecal matter will contain resistant bacteria which can spread to the community. So please think not once, not twice, at least 3 times before you write an antibiotic to a patient. How does this happen? Normally, bacteria spontaneously mutate. This happens regularly. And if you are exposing the bacteria to drugs, this mutant is selected out by a drug, and this clone multiplies and can be transferred to other bacteria. So that is the reason why we have to think. And there are other factors also which lead to resistance development. There are certain antibiotics which have an increased propensity to cause resistance. Ciprofloxacin has a higher propensity to cause resistance than levofloxacin. Meropenem can have an increased possibility of causing resistance development than imipenem. Gentamicin has an increased propensity when compared to amikacin. So it is the inherent nature of the bacteria which can induce resistance. 2, if you're using antibiotics as prophylaxis, you're exposing the antibiotic to bacteria which may not be required, increases resistance. Suboptimal dose, I told you earlier, when there is a lower dose, it was Friedrich Nietzsche who said, that which does not kill us makes us stronger. So if you expose it to suboptimal dose, it increases. A prolonged course, when the patient gets better, 3 to 5 days, stop the antibiotics. There are very few situations where you have to complete the course. If it's an infective endocarditis, 4 weeks is necessary. Even there, we are now looking at, after 2 weeks, change to an oral antibiotic. There are a lot of studies coming up. Combination therapy, what we refer to as redundant drugs. Meropenem has excellent anti-anaerobic effect. You don't need to combine metronidazole with meropenem. So when you use combinations like that, increases the risk of resistance. And lastly, there is something called as mutant-inducing dose. I'm not able to get it here. So if that is the medicine is given, the Cmax or the maximum concentration, and then declines with time. So the y-axis is the concentration and the x-axis is the time. You'll find that if it is in the green area, the level of the drug is in the green area, everything is excellent. If it is in the gray area, which means it is below the MIC, it is not working. But if it is in the red area where it is actually above the MIC and you expect it to work, but it is at a level which is subtherapeutic. Thank you. It is at a level which is subtherapeutic, and this will induce mutant selection window. So MSW is a mutant selection window. You should have the antibiotic above the mutant prevention concentration. So the antibiotic should be at this level. If it is at this level, it will work, but gradually resistance will develop. Okay? So remember what Charles Bryan said. There are 3 things that are important in medicine. Number 1, diagnosis. Number 2, diagnosis. Number 3, diagnosis. So this is the lesson I want you to take home, that the diagnosis is the most important part of treating a patient, because following that, William Osler said, incorrect diagnosis lead to incorrect treatment. So spend your time, invest the money in getting the diagnosis, because you can treat the patient well. Okay? So with this introduction, I've got only 15 minutes more. I think I took time longer than I anticipated. There are 2 things which I'm going to tell you. One is the microbiological aspects. The other is the pharmacological aspects. Microbiological, I apologize, it's a very busy slide, but just look at these 2. That's enough. If you're looking at gram-positive bacteria, it could be Staphylococcus, Streptococcus, Enterococcus. That's all you need to know, because we are busy practicing physicians. Let's not confuse. If it's gram-negative, we are looking at bacilli, which is of 2 types. Lactose fermenters, which is E. coli, Klebsiella, Enterobacter. Non-lactose fermenters are also known as non-fermenters, Pseudomonas, Stenotrophomonas, Acinetobacter. That's all you need to know. Okay? So this is a very rapid 3-minute tutorial in microbiology. If we are looking at Staphylococcus, the first question is it coagulase negative or coagulase positive? If it is coagulase negative, what is called as cons, which is not Staphylococcus aureus, all the others, Staph hemolyticus, Staph epidermidis, other bacteria, in general, they are harmless commensals. You think of treating it only if it is in the blood and there is a prosthetic material in the body where that may be colonized and infected. Except this Staphylococcus lugdunensis, which is a coagulase negative staph, but can be a nasty fellow like Staphylococcus aureus. So this is the only species you need to worry about. Otherwise, cons, unless it is multiple cultures or there is a foreign body, you can usually ignore. Whereas if it is coagulase positive, which means it's a Staphylococcus aureus, you have to identify whether it is MSSA or MRSA. So if it is resistant to oxacillin or cefoxitin in the culture, it is MRSA. If it is MSSA, cloxacillin, cefazolin, cefalothin, excellent antibiotics. So simple antibiotics will work. Whereas if it is MRSA, you may need to use glycopeptides like vancomycin, teicoplanin, daptomycin, linezolid. Sometimes if it's a community-acquired MRSA, doxycycline, cotrimoxazole, clindamycin may also work. Please remember, vancomycin, which will cover both MSSA and MRSA, is actually inferior to cloxacillin in the treatment of MSSA. So reserve vancomycin only for MRSA, not for MSSA. Okay? 2, Enterococcus. In general, most enterococci are sensitive to penicillin. All Enterococcus are inherently resistant to cephalosporins. 2 main species of Enterococcus, Enterococcus faecalis, Enterococcus faecium. Enterococcus faecalis, generally penicillin sensitive. Enterococcus faecium, generally penicillin resistant. So if it is faecalis, you can use ampicillin, amoxicillin, coamoxiclav, excellent drugs. If it is either resistant to penicillin, which usually happens with Enterococcus faecium, then you have to treat it like an MRSA, vancomycin, daptomycin, linezolid. Okay, I'm not going to go into too much of depth. If there are any questions, you can always contact me later. Streptococci still very, very susceptible to penicillins. So penicillins, ampicillin, coamoxiclav usually will get away with it. But in some situations, if it's a meningitis caused by a streptococcal species, you may need to use a 3rd generation cephalosporin like ceftriaxone. This is all you need to remember with gram-positive organisms. Any questions? Oration? We'll come to that later, so otherwise we'll get stuck. We will finish and then come, sir. If you're looking at gram-negative therapy, there are certain things you need to see. I told you, if it's a gram-negative, it is non-fermenters and fermenters generally. Non-fermenters, Pseudomonas, Acinetobacter, Burkholderia, Steanotrophomonas. If it is Enterobacteriaceae, it's usually E. coli and Klebsiella. There are certain other Enterobacter and of course Serratia, Proteus, Morganella. This is all you need to keep in mind. So what are the drugs of choice? In general, if it is a sensitive gram-negative, 3rd generation cephalosporins, ceftriaxone, ceftazidime, cefoperazone, all that is fine. Sometimes a beta-lactamase is produced. A simple beta-lactamase, I'll give you an example. Staphylococcus produces a beta-lactamase. That is why coamoxiclav, ampicillin won't work. You have to use cloxacillin, okay? But when there is a beta-lactamase produced by the gram-negative, it is usually what is known as extended spectrum beta-lactamase or ESBL. How do you know it is an ESBL producing gram-negative? If it is resistant to any 3rd generation cephalosporin. What are the 3rd generation cephalosporins? Ceftriaxone, cefoperazone, ceftazidime. If it is resistant to any of this, it means it is an ESBL producer, and the only drugs which will be effective for serious infections are carbapenems, which is imipenem, meropenem, ertapenem. Sometimes you can also use cefoperazone sulbactam, piperacillin tazobactam if they are sensitive. Why I am saying if they are sensitive, normally it should work, but sometimes along with ESBL, there is another mechanism called AMP-C. When AMP-C is found, then the beta-lactamase inhibitor combination will not work. So for serious infection, it should be carbapenems. Milder infection, if it is susceptible, cefoperazone sulbactam or piperacillin tazobactam can be used. In general, in our country or state, ESBL producers in E. coli and Klebsiella is as high as 80 to 90%. Which means whenever you get E. coli or Klebsiella, typically in the urine cultures, your 3rd generation cephalosporins will not work. You have to use parenteral agents like BLBLIs or carbapenems. Carbapenem resistant organisms are now being increasingly seen. Examples would be a diabetic foot ulcer, which shows a Klebsiella which is resistant to ertapenem or imipenem or meropenem. We have to go to tigecycline, colistin, fosfomycin. I'm not going to spend much time there. That will come in the inpatient view, not much in the outpatient. And one sort of useful word about salmonella is, lot of microbiology reports for salmonella will show susceptibility to cephalexin or susceptibility to amikacin. Please don't use first generation cephalosporins like cephalexin or aminoglycosides like amikacin for treatment of salmonella. They will not work. You have to use third generation cephalosporins like ceftriaxone, azithromycin. I told you earlier, cotrimoxazole will work very well. Do not use quinolones for salmonella. We also need to understand there are holes in the spectrum. What do you mean by holes? Clindamycin works only for gram-positive. It has absolutely no gram-negative effect. Quinolones has a brilliant spectrum. It covers everything under the sun. But because in India of its extensive use, the susceptibility is close to 10 or 20%. So quinolones without definitive susceptibility do not use. Earlier we used to, if person has urinary tract infections, start ciprofloxacin. No longer. Ciprofloxacin will work only 10 to 20% of times. Do not use ciprofloxacin. If it is an uncomplicated cystitis, nitrofurantoin. If it is complicated in an outpatient where the person has fever, when I say complicated, I mean it is not just in the bladder, it is moved up. It's complicated, one option would be cotrimoxazole, Bactrim or Septran. That's an oral option. Otherwise, you may need to use an IV option. Cephalosporins, first generations are gram-positive, third generation, fourth generation are gram-negative, but if it is an ESBL producer, then none of the cephalosporins will work. Carbapenems, excellent spectrum, still it is now almost the pillar of most treatments, especially in slightly unwell people. And even colistin has a lot of holes. Carbapenems don't work against MRSA. Cephalosporins, most of the ones commercially available will not work except ceftaroline and ceftobiprole, which is very rarely used in India. Colistin will not work against Proteus, Serratia, Providentia, Burkholderia, Brucella. It won't work. So don't think that colistin is ultimate, it will work against everything. No, there are some gram negatives like Serratia, Proteus, Providentia, even Morganella, it will not work. So please keep that in mind. So that's the bit about the pharmacology. Now looking at microbiology. Please remember, microbiology reports are very useful in directed therapy, but they do not differentiate between colonizers and pathogens. A urine culture showing E. coli 10 to the power of 5 may not require treatment unless the person is symptomatic. Unreliable bugs. I told you, there are some bugs, Serratia, Proteus, Providentia, which you cannot assume they are gram negatives, colistin will work. You have to be careful. And if there are sometimes unusual susceptibility patterns. So this has to be kept in mind. And more importantly, it is the interpretation of microbiological reports which is more important. The doctor asked me to spend at least 1 hour a day on the treadmill doesn't mean this. So you need to be careful the timing of the test, both with regard to serology and with regard to the sensitivity. PCR will pick up everything, even the smallest genetic material. So just because your microbiology report shows that there is PCR for E. coli or PCR for Klebsiella in a respiratory secretion, doesn't mean that the person has a pneumonia due to E. coli or Klebsiella. You have to interpret with caution. So having named all this, we have about 5 minutes more. The syndromic approach is what you have to use to select antibiotics. So the first question you ask a person who's come to you with fever is it a pneumonia syndrome? Is it a skin and soft tissue infection syndrome? Is it an intra-abdominal infection syndrome, UTI, meningo? You need to classify what syndrome he is likely to have based on the presentation. So if it's a pneumonia syndrome, when I say pneumonia, I mean pulmonary infiltrates. I'm not talking about cough, cold, and fever. That is usually viral. If he has a bronchial breath sounds, if he has an infiltrate, commonest is 6 organisms. Strep pneumoniae, H. influenzae, Moraxella catarrhalis, 3 bacteria, Chlamydia, Legionella, Mycoplasma, 3 atypical organisms. I repeat, Strep pneumoniae, H. influenzae, Moraxella catarrhalis, Chlamydia, Mycoplasma, Legionella. So almost 70 to 80% of pneumonias are generally caused by this in a community-acquired situation, which means you need to use either coamoxiclav or a cephalosporins. You don't need to use routinely meropenem, imipenem. Only if it's a diabetic who's been exposed to antibiotics before, immunocompromised, patient with a bronchiectasis, then you need to think of gram negatives. Otherwise, you don't need to think of gram negatives at all. If it's a urinary infection, it is usually a coliform, E. coli, Klebsiella, like that. So if it is meningoencephalitis, I need to cover only with third generation cephalosporin, with or without vancomycin. If there is a possibility, it is a resistant streptococcus, and doxycycline, which may cover for other other bacteria. So, but remember, you also need to keep in mind the susceptibility patterns. Just the bug is not enough. What is the local susceptibility? What IDSA in America says will work? They say use quinolones for pyelonephritis. In India, pyelonephritis, none of quinolones will not work. There are 2 or 3 caveats. Do not treat asymptomatic bacteriuria. Do not routinely treat bugs in the sputum, because they will show a lot of bacteria. Significant, heavy growth doesn't mean that they are causing the problem. And similarly, cutaneous ulcers, they will show bacteria. Do not routinely treat it. So please remember, just because the microbiology report says there is growth of bacteria doesn't warrant antibiotics. This is what I said. Nietzsche, who said, that which does not kill us makes us stronger. So if you're using an antibiotic, choose the right antibiotic, use the correct dose. Don't compromise on that. The last 2 or 3 slides, this I told you. I think I will skip this. It's basically, this is what matters with aminoglycosides. So aminoglycosides currently recommended as once-a-day therapy. Please remember, only if it is an infective endocarditis, you may need to give split doses. Otherwise, calculate the full dose for a day, use it once a day. So gentamicin 300 milligrams, 400 milligrams once a day. Amikacin 1 gram IV once a day is all recommended. Whereas we are now giving beta-lactams like meropenem and penicillin as an extended infusion to keep it above the MIC. So meropenem we give as a 4-hour infusion. Imipenem as a 3-hour infusion. The newer drug ceftazidime, avibactam, we are giving as a 2.5, 3-hour infusion. So we are giving it as an extended infusion because it has to be kept consistently above the MICs. These are modifying the administration to make it work better. Lastly, what is the role of prophylaxis? This is what we all think. I took the medicine at 6 p.m. instead of 9 p.m. because I want to surprise the bacteria. You think by giving a prophylaxis, you prevent infections. No, you don't. There are very selected indications for prophylaxis. Why do you give surgical prophylaxis? Before major surgery, you give antibiotics because the chlorhexidine, the iodine will take care of all the bugs on the skin. But there are bugs sitting here inside the hair follicles and the glands, which even when you incise can go in and cause problems. So the antibiotic is given to prevent surgical site infection. It doesn't prevent pneumonia, it doesn't prevent UTI, no. It's probably going to delay and cause a resistant bug to cause the infection. So only in selected individuals, immunocompromised in PCP prophylaxis in HIV patients, post-exposure rabies or chickenpox prophylaxis, endocarditis and traumatic injuries, do not routinely use prophylaxis in patients in the ICU just because they have a line, they've got a catheter, they've got a ventilator. No role. Lastly, I may take 1 more minute, I please crave your indulgence. Other issues, the site of the infection is important because it may be a sensitive bug which works with an antibiotic, but if the antibiotic does not reach that area, a simple example, meningitis caused by strep pneumoniae, it may be sensitive to, say, first generation cephalosporin, but first generation cephalosporins do not cross the blood-brain barrier. You need to use ceftriaxone. So keep that in mind. Combination therapy, as I said, if you have a single drug which will take care, use a single drug. Do not combine. Combination therapy has very, 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 very limited role. If you are using certain kinds of endocarditis, yes. Otherwise, no. Duration, the lesser the better, except pyelonephritis, minimum 7 to 10 days. So do not shorten that. Endocarditis, osteomyelitis, liver abscess, empyema, longer course. Otherwise, short course. Sequencing means stopping the IV and changing over to oral. There are antibiotics which have very good oral availability. All the quinolones, linezolid, doxycycline, clindamycin, they reach very good oral dosing. So if you are able to, patient is better, hemodynamically stable, change over to an oral equivalent. Patient characteristics, drugs clearance, so renal failure, liver failure, pregnancy, all that. And this role of bactericidal and bacteriostatic is no longer used, except for 2 or 3 high inoculum infections, meningitis, endocarditis, and probably febrile neutropenia. These are the only 3 situations where you think of using a bactericidal antibiotic. Otherwise, you can use a bacteriostatic also without any compromise. So lastly, the take-home message is, This is our expectation from antibiotics. We think antibiotics can work miracles, but unfortunately, it doesn't. So please use your efforts wisely. Spend your time, spend the money in diagnosing the patient before you start using parenteral antibiotics. Oral at least is acceptable. Parenteral, do not, even if it is delayed, get a culture, send the necessary tests before you use the antibiotic. Thank you very much.
My question is, no question.
Sir, I'll answer the question directly, don't worry. Thank you.
Thank you, sir. Now we move on to the next session. I welcome Chairperson Dr. M. Swamikannu sir and Dr. A. Natarajan sir on the dais.
I think we had a very interesting session from the morning, and now we will go to the very important topic on obesity. I think obesity is no longer considered as a disorder, it is considered to be a disease because it leads to multiple comorbid conditions like hypertension, diabetes, and OSC, so forth and so on. So to talk about on this important topic, we have Professor Dr. S. Venkatraman, who needs no introduction to Chennai probably, in the nationwide. So I know him for nearly 30 years now. And I'm not going to read out all the things that is written on the thing. So I straight away call him upon. Before we going to the topic, we recently started on Nalam program. We have a how to lose weight without any problem. Lose it right and lose it safe. So he's going to tell us all about obesity, and we'll learn from him how to lose it safe and right. I call upon Dr. Venkatraman.
Slide changer. Oh, you don't have, don't bother, it's okay. So good afternoon. Thank you once again, Dr. Natarajan, Dhanmitran, and my friends. Before I proceed on to the topic, a quick thought. I think right from the morning, we have seen the agenda. The agenda was catering to the day-to-day relevant clinical entities for a practitioner. And before going to the topic per se, maybe in a lighter vein. So we had a lot of topics. We had a lot of good speakers. I think the selection of the speakers were based upon their credentials. I think this particular topic, Dr. Dhanmitra Nuts and Co. did have an issue whether we should give importance to the credentials, academic credentials, or to the phenotype of the person. So they chose, they'll give a lot of importance to the phenotype, and that's why I'm here. So thank you so much. Before I go on to talk about this molecule in the context of obesity, for which I have been contracted by Eli Lilly about the newly introduced tirzepatide in surmounting obesity, that is the topic. A few aspects about obesity. I think as Chairperson Professor Swamikanda nicely pointed out. Again, coming back to the agenda of today's program, there are a lot of topics. You have hypertension, diabetes, heart failure, dyslipidemia, etc., which are very relevant, very highly prevalent in the population. What about obesity? Is obesity a huge problem in our country, or is it a problem of the West? I'm sure all of us are aware of it, but if you just link with our academics and then the teaching that we have had in our undergraduate and postgraduate days, I think the things have changed now. I think as Dr. Abraham Oman pointed out, in the ICMR INDIAB study, prevalence of diabetes was 101 million, whereas prevalence of general obesity was 250 million, and central adiposity was 350 million, which means general obesity is 2.5 times more than diabetes, and central adiposity is 3.5 times more than diabetes. So obesity is a huge problem in the context of any scientific deliberations occurring in this part of the country. That's number one. Number two, why is obesity important? Is it from the cosmetic or aesthetic point of view? It is associated with diseases, yes. The disease association is so much that when you take an obese population, 20% of them will be diabetics, 50% will be hypertensive, 20% will have myocardial infarction, 10% will have PCOD, 1/3 will have metabolism-associated state of hepatitis. So obesity has a huge association by way of percentage with respect to the various disease entities which you and I are facing in our day-to-day clinical practice. So that's the second point. Third point, is it the quantum of obesity that's important or obesity per se? We always used to see a patient with a BMI of say around 35 equivalent to 30 with somebody who has got a BMI of 38. The answer is no. Both of them might have a lot of mechanical problems like obstructive sleep apnea, osteoarthritis, etc., but most of the disease entities are related to the magnitude of obesity. Obesity class 1, class 2, class 3, especially your steatohepatitis and some of the diseases like heart failure probably. So obesity is huge in our population. Lot of disease entities are associated with obesity. The magnitude of obesity, I think nowadays we use adiposopathy as an entity, and then that leads to obesity, a disease. And this association assumes a lot of significance, a lot of strength in the causality. Of course, with respect to causality, we are not discussing. All of us know the various mechanisms as to how they predispose to these diseases. The quantum of obesity is associated. So far, it's good. I think it's there in the literature. Now, you say that nowadays, whenever we talk about obesity, we always used to say, you're obese, you need to lose your weight. In fact, we all used to have a tentative attitude towards weight reduction. I'll give an example. Somebody is about, say, 170 centimeters height. His ideal body weight, if you calculate approximately, maybe about 66, 67 to 72, if you have 5% this, percent that. If this patient is 95 kgs, you know that he needs to lose probably to the tune of about 20 kgs, which was a nightmare for us. Is it possible, excepting bariatric surgery? No, it was not possible. So, in the absence of molecules, even though we know the association, and of late we have realized the magnitude of association is important, and we know the urge to interfere, do you have the avenues to interfere excepting reinforce the patient for a lifestyle modification? Lifestyle modification has got its own limitations. Why? Again, coming back to the same example. Somebody who is about 170 centimeters, he has to be 65 kg. You just prescribe a diet of 1,400 calories or 1,500. Previously he was taking 2,000 calories. You put him on to 1,400 calories. You think that this 500 and 600 calorie that I am going to reduce in him, if he follows meticulously, that's always a caveat like that, if he follows meticulously, should translate into a negative benefit of about 500 calories every day, which will be 500 into 30 will be 15,000 calories. Maybe he can lose about 2 kgs in 1 month. No, it doesn't happen for the simple reason the body reacts. See, many of the diseases in the body or the manifestation of the disease are because of what we call it as a maladaptation, but for the organism, for the system, for the CNS, it's an adaptation. See, your body weight is say about 65 kg for about a long time, for about 10 years. Your homeostatic, it is set up in such a way, even if he consumes 1,800 calories are spent so that he maintains 65. Over a period of time, you gradually increase it to 85 kgs. At that time, even if he takes 1,600 calories, he spends 1,600 so that it is reset. So the homeostatic reset with respect to the energy consumption and the energy expenditure is the same. On top of it, what you have got is the hedonic component, the pleasure of eating. So you finish your lunch, your relative comes to you with a good son papadi from Srimathai, unable to resist. You know that. We know as doctors it's 250 calories, 350 calories, 400. So that pleasure of eating, so that's a huge, huge component, and eating itself is a behavioral aspect. Now coming back to the system's adaptation, what the system does. The system reduces the expenditure. So whenever there's an attempt by the individual to restrict his diet, the intake of calories, the energy expenditure, inherent energy expenditure comes down to the tune of 30-40%, so that sincere attempts by the patient and prescribed by the clinician or the dietitian are not always, if not quite often, not associated with an anticipated weight loss because of this mechanism, number one. Number two, when you reduce the intake or reduce the calories, all the hormones like your ghrelin, which are important for stimulating the appetite, are stimulated. So we are in an era wherein we know the association of obesity, we know the degree of obesity which has to be interfered, and then we know the amount of weight loss that you need to achieve. To give an example, if you achieve 5 to 10% weight loss, you have a favorable effect on, say, hyperglycemia and hypertension. 5 to 10% in pre-diabetic, you can prevent diabetes. And you can modify non-alcoholic fatty liver disease. When you talk about NASH or MASH, that is metabolism associated, there are stages. Initially, it is fatty acid infiltration of hepatocytes. It is NAFLD, non-alcoholic fatty liver disease. Then when it persists for a long time, there is certain amount of steatosis and steatohepatitis, and lastly, it goes on to fibrosis. So 5 to 10% weight loss not only has an effect on preventing diabetes, it has an effect on reversing or correcting the NAFLD. When you achieve a weight loss of 15 to 20%, you're able to prevent or reverse diabetes, remit diabetes, possibly have a tangible effect on the steatohepatitis, on the cardiovascular disease. When it is more than 20%, you are able to have a sustained remission of diabetes or reversal of diabetes, which has been proved also, and also in other disease entities like fibrosis. Now, these numbers are quite fascinating for a theoretical discussion. 5% weight reduction, 10% weight reduction, 15% weight reduction, 20% weight reduction. So in the context of 250 million obese diabetics in the Indian context, in the context of so many diseases that we are seeing in day in and day out, in the evidence in the literature that good amount of weight reduction is associated with benefits, is it a theoretical exercise that we are talking about, or is it possible? Now it is possible. So because of the reasons that there are limited opportunities, of course, lifestyle modification absolutely essential whenever we talk about metabolic diseases, including obesity, but by itself it is not adequate for the reasons that we have said. So we depend upon molecules, and fortunately, a couple of molecules are available and which have been recommended for obesity, which have a tangible effect on obesity. And again, I thank Eli Lilly for contracting me to do this portion of my talk, which is going to be on tirzepatide for the weight reduction, various. So I have been contracted, and I have also been contracted by the many players in the industry who market and then sell anti-diabetic drugs both in the oral as well as the injectable space. Now, when we talked about the weight reduction, at least in the context of the diabetic population, what we had was a GLP-1 receptor agonism. Why the GLP-1 receptor agonism was given a lot of importance and not the GIP initially? We know that the incretin axis is sluggish in the diabetic population. Both the GLP as well as the GIP are. Now, once you bring down the blood sugar level with the GLP mechanism, that's what has been attempted. So, even in the presence of a sluggish inherent endogenous insulin response, GLP agonism has been associated with good benefits from the metabolic and other aspects which we'll discuss. So, the initial response with the GLP-1 agonism and then probably relative sluggishness in the early part of the disease of hyperglycemia when the blood sugar is very high, lack of that sort of an anticipated response from the GIP made the researchers and the industry cling on to the GLP-1 receptor-based therapy. That's why we had exenatide twice a day, liraglutide once a day, and dulaglutide once a week, and now we have sema once a week, both for diabetes and in a different dose for obesity. So, GIP was not studied for a long time for the simple reason that initial part of the disease, when the hyperglycemia is there, probably the GIP agonism may not work. But when you have the initial taking care of your diabetes, then GIP works probably much more. It enhances the effect of the GLP-1. How does it do? As you will see here, when you talk about the GLP-1 activity, what we are all aware of is what is happening in the pancreas. Substrate-mediated insulin secretion and then substrate-dependent glucagon suppression. But the GLP-1 receptors are ubiquitous in the central nervous system as well as in the stomach, so that we do have an effect on the satiety. It's a complex discussion. It involves the brainstem, the hypothalamus, the mesolimbic system, the various connection pathways, the vagal afferents, and then the various neurotransmitters. For example, GLP-1 probably is the neurotransmitter of significance is the glutamate. We call them as glutamatergic neurons. Whereas when it comes to GIP, it potentiates the effect of what the GLP-1 does in the central nervous system and in the stomach, and of course in the pancreas, and then it has got an additional effect on the adipose tissue. I think this is one thing which is an amazing aspect which we have realized. So, in the chronology of interventions for the obesity, you had various molecules. The successful molecules, at least in the context of diabetes, are the GLP-1 based therapy. The GLP-1 receptors are ubiquitous. You target them, you target the hunger center, the satiety center, probably the expenditure as well. You have a weight loss. You always modulate the GI motility as well. And then you have this combination of an agonism of the GLP-1 as well as the GIP, which takes part in amplifying the effects of the GLP-1, and also it has got an independent effect on the adipose tissue. What is this independent effect? The independent effect is it increases the blood supply to the adipose tissue, it stimulates the lipoprotein lipase, so that in the postprandial period, when the nutrients are there, nutrient-stimulated GIP is able to trap the nutrients and then partition them in the tissue where it is supposed to. That is adipose tissue, and then modulate the metabolism in such a way that probably is not much understood. Only speculations are there. My own speculation is, it's my speculation, that since GIP is involved, probably the glucagon is there at some stage that is responsible for burning the free fatty acids. So even though it is lipogenic in the postprandial period, the post-absorptive as well as the fasting period, which occupies a huge space in anybody, the combustion of the nutrients, the metabolism of the nutrients is in such a way that, number one, there is no ectopic deposition of the fat to the other tissues. So the fatty liver is reduced, probably your other disease entities which are related to the ectopic deposition of fat will be reduced. And there is also a theoretical entity. Since I see the professors here, I can make this theoretical point. There is also a suggestion that there is an entity called, what I forgot, the metabolism will be on, but it will be a negative, or the yield will be less. I'll give an example. You talk about glycolysis. You start with glucose, pyruvate. Pyruvate enters the TCA cycle, goes to the mitochondria, even the TCA and mitochondria, oxidative phosphorylation, so that you have one molecule of glucose yielding 36 ATPs. Now, you have the other pathway called gluconeogenesis. So you start with glucose, go up to pyruvate. This pyruvate can generate, recycle to produce glucose, gluconeogenesis. So imagine a situation when these two pathways are running concurrently, then you have both the pathways, you have the utilization of substrates, but the energy is zero. One equivalent will be what is happening in the Cori cycle or a rapidly dividing sarcoma. So when you have a rapidly dividing sarcoma, the blood circulation is less. So the glucose that is oxidized is converted to pyruvate. Pyruvate gets converted to lactate. Lactate goes back to, so you have a negative energy balance. That's why one of the reasons for the weight loss associated with a rapidly dividing sarcoma. What I'm trying to say is, when you have a GIP agonism, you have the additional advantage. This additional advantage is in the adipose tissue. Initially, it looks like an adipogenesis, but what it means is a favorable metabolism of the nutrients stored in the adipose tissue and metabolized, and preventing the ectopic deposition. And of course, it has got a pro-inflammatory effect like your GLP-1. So we are going to discuss in some detail about the data that is being available, a healthy data, very relevant data, which is for the obese population, and this population is not a small number in our country, and the association of the diseases we have visited just now. So this is what I was trying to say. The GIP action of the adipose tissue has been shown to increase adipose tissue blood flow, the lipoprotein lipase, etc., etc. And when glucagon levels are low, GIP promotes glucagon secretion from the alpha cells. So this is what I have been harping on. So initially, when the molecule was discussed, probably this was one aspect that was probably, in my opinion, it should be highlighted. Because you have adipogenesis in the postprandial period, and there is no gain in the body weight. On the other hand, the substrate is being better utilized. So how does it happen? The fatty acid oxidation is increased, the insulin sensitivity is increased. So the insulin sensitivity is increased probably because of the better metabolism of the nutrients that are trapped in the postprandial period, and this is facilitated by the GIP. So a combined agonism of a GLP-1 and GIP, and with a molecule tirzepatide which has got a structural analogy to GIP, which has got an affinity for the GIP receptors much more than the GLP-1 receptor, is able to translate into, in the context of today's topic, result in a good amount of weight loss by acting on the satiety center, probably increasing the expenditure, modulating the GI motility as well, and also possibly it is expected to have a favorable effect on the nausea, because you have anti-aversive neurons in the brainstem and the GIP receptors are there. So what it means is, when you have a good dose of a GLP-1, you always have certain amount of nausea, which is which has to be adjusted over a period of time, and many patients do that. To an extent, GIP theoretically can do something for it because it acts specifically on the anti-aversive center. So, yes, synergistic effect with GLP-1, an independent effect on the adipose tissue, and possibly to tolerate the effects of the GLP-1, it does something at the central level. So this is our understanding about this molecule today. So it has got a single molecule, yes, all of us know about it, both the GIP and the GLP-1 receptors. So Mounjaro is the trade name, since it is a talk which has been sponsored by Eli Lilly. I don't have any hesitation in talking about it. So it's a dual agonism of the GLP-1 as well as the GIP. Now, this has been studied in the population which has been termed as surmount. So that's why the topic was surmounting obesity with tirzepatide, that is Mounjaro. So you have the surmount 1, surmount 2, 3, and 4. I mean, in the various population, the 1 to 4 have been a double-blind study, the last one in comparison with semaglutide. This becomes interesting because sema is one of the molecules in the contemporary medical practice wherein it is recommended. It has got its own data which are highly impressive. Let us see how do they compare. The questions that will be asked are, number one, what is the dose of these molecules that are effective? Effective means weight reduction. What is the amount of weight loss that we are going to witness once you use these molecules? What will be the side effects? Will the side effects be comparable? And more importantly, supposing I have a patient who has been on few weeks of Mounjaro, either you discontinue for various reasons or he, because of the compliance issue, he stops. Will the benefit accrued out of the limited period continue for an extended period or not? I think these are questions which will be answered in the next 5 to 10 minutes, and I hope to finish another 10 minutes. So let us talk about the first trial in great detail. It's very impressive. This is a placebo-controlled double-blind trial in about 120 centers in 9 countries. Huge number, 2,500 subjects. Subjects were started, obese subjects, BMI more than 30 or BMI more than 27 with one comorbid condition, excepting diabetes, excepting in SURMOUNT-2 wherein diabetes was included. Otherwise, it will be hypertension, dyslipidemia, osteoarthritis, etc., etc. They have been titrated with 2.5 milligram and with monthly intervals of 2.5, 5, 7.5, etc. So that we have 4 arms. One is the placebo, the other is 3 dosage types of 5 milligram, 10 milligram, 15 milligram, and then the primary endpoint is the weight reduction at the end of 72 weeks. So as you will see here, from the baseline, we started with a body weight of 105 kgs. Look at it. At the end of 72 weeks, a dosage of 5 milligram is able to achieve a weight loss of 16%. Now, coming back to the initial discussion, we talked about 5 to 10%, 10 to 15%, 15 to 20%. So whatever we want to achieve, whatever the clinician's anticipation is there, a molecule is there to address you. I mean, which class of patients you identify and then start them on, that is purely our discretion. But the science is there. This is with respect to 5 milligram. If you go to 20 to 25 milligram, 15 and 20, 10 and 15 milligram, you have the additional. So extrapolation of data are, now, if you look at the molecule, obese population, we have been started on this molecule, probably the weight loss starts appearing as early as 4 to 8 weeks. It occurs throughout maybe about around 60 to 64 weeks, then it plateaus down. A dose as small as 5 milligram is associated with a huge 16% weight loss. Additional weight loss are associated with further increases in the doses, and then probably one needs to administer them and continue them. The plateau effect is seen probably at the end of about 60 to 64 weeks. Now, when we talk about the quantum of weight reduction, which I have always been insisting, till recently, when even the oral sema was used in the diabetic context, we always used to talk about the 5% weight loss. We thought achieving a 5% weight loss, yes, it is. Achieving a 5% weight loss is really a difficult issue. Now, look at the 5% weight loss. Almost all the subjects in the trial had, almost all, it's about 96%. Almost 100% subjects had 5% weight loss. And look at it, 90% in the 15 milligram dose had a weight loss of 10%, 15%. And now you're going to talk about 20% weight loss, which means in the context of diabetes, prevention of diabetes, in the context of fibrosis, preventing fibrosis, reversing fibrosis, in the context of CV mortality, heart failure, etc., you are able to, from the point of view of adiposity intervention, from the point of intervention with respect to the inflammation, and also probably the inflammatory component is independent of obesity as well, which we will not discuss now. So if you look at the various percentage of weight loss, the impressive results are there, and one can achieve to the tune of about, say, 20% weight loss in about good number of subjects, as you will see here. 50% of subjects cross the 20% weight loss. I think this is something which is amazing, How far it is translatable to in our population, let us see. Let's wait and see. At least the data are so impressive that it warrants a serious positioning in the day-to-day practice of the management of obesity. So 8 out of 10 achieved 15%, 2 out of 3 achieved about 20% weight loss, which is amazing. Changes the body composition, reassuring, but still, whenever you have huge weight loss or any weight loss, there is bound to be an element of lean body mass loss as well. Anticipate this, enhance the protein intake, protein supplementation, and then strengthening exercises. But it is reassuring that a good chunk of the tissue that is lost is in the adipose tissue compartment, and these are the modifiable risk factors which are also equally addressed in this population of obesity with or without one additional risk factor. The numbers are here for us to realize ourselves, the systolic, diastolic BP, and then the various metrics of lipid parameters which matter to us. Now we are interested in this question. There is yet another molecule, SEMA, which has been approved, which is good. The data is available, so impressive. How does this molecule compare to semaglutide in the same titrating dose? Here what has happened is the maximal tolerated dose of 10 or 15 milligram of tirzepatide has been compared with 1.7 or 2.4 milligram of sema. Let us see the response. Again, the same pattern, the weight reduction is seen as early. You see the plateau around 60 to 40 weeks. But if you look at the number, look at the superior body weight reduction with tirzepatide compared to sema. It's not a weaker molecule. This is able to achieve a weight reduction of about 15% in the graded doses, and the trial results are impressive. It is able to score over. Tirzepatide scores over sema, and then these are the other aspects. More than 10%, 15%, 25%, more than 1/3 of the subjects in the tirzepatide arm had more than 25% of the weight loss. And then we know the compartment of obesity that's being targeted, especially the visceral adiposity, you have a difference in the waist circumference with both the molecules, and certainly a superior weight reduction with tirzepatide. What happens? I think this is one of the important trials which gives a lot of message to the clinicians. You start somebody on tirzepatide, you give them for some time, and then you discontinue or the patient discontinues. So here, there's a lead-in period of about 36 weeks, dose up-titrated, and then there's a placebo arm, and then the maximum tolerated dose is continued for the rest of the time duration of about total period of 82 weeks. So here, when the lead-in period, you had a weight loss of about 21%, close to 21%. If you continue, you have a further 5% weight loss. But if you are going to discontinue, you regain to the tune of about 12% of the weight loss that you have achieved, so that it is only 9.5%. So the beneficial effect is seen early. It is continued. Durability, the plateau effect is seen after 1 year, and then it has to be continued. If you discontinue in the middle, then the answers are here. Side effects, we are all aware about the incretin-based therapy, especially in the parental form. The GI side effects are predominant. And then GI side effect resulting in discontinuation of therapy, a small number is there. So these are again the trials in the SURMOUNT-5, wherein Mounjaro has been compared with semaglutide. These are the results. I would have expected the nausea to be slightly better, maybe with our own experience, because given the theoretical reasoning, it has to be better, but these results are not showing it. Now, the adverse reactions in the tirzepatide trial, sema versus thing, you can see for yourself, most of them are comparable. Some of them, maybe one of the two molecules has a higher. Now, this is a slide I want to spend some time on. Now, the GI side effects are much more known when you escalate the dose. Now, SURMOUNT-4 gives an opportunity to study patients who have been in the placebo after the lead-in period. Now, when you are in the lead-in period with the dose escalation, the GI side effects are more. When you are on the double-blind period compared to the placebo, the same dose, look at the side effects. The message is very clear. Of course, the company comes with a statement saying that at the dose escalation, the side effects are more. They are self-limiting, stay put at the dose. The answer is given here. You stay put to the same dose, look at the side effects, at least the parameters that are available for comparison, they are so favorable with respect to your nausea and diarrhea. So, dose escalation has to be gradual. Associated side effects, especially the second, third, or fourth day after the dose escalation, maybe after 5 or 7.5, may not be with 2.5. Persist with the dose, persuade the patient, and then if it is very severe, of course, go back to the previous dose which was tolerated, and if it is going to the maximal tolerated dose, still the benefits will be there, as we have seen. So, friends, I have slightly, as usual, exceeded only by about 3 or 4 minutes. I hope my chairperson, Professor Swamikandan, and Dr. Dans, they do not mind that. So we started with the initial introduction of obesity, how obesity is important in the Indian context. The association with the various diseases which matter to us clinically. More importantly, we are in an era, we are not talking about just your general adiposity. We are talking about the magnitude or the quantum of obesity which is associated with the diseases. And then more importantly, how the reversal is able to have a favorable effect. And this is not a theoretical exercise. Options are available. We saw the limitations of the lifestyle modification, which is absolutely essential for all our patients, but because of the various adaptive mechanisms, we are not able to see the anticipated results. So we have to depend upon the molecules. Today, we just talked about the intervention with one molecule, the tirzepatide, in the obese population. We saw the results for ourselves. The results are amazing. Doses 5 milligram as low can produce a 16% weight loss, and we are going to talk about something like a 25% weight loss, and an interesting comparison with a SEMA, again a molecule which has got wonderful results backed up by the data, and the comparison was there. And it is heartening to realize that when you stay to the particular tolerated dose, then possibly the GI side effects die down over a period of time, so that you're able to reap the benefits of this type of intervention in our obese population. And then it is up to us to see much more data or in the offing, and it's an anticipation that we are something doing good to the population. Thank you so much.
Thank you very much, sir. I like the title of your topic, Surmounting the Obesity. My first patient had a lot of GI symptoms, but I just managed symptomatically. When I finished the 4th dose, she has lost 10 kgs in 4 doses. So I think it has got a good property, but the GI symptoms, how do you handle this GI symptoms?
Fortunately, I think most of my patients have not crossed the 5 milligram dose because I started very late. So so far I have not had, in fact, I've had an interesting experience which I shared with the industry as well. One of the patients who was on 5 milligram, he saw as you described also, he has lost about 4 to 5 kgs. He wanted to jump from 7.5 to 10. But I gave a prescription of 7.5. What I'm trying to say, if they are motivated, especially knowledgeable, affordable patients, if they are motivated, I think that is the best solution to this. I have not had the side effects. If the side effects in a particular dose are going to be too huge, then it's better to go back to the dose. For example, if 7.5 was tolerated better, and then when you switch over to 10, if the side effects are more, stay put on 7.5 some more time, and then let us take a longer time to step back to the 10 milligram dose, another 4 to 8 weeks. That will be my approach. I think that's what the recommendation is as well.
Just about the one question about Surmount Trial 5. Was the cardiovascular benefits comparison is there between semaglutide?
No, I think regarding the tirzepatide, the cardiovascular data are not yet available for us, so we wouldn't be able to discuss about that.
Thank you very much, sir, for the wonderful talk, and I don't think anybody would have made justification like you. Thank you very much.
Thank you all.
Speak on the topic, interpretation of CBC in clinical practice. Over to you, madam.
Good afternoon to all. I thank the organizers for giving me this opportunity. The topic is complete blood count in clinical practice. So I thought before we go to the complete blood count, since we are talking about its application in practice, the first thing would be to get a detailed history and a thorough physical examination. I have just listed out the important points which you should ask for in any patient for whom you are ordering a CBC. So ask for history of symptoms of anemia, fever, bleeding, history of jaundice, because if you have hemolytic anemia in mind, you have to keep in mind jaundice, joint swelling, pain to rule out rheumatological disorders, skin rashes also. Past history of transfusion is very patient has had recurrent transfusions, you would be thinking of a hemolytic anemia or a chronic marrow disorder like aplastic anemia, myelodysplastic syndrome. Loss of weight and appetite, especially if it is more than 6 kg in the last 6 months, you think of something more serious like a lymphoma, which may not have any other symptoms. Family history of malignancy, occupational exposure. In a female, menstrual history and history of abortions. Drug exposure is also important because there are some drugs which can produce anemia, thrombocytopenia. So history of drug exposure, and if you stop the drug, the whole thing improves. So a thorough history, physical examination particularly looking for lymphadenopathy and hepatosplenomegaly. So with that, we go to the disorders. The CBC is a very important tool, as we all know. It gives us an idea of the RBC, WBC and platelets in the patient's circulation. So first, coming to RBC disorders, the common one is anemia. So if the hemoglobin is less than 13 grams in a male and less than 12 in a female, you think of anemia. You know the prevalence is very high, more than 50%. In men, it is around 25%. So the first investigation we order will be a CBC. So we classified it as initial evaluation and further evaluation. So initial evaluation, which you should do in any anemic patient, is a CBC, peripheral smear examination and a reticulocyte count. Whatever is missed in the CBC will be obvious in the peripheral smear, and reticulocyte count will tell us whether the marrow is functioning normally or not. So if you have a normal retic count or a high retic count, you know that the marrow is functioning normally and is trying to compensate for whatever loss, whether it is blood loss or whether it is RBC destruction due to hemolysis. Further evaluation will be based on the values that we get from these first 3 investigations, so particularly based on the MCV and the reticulocyte count. So as we all, I thought I'll just put up this one normal CBC report, so that when you see the report given to you by the patient, just have a glance at everything. The WBC count, always keep in mind whether it is a single cell disorder or more than one cell line is involved. So if the WBC is okay, hemoglobin is okay, and the platelets. So that will be the first glance. Then if the patient is anemic, you have to see the RBC indices, which is MCV, MCH, MCHC, and RDW. RDW just tells you the difference in size of the RBCs, whether they are all uniformly small, uniformly normal in size, or there is variation in size. Then you have the differential. So the differential is also very important. One point that I would like to mention here is when you see the total count and if it is normal, always have a look at the differential also. Because in an adult, you should have a neutrophilic dominance. If you have an increase in the lymphocyte, even if the total count is normal, it could be something more than just a viral infection. Very often it is a viral infection, but it could be a malignancy, which like CLL or some chronic lymphoproliferative disorder. So always have a look at the DC. And there is one last thing which is not very clear here, that is the immature granulocyte, which is given in some counter strips. And if that is more than 2%, then you know that the patient has got some active infection. So based on if the patient is anemic, you classify it as normal retic or high retic. So if the retic is normal or reduced, then you decide whether it's a microcytic anemia, normocytic, or a macrocytic. If it is microcytic, there are just 3 or 4 things that you should keep in mind. Iron deficiency anemia, thalassemia trait, anemia of chronic disease, and sideroblastic anemia. Why this thalassemia trait is important is, particularly when we are seeing antenatal patients, you will find that thalassemia trait has no symptoms. They are not anemic very severely like a thalassemia major. They don't have hepatosplenomegaly. They are not transfusion dependent. So these patients you have to identify only by looking at the CBC. And it's important that if the mother is carrying the gene, then you have to work up the husband and see if he is also carrying the gene, then we'll have to do antenatal diagnosis for the baby. So especially when the first trimester, when the mother comes in, this should be kept in mind. So with the initial indices I told you, I just thought I will highlight the differences between iron deficiency and thalassemia trait. We know thal trait is a genetic disorder. Here the RBC count is usually normal. HB is around, they are not very severely anemic. It is usually 9 to 10, 10.5. But what we should remember is the RBC count does not proportionately reduce. So RBC will be normal, but hemoglobin is low and MCV is grossly low. RDW is normal because all the cells are uniformly small. So what we have to remember is the rule of 3. Normally RBC count into 3 will be the hemoglobin. If that rule is not conformed to, then you think of a thalassemia trait. Here it is 5, into 3 should be 15, but the patient is anemic, so we know there's something wrong. Similarly, hemoglobin into 3 should be the packed cell volume or the hematocrit. So when you have a disproportionate microcytosis with mild to moderate anemia, you ask for a HB electrophoresis, and if the A2 is more than 2.5%, then we know that it is a thalassemia trait. In iron deficiency, if you see, the RBC is proportionately reduced, hemoglobin is also reduced, MCV. RDW is high because you may have some normal cells, you may have some small cells. So RDW increase indicates a iron deficiency anemia. HB electrophoresis, just one important point. If the patient has had a recent transfusion, it will not give you the right picture. So you will have to repeat it after 3 months, or you can do it earlier before you plan any treatment. So this is just the normal peripheral smear examination. If you see beta thalassemia trait, all the cells are uniformly small, whereas here it is iron deficiency. You have some normal size, some small cells, etc. So this is the use of peripheral smear examination. So how do you manage when you suspect iron deficiency? Do an iron profile. Transferrin saturation will give you a very important idea because ferritin, if you see, very often it's an acute phase reactant. In a well patient, it gives you a real picture. But if you have a patient who has fever or has some underlying rheumatological disorder or a malignancy, then it will be falsely elevated even in the presence of iron deficiency. Serum iron also is not very reliable. If they have taken a tablet of iron in the morning, then the levels will be normal. So it's best to go by the transferrin saturation. Hemoglobin electrophoresis I've already mentioned. Marrow is usually not required in a microcytic anemia unless you're suspecting a sideroblastic anemia where you have to do the marrow and document sideroblasts in the marrow. Otherwise, there is no indication for bone marrow aspiration. Treatment will be with oral or IV iron. Nowadays, ferricarboxymaltose is available, and most patients who require a quick increase in hemoglobin can be given FCM. So now coming to macrocytosis, normal MCV is usually 80 to 95. So if you have more than 95, it's macrocytosis. Commonest is B12 folic acid deficiency, which you commonly see in vegetarians, those who have had some GI surgeries. The point to remember in macrocytic anemia is bone marrow disorders like aplastic and myelodysplastic syndrome can also produce macrocytosis. So this should be kept in mind. So when you diagnose B12 folic acid deficiency, make sure it is a hematinic deficiency. Follow up the patient after 6 months and see if they have recovered completely. If they have not recovered, then you have to evaluate for these marrow disorders. Other conditions which can also produce macrocytosis are commonly hypothyroidism, liver disease, and drugs, particularly metformin. In this crowd, metformin is something that we should remember. Most patients who are on metformin will have macrocytosis. They need B12 folic acid replacement. Phenytoin, zidovudin, and hydroxyurea are the other drugs. So if the patient can afford, straight away do a B12 folic acid assay. One very good clue would be to see the peripheral smear. And if the smear shows hypersegmented polymorphs, then it indicates a B12 folic acid. If it is MDS, you will not get this hypersegmentation. In fact, it will be hyposegmented, and it's called pseudopelga-Hewitt. So if you have macro-ovalocytes with hypersegmentation, that confirms the diagnosis of B12 folic acid deficiency. The other thing about B12 folic acid deficiency is these patients will have an icteric tinge because of destruction of the macronormoblasts in the marrow. And they will also have acral hyperpigmentation with indirect hyperbilirubinemia, very often mistaken for hemolytic anemia. So they present with anemia, icterus, acral hyperpigmentation, treat with B12 folic acid, always follow up to rule out myelodysplastic syndrome. The treatment duration should be a minimum of 6 months. Coming to normocytic, where your HB is low, but the values, the MCV is 80 to 95. Think of all the secondary causes like chronic infection, renal, endocrine, etc. So This is about normocytic anemia. Next, we go to retic count increase. So all this was normal retic count or reduced. Now we go to high retic count. As I told you already, retic count increase tells you that the marrow is functioning, trying to produce more to compensate. So this happens in autoimmune hemolytic anemia. The Coombs will be positive. So when the retic count is high, the first investigation to look for is direct Coombs test. Do the Coombs test. If it is positive, it is autoimmune. If it is negative, you have to rule out congenital causes of RBC disorders like spherocytosis, thalassemia, and also enzyme disorders like G6PD pyruvate. Acquired disorders will be PNH and microangiopathic hemolytic anemia. So retic count increased, keep in mind autoimmune, ask for a direct Coombs test. Next will be we have finished the low RBC count. Now we come to the high RBC count. So very often nowadays we see patients with high RBC, hemoglobin increased, hematocrit increased. So when you see an erythrocytosis, you need to decide whether it is primary or secondary. Usually what you see in practice is secondary to smoking, alcohol consumption, pan chewing, sometimes due to cyanotic heart disease, COPD, polycystic kidney disease. Renal cysts will produce erythropoietin and stimulate the marrow. Post-renal transplant, cerebellar hemangioblastoma. So these are some of the secondary causes. How do we diagnose that? Do the serum erythropoietin. So any patient with high hemoglobin, do the serum erythropoietin. If it is normal or high, you think of the secondary causes. If it is low, then you think of polycythemia vera, which is a marrow disorder. This is polycythemic smear, which is packed with red blood cells. The point we should remember in polycythemia is not only the hemoglobin, but the WBC and platelet will also be increased in number, and so it's called pan-myelosis. So any criteria will be more than 16.5 in men, 16 in women. Anything more than this should be evaluated. Do the molecular markers, and the minor criteria will be low serum erythropoietin. Treatment is very simple. Just put these patients on low-dose aspirin, 75 milligram per day. If the PCV is more than 45, so the target for polycythemia vera is 45. Anything more than 45, you have to do a phlebotomy. But if it is a secondary polycythemia, this is an important point to note. If the patient has a COPD, is an asthmatic, or has a congenital cyanotic, then a higher PCV is required. Such patients, you should not do a phlebotomy. They need a PCV of around 55 to 60 to support oxygenation. The most important would be low-dose aspirin. These patients have to be on 75 mg of aspirin almost lifelong. Coming to the WBC disorders, low leukocyte count. We very often see count less than 4,000. Where usually it is due to some acute infection or chronic infection and drugs. So they are manageable. So infection, particularly malaria, enteric, viral, the counts will not go up. So it could be some simple infection like this or B12 folic acid deficiency. Very often if you correct B12 folic acid, the WBC count will pick up. Isolated leukopenia is very rarely a grave hematological disorder if the peripheral smear is normal. If the peripheral smear is normal, it's very important. Drugs, particularly antithyroid, carbimazole, antipsychotic drugs and native medication can produce leukopenia. The other causes will be chronic liver disease, autoimmune disorders. So an ANA is important. Finally, aplastic and MDS. So most of these patients will manage with treatment of infection and B12 folic acid replacement. So if it still persists, then you have to think of a marrow disorder. Leukocytosis, again, is what we very commonly see, more than 11,000. So then you have to see the differential count. Is it a neutrophilic or a lymphocytic leukocytosis? If it is neutrophilic, it's usually acute bacterial infection, inflammation, post-splenectomy. Sometimes patients who have had a splenectomy many years ago, if you see their total count will be around 14,000, 15,000. So smear examination is important. Patients who are on steroids long term, some patients like SLE patients who are on steroids, there will be some neutrophilia. If it is lymphocytic, we think of viral, and if it persists for more than a month, think of chronic lymphoproliferative disorders. Monocytic leukocytosis, tuberculosis, and autoimmune. Eosinophilia, we are all familiar with. So this leukocytosis, I told you in the first slide, look at the immature granulocyte percentage. If it is more than 2%, you can be safe and say that it's probably due to infection, treat the infection, recheck the count. look at the smear, there is usually a shift to left. CRP is a very useful tool both in leukocytosis and in thrombocytosis because that rules out infection or inflammation as the cause for leukocytosis. So if you have a normal CRP, there is no shift to left, immature granulocytes are normal, then you have to think of a marrow disorder. Next, again, a very common issue, low platelets. So when do we worry when the platelets are low? They all present with different sites of bleeding. Always when you see the counter strip, see if it's only a decrease in the platelet count, isolated, whether HB and WBC are normal. If it's only an isolated thrombocytopenia, next step is it pseudo or true? Pseudo meaning when you take sample in the EDTA, sometimes the platelets will clump and it will not be counted by the machine. So you will get a false low value and unnecessarily you'll be transfusing platelets. So always look at the peripheral smear. So my most important point that I would like to convey here is if you see a low platelet count, see the peripheral smear, do the manual platelet count. And if the manual platelet count is low, then you can proceed to identify the cause of the thrombocytopenia, whether it is a decreased production marrow disorder or whether it is increased destruction as you see in ITP or it's just a liver disease with splenomegaly. Again, platelet count, anything less than 30,000, you have to closely follow up. In a well patient, if the patient is sick in ICU, 50,000 would be a safe count. So if it is less than 30,000, identify the cause and treat, give platelet transfusion if required, if you have ruled out ITP. No treatment is required if the platelet is more than 50 and the patient is asymptomatic. So even if we diagnose ITP and the platelet count is more than 50,000, there is no need to put the patient on unnecessary steroids. So treatment will be first-line steroids for ITP. That's a common cause of thrombocytopenia next to infections and drugs. And most of 65% will relapse. So then they need the second-line drugs like Azoran, HCQ, and L-Trombobag and Romiplastim, which are the newer drugs. Splenectomy, we don't do it that often these days. So the most important point is, if it is ITP, don't give platelet transfusion unless you are suspecting an IC bleed or a massive hematemesis. There's no role for platelet transfusion. Whatever platelets you give will be destroyed. Next is an increase in the platelet count. Very often patients are referred with platelet count of 6 lakhs. So if you see the common cause, it is usually iron deficiency. So when you see the counter strip, you'll be able to identify the HB is low, MCV is low. And if you find a high platelet of more than 4.5, you know it is only a reactive thrombocytosis, reactive to iron deficiency. Any inflammation, myocardial infarction, post-op. What you should keep in mind is rule out a myeloproliferative disorder like ET, essential thrombocythemia. Even for this condition, like in polycythemia, the treatment is only low-dose aspirin. So here the criteria will be more than 4.5 with these mutations. But the mutations are present in only 50% of patients with ET. So we have finished single cell line involvement. What if you have a bicytopenia or a pancytopenia? Here I would like to stress that clinical examination is again very important. Does the patient have nodes, lymphadenopathy, hepatosplenomegaly? Then rule out infection CLD and think of malignancy. If there is no lymphadenopathy or hepatosplenomegaly, then we think of common conditions like infections, drugs, megaloblastic, and more importantly, marrow failure. So these patients, you have to do a bone marrow aspiration and biopsy. Any pancytopenia, if infection drugs are ruled out, plan a bone marrow aspiration and biopsy as early as possible. Thank you.
Thank you very much, ma'am. It was a wonderful talk. You have given a very good practical points for general physicians. And are there any questions from the audience?
Total count keep increasing. We found that most of the time the fungal infection grown culture. So if we give antifungal during that stage, it helps. Or what is your take home?
Yes, actually fungal infections are common when there is a prolonged neutropenia of more than 7 days with an ANC of less than 500. Absolute neutrophil count less than 500 lasting for more than 1 week, there is a risk of fungal infection. The clue that you can get from CRP and Procal is usually CRP is high in fungal infections, Procal may be normal. And depending on the site of lesion, if it's an invasive fungal lesion, then you have to give a prolonged course of 4 to 6 weeks. If there is no invasive fungal infection like a foci in the lungs, then usually once the neutrophil count picks up, we stop the antifungal. Once the ANC is more than 1500, we stop the antifungal. Unless there is some localized lesion in the lung, like an invasive aspergillosis, then we give for 4 to 6 weeks.
Thank you. Thank you.
Oral candidiasis, it's only
Blood count, there no
There is
change
no-
in peripheral smear, ma'am?
peripheral smear, there is no change in a fungal infection. What you will see is neutropenia. Usually fungal infection occurs when the patient is neutropenic or in diabetic patients who are uncontrolled. Then you can have oral candidiasis. Usually oral candidiasis, if the baseline neutrophil count is okay, they can be managed with just candid mouth paint or fluconazole. They do not require intensive drugs like voriconazole or posaconazole if the neutrophil count is normal.
No, if you encounter oral thrush, it's best to do a smear of the tongue coat. And
smear of
the
the
therapy is local as well as systemic. Systemic 5 days of fluconazole is enough.
Fluconazole is enough.
200 milligram stat followed by 100 milligram body for 5 days.
5 days.
As you can apply 5 to 7 days.
Till it clears.
Thank you, madam. You rightly mentioned there is no role for platelets in ITP, madam. That's a myth. I'm a blood transfusion specialist. So for every fall in platelet count, they come for a platelet transfusion. That should be very much highlighted, madam.
Yes.
No role for platelets in ITP. But what is the significant count, or rather the number, wherein you should start platelet transfusion without any risk?
Yes. So
No,
that
count, madam.
Based on-
Actually, the count, many get carried away by the count. Even with patient with 1 lakh, the patient will be stable. I'm attached to Kasturba Gandhi Hospital. It's a maternity hospital.
Yes.
But they hyperreact because that's an obstetric case. So we should advise them, what is the count at least? This is the right time we should start platelet transfusion. Because platelet is a double-edged weapon, madam. It adds fuel to the fire. That, as a blood transfusion specialist,
Yes.
I want to caution the general physician
Yes.
and surgeons. He should use judiciously, madam.
Yes.
If only if it is absolutely indicated, platelet should not be used. Okay.
And puts an unnecessarily load on the
Yeah,
blood bank
absolutely,
also.
yeah.
Where they will not be able
Load
to.
on the patient also, madam. You are overloading the patient. Maybe she or he will land up with failure. Okay, overload, circulatory overload. One of the adverse reactions of blood
I
transfusion.
think your point is well taken. And the more you give platelets, you are going to do more damage to the patient. So that kind of education has to go on. That is why we are all here to discuss this factor.
I think it will be very easy to ask for a manual platelet count. Very often if it's 30,000, you do
whenever
the manual, it will be 50,000, 55. They will
Whenever
not
you
require
get a
transfer.
machine count, you will always ask for a manual count.
We have a detailed
And
count.
also, they will tell you the large platelets are seen and aggregates of platelets seen. That and all points towards good prognosis, and you don't have to transfuse.
In iron deficiency anemia, when to repeat, sir? Peripheral smear, when to repeat, ma'am? In iron deficiency
When to
anemia.
repeat the hemoglobin?
Yeah.
If it is not an acute emergency, then you can repeat after a month. Usually the hemoglobin increases by 0.5 gram per week. Hemoglobin increases by 0.5 gram per week.
How long we have to treat? Any prophylactic
Any iron
doses?
deficiency, 6 months. 3 to 6 months to replenish the iron stores. to replenish iron stores, 3 to 6 months of iron. I think the next talk is on platelet disorders, so they will be giving you more details. Post lunch, okay, thank you.
Thank you,
Thank you
ma'am.
very much, ma'am.
Thank you, ma'am. Now let's break for lunch. Please join us by 2:15 back. For TNMC credit hours, please contact the registration desk. Thank you.
Welcome to post-lunch session. So now we have three interesting topics which are highly relevant for our clinical practice. The first will be the low in the platelet count. What are the clinical, because we used to see a lot of thrombocytopenia in our clinical practice, maybe acute thrombocytopenia or chronic thrombocytopenia. So what is the relevant in our clinical practice which have to be implicated regarding with the patients? For that we have the eminent speaker, Dr. Prabhu. It's a great pleasure and honor to introduce Dr. Prabhu. He is a hematology from Apollo Main. He is FRCP in pathology from the Royal College of London. He is MRCP. He is completed MD General Medicine, one of the prestigious institution, JIPMER, Pondicherry. Once again, MBBS at JIPMER. And he is currently is a senior consultant hematologist and hemato-oncologist at Apollo Hospitals. Over to you, Prabhu.
Introduction, and thank you for inviting me to give this talk. Of course, thrombocytopenia, as Dr. Kannan mentioned, is quite a common occurrence in practice, and it's very important to understand how to approach thrombocytopenia. So platelets, although they are kind of tiny structures that are circulating in the blood, they are very dynamic structures. They play a lot of role in hemostasis and plenty of role in inflammation as well. So one of the first things to happen when you have an injury is that the endothelium get denuded, and the denuded endothelium attracts the platelets through, there is a subendothelial layer platelet interaction, and subsequently, due to release of granules from the platelets, you have platelet-platelet interaction, and you find, and there is primary hemostasis, which is a platelet-mediated clot. If it was only if it is only primary hemostasis, you will actually the clot would be unstable, and you'll probably bleed to death. On the platelet aggregation, surface platelet aggregation, you tend to have various coagulation reactions resulting in formation of a fibrin clot. So platelets are very important in that initial interaction between the subendothelial structure and platelets. So I know it's a post-lunch session, so we'll just make it all very interactive with case presentations. These are cases that are very common, and they are real-life cases. So 28-year-old athlete in great health, presents with a few blood spots in both his legs. His blood count shows hemoglobin of 14.5, total count of 8.2, and platelets of 8,000. So it's isolated low thrombocytopenia. So once you see that, you do a renal and liver function test, and it's all normal. Of course, whenever you see low platelets, you want to see if the coagulation is normal. So you do a PT, APTT, and fibrinogen, and that's normal too. And his examination is unremarkable. He doesn't, except for those petechial spots, he doesn't have any lymphadenopathy, hepatosplenomegaly, otherwise a very well patient. So when you see such a patient, let's say you see someone like that in your outpatients, what are the questions that you need to ask when someone has got a low platelets like that? First thing, is there a bleed? Is the patient symptomatic? So if there is a bleed, what is the nature of the bleed? Is it mucosal? Mucosal would mean gum bleed, skin bleed, etc. Or is it tissue bleed? Tissue bleed would be your muscle hematoma, etc. So that's important. Then the next thing, is the patient well or unwell? And is the patient on any medication? Nowadays, there are lots of medications that can cause low platelets, and there can be also medications that can affect platelet function. So that you need to know. Personal habits. Sometimes you see a lot of patients who are alcohol abusers. They tend to have slightly low platelets, and several other reasons how patients can have low platelets. So for our patient, if you ask these questions, is there a bleed? Yes. The bleed is mucosal. Yes. Patient is well. Yes. Patient is not on any medication, and very healthy patient. So that is what we have as case 1. So what are the questions that you would ask the laboratory to answer? The first question is the thrombocytopenia real? So when you ask this question, obviously there's something called pseudothrombocytopenia, which is, I'll illustrate that with a picture. So is the thrombocytopenia isolated abnormality? Is it just low platelets alone, or is there anemia? Is there low white cell count? You need to look at that as well. Are the coagulation parameters normal? And any abnormal biochemistry? So these are the things that you would ask for. So of course, this is a slide which just shows that there is a phenomenon called pseudothrombocytopenia. This will occur in about 1 to 2% of patients where it's an in vitro phenomenon. It doesn't happen inside the body. So when you put blood into EDTA, platelets clump together, and the autoanalyzer will just give you a report of low platelets. But if you put that through, if you look at it under the slide, you would see a lot of clumps, and the low platelet would be, the low platelet would be because of the clumping rather than any other reasons. So it's important to identify. So this is one reason why you have to look at a peripheral smear whenever there is low platelets. So when you have a patient with such low platelets, always ask for a good peripheral smear, because in the peripheral smear there are so many things you can find. You can find, let's say, it might be completely normal, like in our patients. It might have some RBC abnormalities like dacryocytes, teardrop poikilocytes. You can have polychromasia. There are several things that can be seen in a peripheral smear. And sometimes, parasitic infections can cause low platelets. So a good peripheral smear examination is important to look for situations like malaria. So what are the other things that important when you look at a peripheral smear? Let's say not in this particular patient. Let's say it's a patient with connective tissue disease and they have, low platelets. You can have fragments, causing microangiopathic hemolysis, red cell fragments with low platelets. So TTP-like situations. So a peripheral smear is extremely important. And of course, you could have, circulating abnormal cells like blasts, it could be leukemia. There are at least 1 or 2 times whenever the dengue, when there are a lot of patients with dengue, there are certain situations where patients, with acute leukemia, promyelocytic leukemia get wrongly diagnosed as dengue for a while because someone hasn't really looked at their peripheral smear carefully. So peripheral smear, extremely important when you see a patient with low platelets. You need to look at that. So case 1, let's just analyze case 1. So this is a patient with isolated severe thrombocytopenia in a very well person. So this is ITP. 9.5 out of 10 times, this will be ITP irrespective of your bone marrow finding. Because well patient, no hepatosplenomegaly, coagulation normal, biochemistry normal, no lymph nodes, no other abnormalities, tends to be ITP. So in terms of investigations and treatment, it depends upon how old the patient is. So the petechiae are present in the legs of the patient with ITP. So this is, in this particular picture, we've got petechiae and certain big blood blisters in the mucosal surface of the oral mucosa. So you need to look for all those things. So ITP treatment is pretty straightforward. The initial treatment is, of course, before we go to treatment, not everyone needs treatment, because if you have ITP with a platelet count of 30 to 40,000 with no bleeding, you don't need to treat. It's only when platelet count goes less than 30,000 that you need to treat. So treatment, initial treatment will be steroids. If you need urgent treatment, you would give IV immunoglobulins. There are other agents also you would use in case patients don't respond, like it's an autoimmune disease, so you use rituximab. And there are newer thrombomimetic agents like romiplostim, which is a parenteral subcutaneous agent, and L-thrombopag, which is an oral agent. And there are some newer agents like splenic tyrosine kinase inhibitors, etc., which is still not available in the market in India. But ITP treatment is steroids and IVIG as acute treatment, and second-line treatment would be splenectomy or rituximab or thrombomimetic agents. We are increasingly using L-thrombopag and romiplostim and rituximab rather than resorting to splenectomy. So moving on, case 2. So 55-year-old lady with fever for 5 days, severe fatigue and body ache. See, these are real-life cases. Afebrile right now. I'm sure you can guess where I'm getting to. White cell count, mild leukopenia, platelet count of 15,000 and hemoglobin of 13.5. PT-APTT is normal. LFTs show a transaminitis. creatinine is mildly increased. So this is a lady with fever, following fever, thrombocytopenia, mild leukopenia, normal coagulation, transaminitis. So we're looking at a picture of a dengue, post-viral thrombocytopenia. So low platelets with leukopenia and abnormal liver and kidney function, a patient with recent febrile illness. And the patient's NS1 antigen came positive. So the mechanism of thrombocytopenia and dengue would be immune destruction. That is the common mechanism, but it also can be part of DIC. Sometimes there's also a decreased production. Treatment is again symptomatic. If you have immediate access to platelet transfusions, you'd only transfuse platelets if platelet count is less than 10,000. This is uncomplicated dengue. Of course, a small proportion of patients with dengue would have DIC, etc. That's a different issue. No role for steroids. Sometimes we do see people using Solimedrol and steroids in patients with dengue. It just makes things worse in terms of gastritis, etc. But there's no role for steroids. So moving on, we'll finish as many cases as we can, because this is what we encounter in our day-to-day practice. 28-year-old primey, 36 weeks pregnant, let's say she's also got gestational diabetes, IUGR, presents to you with lack of fetal movements for 3 days, has got fever and some bruising. Hemoglobin is 6.8, total count 18.5, and platelet 32,000. PT is prolonged, APTT is prolonged, and fibrinogen is low. Creatinine is 2.9, bilirubin 3.2. So, DIC, because it could be HELP syndrome too, because DIC, HELP syndrome, acute fatty liver of pregnancy, they're all, when patients present with thrombocytopenia in pregnancy, these are all very important things to consider. So low platelets, coagulopathy, abnormal renal and liver function in a patient with a complicated pregnancy. She's got GDM, absent fetal heart sound recently, so she must have had a retained dead fetus with DIC. I think we've got 9 more minutes, so I won't go through the theoretical aspects of DIC. We all know where DICs can happen: severe infectious disease, malignancy, trauma, obstetric complications, vascular malformations, immunological reactions. So there is a whole host of situations where DIC can happen. And there are many ways to calculate certain scores to predict DIC. But the basic treatment of DIC is you have to treat the disease. If someone has got sepsis, you treat sepsis. But of course, you have to support them with transfusions. If, like for example, if platelet count is less than 50, if they've got prolonged coagulation times, you need to support them with transfusions. There was an old adage that if you give platelets or giving coagulation factors, you're adding fuel to fire, but that's not true. You need to treat them. So that was DIC. So let's move to case 4. This is, I'm sure, something that happens quite commonly in day-to-day practice. Somebody just comes with a blood count done as part of a health checkup. And routine health checkup showed hemoglobin of 13.8, total count of 7.6, and platelets of 98. So this is quite commonly, there's a reason why I use West Bengal, because we do see that quite commonly in our fellow countrymen from northeast India. They all tend to have, there's a higher proportion of patients tend to have slightly low platelets with large platelets, functionally normal. They don't have any issues at all. So everything normal. So this is isolated, moderate, low, large platelets in a very well person. So this basically is not anything, it's not clinically relevant. It just, what it does is, it comes in the way of you effectively treating that patient. Let's say he's got coronary artery disease. Let's say he needs antiplatelet agents or anticoagulation. The people get worried about these low platelet counts. So let's say, what if this patient needs an urgent PTCA because he's got bad coronary artery disease? You would say, please go ahead, because he doesn't have any bleeding history. So that's why this is important. Case 5, 72-year-old male patient, diabetic, hypertensive, flu-like symptoms for 1 month, pain in the left hypochondrium. Hemoglobin of 7.8, total count of 1,42,000, and platelet count of 34,000. Has got a splenomegaly 12 centimeter below costal margin and multiple lymph node. This is the kind of patient that you'll have to, as soon as you see, send them to a hematologist or a hemato-oncologist. So his peripheral smear showed all these large cells with vacuoles. So this turned out to be acute lymphoblastic leukemia, like L3 type. So this is a totally different type of thrombocytopenia. So low platelets as one part of many hematological abnormality in a patient with enlargement of lymph node and spleen. So this is very dangerous thrombocytopenia. You don't want to keep him in your clinic. You want to immediately put him in an ambulance or in a car and send him to a place where there is a hematologist. Case 6, 32-year-old primey, 32 weeks pregnant, known case of SLE, brought into emergency with seizures, okay? BP 160 by 110. So you're looking at toxemia of pregnancy, HELP, those kind of things. But also the patient has got SLE. Patient has got proteinuria and edema. Anemia, not unusual, mildly low white cell count, maybe SLE related, but platelets are 41,000. And it's got an LDH of 9,20,000. There are occasional schistocytes. What are schistocytes? Those were the fragmented red cells that we saw. And there's polychromasia, which means that there is some hemolysis. PT is 13, APTT is slightly prolonged, fibrinogen is slightly high at 698. Creatinine is 1.6. So, yeah, I think this is where it's a very, this you do see now and then, a pregnant lady with low platelets. Again, you have to apply the same logic. A pregnant lady with low platelets, otherwise well, could be ITP. But you also see this kind of situation where patient has got other issues, like hypertension, proteinuria, a high LDH. So this is a very challenging scenario where several things come into play. I deliberately made up this case, but sometimes many of the pregnancy cases who are not well tend to be like this. So here, the differential diagnosis, of course, this is most certainly not ITP. You cannot treat it as ITP. So HELP syndrome could be TTP or HUS, acute fatty liver of pregnancy. So these are the kind of differential diagnoses we look at, and catastrophic antiphospholipid antibody syndrome. So this is very, sometimes it becomes very difficult to, differentiate between here, there, everywhere. So that is a complicated situation in pregnancy, not ITP. So case 7 is a 75-year-old man who had a CABG, we got 3 minutes, CABG 10 days ago. Now presents to ER with darkening of toes on the right leg, a dusky discoloration of toes on the left leg. This could happen in practice, your patient has gone for CABG. Hemoglobin 11, total count 12, platelets are low. So renal liver function test and coagulation tests are normal. Doppler, right side, iliofemoral DVT. So this is a clinical syndrome where you got low platelets, but patient has got paradoxically thrombosis. So there are a few situations where that can happen. One is HIT, heparin-induced thrombocytopenia with thrombosis, antiphospholipid antibody syndrome, and you can have that in thrombotic DIC. So this patient turned out to have heparin-induced thrombocytopenia. So something to remember, thrombocytopenia doesn't preclude thrombosis. So if you have thrombocytopenia and thrombosis, you have to think about these situations. Always think about drugs when it comes to thrombosis, thrombocytopenia. There may be on many drugs that can cause low platelets, from simple antimicrobial agents to chemotherapeutic agents and others. So now coming to a very important part of management of low platelets. When you see patients with low platelets, you need to know what is a safe platelet count for several reasons. So safe for day-to-day practice, safe in terms of surgery. But what is a safe platelet count depends upon the clinical context when you're seeing the patient. So one main thing is the patient bleeding? Is a patient on concomitant other drugs, antiplatelet agents, warfarin, acetrom, etc.? Comorbidities, do they have, let's say, a big peptic ulcer or some other bleeding tendency? So these are the things that you take into account when you decide whether a particular platelet count is safe or otherwise. In patients, in your normal patient, prophylactic platelet transfusions are done only when the platelet count is less than 10,000. So But of course, there are several other situations where you would use a higher threshold for platelet transfusions. For example, if somebody is going to have a surgery, liver biopsy or epidural, so there are cutoffs. But in otherwise well patient, you would not use platelet transfusion if the platelet count is above 10 to 20,000. So safe preoperative count is something that you get asked very often as a patient, as a doctor who's looking after a patient needs to go for surgery. Greater than 100,000 for neurosurgery, surgery in posterior chamber of eye, more than 80,000 for epidural, more than 50,000 for laparotomy. Again, remember, clinical context, comorbidities. If it's an urgent surgery, somebody has got 35,000, you would just send them with some platelet transfusion. So then the important question of single donor platelets versus random pooled platelets. In normal clinical practice, you do not need single donor platelets. You just can use pooled platelets. Single donor platelets may have slightly high increment, but single donor platelets we use in patients who are regularly platelet transfusion dependent, where you don't want them to get exposed to a lot of platelet-related HLA antigens because they'll become refractory. Let's say somebody has got MDS or something along those lines, where they have to have platelet transfusion every 2 weeks. You would not use random donor platelets, and you would use single donor platelets. So I think that is more or less a whirlwind tour of how you manage low platelets. Thank you very much, and if there's any question, I can take.
Thank you, Prabhu, for the comprehensive deliberation on the low platelet count regarding with the clinical consequences, and also you have given the very good clinical based approach. Prabhu, I have a small question. So we used to see a lot of diabetic patients. The long journey of diabetes, who have poor control of diabetes, having more than 10 years or 20 years. We used to see some patients having the chronic low platelet, the chronic thrombocytopenia. What is the pathognomic integration with the diabetes and low platelet? Whether we have to deal with anything with PAI or IL-6 or any inflammation triggering on?
So your question is, in poorly controlled diabetics, some patients tend to have like moderate to mild thrombocytopenia.
Because we are using this platelet count as one of the marker for the FIB4 index to assess the MASLD among the diabetic patients. So I'm asking because diabetic will lead to the triggering of the PAI, plasminogen activator inhibitor. This will provoke for the engulfing of the platelet going for low platelet count.
Okay. To be honest, I have no idea. I don't know about that. Yeah. So this is in diabetics who have mild to moderate thrombocytopenia. They have high PAI activity, sir. I have to admit, I don't know about it.
Yes, thank you. Thank you.
Sorry? Huh. Yes.
So because it's associated with vasculitis, so the comorbid is more important than the platelet count by itself.
Yeah.
If you have ITP or other conditions where we go by the count.
Yes.
Whereas in situations like dengue or like scrub typhus and leptospirosis, in addition to the low platelet count, there is a vasculitis component there. So that might trigger this bleed. The GI bleed is very common. That we have seen.
Yeah.
What is your take home?
Yeah, I agree with that. See, when I say role for prophylactic platelet transfusion is 10,000, that's a broad generalization. So let's say you have a patient who is febrile with very high temperature, because platelets have a role beyond coagulation. They're also pro-inflammatory. There's a lot of consumption of platelets when there is a lot of inflammation. So in a patient who's unwell with high fever and lots of inflammation, in such a patient, your 10,000 may not be the right prophylactic threshold. So in such patients, there is literature to say around 20,000, but all these things depend on clinical context. Let's say you have a patient with scrub typhus who's also got prolonged APTT, low fibrinogen, etc. Then your threshold will be much higher.
Thank you. Thank you.
If at all there is time, we'll always discuss. Platelet is always a hot topic. We'll call upon Dr. Tirupati, my friend. He's a senior consultant, pulmonologist, and he needs not much introduction. He's a consultant pulmonologist and he is specialized in airway disease. He will be giving us some light on what are the recent approaches to airway disease, asthma and COPD.
Tirupati is one of the very predominant pulmonologist in SIMS, and also is very well known across the globe, both in ERS as well as the ATS, American Thoracic Society. Over to Tirupati.
Good afternoon. At the outset, I am delighted to have such an enthusiastic audience in the post-lunch session. Thank you for inviting me to deliver this talk. So all of us treat various disorders with wheezing. They may be asthma, COPD, bronchiectasis, bronchitis, even pulmonary embolism, cardiac asthma. So we need to be precise in our management for the better outcome of the patient. So we have variety of options for treating the patients also, starting from bronchodilators, inhaled or oral corticosteroids, then rehabilitation, biological, and so on. So what needs to be given as per the guidelines? So we have two guidelines for management of asthma and COPD. One for asthma, GINA, and for the COPD, it is GOLD. So they have come up with nice ideas every year. They update every year, which will make the job of a physician very easy. So these guidelines provide two important things. One, for precise diagnosis of the condition and easy management of the condition based upon the evidence. So let me start with an illustrative case for asthma. So this individual, it is obvious that he is having a chronic symptoms. He has comorbids, he has exposure to pet animals, and he is having more symptoms during winter. So whenever we are confronted with a patient with wheezing, this history is very, very important. We need to look into the symptom pattern. Anybody can have cough, sputum, wheezing. The person, if he says, I am having more breathlessness at the end of the exercise, for example, that is very distinctive of asthma. Similarly, a patient says, I am having more symptoms in the winter. I don't take any medicines in the summer, but I am not having any symptoms. That again is classical of asthma. So this is called as a variable nature of symptoms. If you have one patient, straight away go for the spirometry, the next important tool for making the diagnosis of asthma. In spirometry, first thing you need to assess is the quality of the spirometry. Many of the spirometries are not done as per the guidelines. See, spirometry is not a test like blood test. The patient needs to blow for the required time and take a deep breath in a forceful manner. The technician who is demonstrating needs to demonstrate that. Otherwise, we will get simple numbers. I can say many of the places it is not done in a proper way. That is why history is important. Then you need to have a quality spirometry. Please look whether the patient has exhaled for at least 6 seconds. Then only the values are interpretable. Then we need to look into 3 parameters for making a diagnosis of asthma. Very, very simple. One, what is the pre-bronchodilator FE1? What is the post-bronchodilator FE1? We need to repeat the test after giving a salbutamol 4 puffs, wait for 15 minutes, repeat the test. That is the complete spirometry. And what is the difference? If it is more than 200 ml, here what is the difference? 300 ml. If it is more than 200 ml and if the difference is 12% of predicted, in the classical symptoms, we have a diagnosis of asthma. Suppose if we are not having an access to spirometry, peak expiratory flow meter can be used, but less preferred. Again, after giving the bronchodilator, if there is an improvement of 20% in adults and if there is an improvement of 15% in children, you have a case of asthma. 2025 guidelines have come up with 2 new biomarkers. Suppose if you are not having access to spirometry or if you are doing spirometry or peak flow meter, the values are not typical of asthma, you can utilize these biomarkers. One is the fractional axial nitric oxide. If it is more than 50 parts per billion in adult or if it is more than 35 parts per billion in children, in a classical symptom, you have a diagnosis of asthma. Not only that, for assessing the risk of exacerbation, for deciding about the biological for a case of severe asthma also, these 2 biomarkers. One is the FeNO, the other one is the absolute eosinophil count. If it is more than the upper limit of normal for that region, that was the specific thing in GINA 2025, you can utilize that in the classical scenario. Please follow up the patient for symptomatic improvement, then decide to continue the inhaled corticosteroid. And similar to FeNO, this also can be used for the risk of predicting the exacerbation and to decide on further treatment like biologicals. So this is how asthma is diagnosed. Then the management. Management is not a single-step solution. We are giving the patient with inhaled corticosteroids. When the patient comes for the follow-up, kindly assess for the symptom control. How you feel, what are the reliever medications in between you required, how many times you had nocturnal symptoms. If the patient is telling, I'm not doing good, then what can be done? Whether there is a problem in inhaler technique or we need to address the comorbid condition, please assess, then adjust the dose of the medication. Then when the patient comes for the review, decide on whether to continue in the same dose. Likewise, we need to repeat the thing in every visit. You need to step down or step up in case of, as per the symptom control. And another point I like to highlight is the treatment. Up to 2018, this is what was advised. For the patient who are having very infrequent symptoms, we can call that as mild intermittent asthma. We were giving only salbutamol as the reliever medication. In asthma, there are two medications. One is the controller medication, which needs to be taken irrespective of the symptoms. And the number two is the reliever medication that needs to be given whenever the patient is experiencing symptoms. Up to 2018, for mild intermittent asthma, only salbutamol was prescribed. When the symptoms are more frequent or the lung function is less, patient is advised to take either a low-dose inhaled corticosteroid, and whenever the patient is having symptoms, he is allowed to take salbutamol as a reliever inhaler. And when the symptoms increase, either we can increase the dose of inhaled corticosteroid or you can add a long-acting beta-2 agonist like formoterol or salmeterol. This is how up to 2018 we were practicing. The year 2019 marked one important change in management of bronchial asthma. That is, there is no role of salbutamol alone for management of asthma. It should be combined with inhaled corticosteroid. So they have given two tracks. One is track 1 and track 2. And track 1 is the preferred one. And what is track 1? In track 1, see, for patients with infrequent symptoms, they have merged step 1 and step 2. And the patient needs to take an inhaler called as anti-inflammatory reliever. So anti-inflammatory reliever is, see here we use the word anti-inflammatory reliever. It is not reliever alone, it is called as an anti-inflammatory reliever. The recommended one is the budesonide plus formoterol. So a patient, whenever he gets symptoms, suppose I get symptom once in a week, he is allowed to take that one puff depending upon the improvement, and if he is getting another symptom, he can have that. When the symptom go up, what needs to be done? Patient needs to take a low-dose inhaled corticosteroid budesonide with formoterol as a maintenance therapy. That is morning one puff, night one puff. And when the patient is experiencing symptoms in between, he is allowed to take additional puffs of the same inhaler. Note that same formoterol plus budesonide inhaler can be used whenever the patient is experiencing more symptoms. He can take whenever he is going to exert, for example, he is going to participate in an athletic activity, or when he is likely to have a puja, or can confidently give that this combination. Please understand, this is only meant for formoterol plus budesonide combination, not other combinations. This is the only thing. And when the patient is getting more symptoms, they can double the dose, and then patient gets more symptoms, the phenotypic management comes. What about track 2? In track 2, suppose for even yesterday one doctor came, I cannot take long-acting beta-2 agonist, I am getting more headache due to that. That is his symptoms. He wants only salbutamol as a reliever. So in track 2 also, salbutamol is allowed, but the patient needs to take along with salbutamol, compulsorily he needs to get the benefit of inhaled corticosteroid. So either he can use the same inhaler containing salbutamol with inhaled corticosteroid, or he can use two inhalers, but the inhaled corticosteroid is mandatory for track 2 and track 1 is preferred. Why? It is very simple. For the purpose of convenience, he can have only one inhaler. Suppose if the patient is allowed to take salbutamol along with inhaled corticosteroid separate inhalers, he may take only salbutamol. He will not be getting the benefit of inhaled corticosteroid. By doing that, the risk of exacerbation is reduced. When compared to MOD therapy, if the patient is taking only salbutamol, the risk is 65% more, and patient is having ICS with salbutamol, the risk is more than 37%. Not only that, we are able to reduce the dose of high-dose inhaled corticosteroids. We are able to reduce the quality of life. So track 1 is preferred. This is called as MORT therapy, that is maintenance and reliever therapy in a single inhaler. So coming back to our illustrative case, what are the things he is doing? He is having classical symptoms of asthma, and the PFT also I showed. He is having a variable airflow limitation, and he is only on salbutamol. So this is against the current guideline. What needs to be done? The diagnosis, we are sure. We need to introduce the concept of MORT and treat the comorbid conditions, and we need to advise him to avoid pets, and more importantly, follow up the patient after 3 to 6 months. Suppose the same patient comes and tells that I am not happy with your medication, still I am experiencing symptoms. What needs to be done? The number one thing I do is show me the inhaler, how many number of puffs you have exhausted, whether it is adherent or not. Then the inhaler technique, very, very important. A number of times you teach, patient will be making at least 1 or 2 critical errors which will impact the quality of treatment. Still, if the patient is not showing improvement despite proper adherence and proper inhaler technique, we need to go for step 5 management of asthma. That requires many assessments. These are all the options for step 5 management of asthma. You can refer to us. We will manage. We need to assess several parameters. There are conditions like ABPA, vasculitis, peripheral eosinophilia with infiltrates. Many things we need to work up. We can take a CT. So step 5 is for us. Coming to COPD. Again, COPD symptomatology is very important for making the diagnosis. One, the dyspnea. Here you can see dyspnea is persistent. It is not intermittent. It is progressing over time, and patient can have other symptoms like cough and wheezing. Very importantly, you need to look for the presence of risk factors like smoking. Not only smoking, it can be from occupation, it can be from the pollution. Even there may be risk factors due to genetics, alpha-1 antitrypsin deficiency, low birth weight. So all these things we need to look. So again, we need to look into the presence of risk factors, the symptoms which is persistent. Then please look, spirometry is required for establishing the diagnosis. In case of COPD, what is the value we are going to look into that? Here again, see there is a pre-bronchodilator testing, which is on the left side, and the post-bronchodilator. You need to look into the only one value. What is that? Post-bronchodilator FEV1 bar FEC. So pre-bronchodilator FEV1 bar FEC less than 70%, it confirms obstruction. Then repeat the test, and if it is less than 70%, you have a case of COPD. Not only that, we require few other things to look into. One is the modified MRC dyspnea scale. It has 0 to 4, and we need to ask the patient what grade he is fitting in. This is an easy way to remember the MMRC grade. Then we need to assess the CAT score, that is COPD assessment test, easily available on the net. You can ask the patient to fill it. It is a score up to 40, and depending upon the score, we need to use the tool called as ABE tool. Again, this is the update from 2023 onwards. Before that, there was A, B, C, and D. Now, the C and D are merged into E. E is meaning two things. One is exacerbation. Number 2, E is meant for eosinophils. So how we are applying? Suppose the patient is telling the MMRC score of 1 and CAT score of less than 10, that individual is into class A. We need to ask for one another important thing. What about the exacerbation history in the last 1 year? Anytime in the last year you got admitted due to COPD, that is called as severe exacerbation, or a moderate exacerbation twice in the last year, again that individual is placed into class group E. And group E requires intensive treatment, and here comes the role of a biomarker, simple eosinophil again. If the eosinophils are more than 300, and if there is an exacerbation risk, we need to give the patient with the benefit of inhaled corticosteroids. So in COPD, not only the medical management, we need to assess the risk of exacerbation. We need to prevent that. We need to prevent mortality happening due to COPD. Here comes the ABE tool, the role of ABE tool. For group A, any bronchodilator which is inhaled is sufficient because the individual is having very infrequent symptoms only. Suppose patient is having more symptoms, then you need to combine two bronchodilators, inhaled bronchodilators, long-acting beta-2 agonist with long-acting muscarinic agents. There are multiple drugs are available in the market, and if the patient is in the group E, we need to place him with LABA and LAMA. We need to add inhaled corticosteroid. Even though it appears simple for asthma also, beta-2 agonist and steroid, here also beta-2 agonist steroid, there are a lot of things behind, the outcomes are different. We need to be very clear in choosing the patient for this thing. Suppose again patient comes for the follow-up, we need to check the inhaler technique if he is not doing well, and if there is predominant dyspnea, we need to combine two molecules, and if there is predominant exacerbation, use the biomarker, and if it is more than 300, give the benefit of inhaled corticosteroid addition to that. Still the patient is symptomatic, there are few things we can do. One, if the FEV1 is less than 50% and the patient is telling I am having more cough and sputum frequently, chronic bronchitic phenotype, we can try the drugs like rofimilast, even though the tolerance is very poor in real practice. Azithromycin can be given for up to a year. Again, you need to be careful about the cardiac toxicity and the hearing impairment. Dupilumab is the biological which is approved for management of COPD but not yet available in India. This is as per 2025 guideline. So management of COPD, it is not only about bronchodilators, it is adding ICS, and you need to do several things like smoking cessation, vaccination, lifestyle measures. Again, when the patient is coming for the review, assess the patient. If there is desaturation or hypoxemia, what is the role of oxygen, non-invasive ventilation, or pulmonary rehabilitation? All these things we need to consider. This slide is very, very important. We need to choose the inhaler which is appropriate for the patient. We need to consider several factors. Whenever patient comes back for the follow-up, we need to ask the patient how you are using. Please demonstrate. And digital inhalers useful in one way that how many number of doses got exhausted so that we can assess the adherence. Nebulizers also can be used in a frail COPD patient if the patient is unable to take the inhalers properly. What about the non-pharmacological management? The smoking cessation is clearly proven to be advantageous. That should be tried for all COPD patients, and pulmonary rehabilitation is clearly having a mortality benefit. So previously, there was a thing called as no medicine is having a mortality benefit. Now it is very clear in an individual with frequent exacerbations, this single inhaler triple therapy combination has clear mortality advantage. It is proved in several trials like IMPACT and ETHOS. There are many papers on that upcoming. So decide upon that when the patient is having exacerbations. Pulmonary rehabilitation to be considered before discharging a patient with acute exacerbation, and at least within 4 weeks you start, and it is going to reward your patients to lead a quality of life. Similarly, long-term oxygen therapy is useful if the PaO2 is less than 55, and it should be given at least 19 hours a day, then only the benefits are there. This is as per the NOTT trial. Non-invasive ventilation has changed many patients' life in COPD. Many patients are having chronic type 2 respiratory failure, and it is very useful to continue their life. And to conclude my talk, in asthma, history is very important, the variable nature of the illness, and check for the post-bronchodilator improvement. If it is more than 200 ml with the classical symptoms, you have a case of asthma, treat with inhaled corticosteroid as a main therapy, and MART therapy is very important when the symptoms get more. Don't rely upon salbutamol alone. In COPD, again, classical history with risk factors like smoking and progressive symptoms in the presence of FEV1 bar FEC less than 70%, use the ABE tool appropriately for deciding which molecule rather than blindly giving a therapy, and consider the role of non-pharmacological interventions which have mortality benefit also. Once again, I thank the organizers.
So thank you, sir, for a very simple, so no complicated thing. So everybody understood what is asthma and COPD. It is very clear about various drugs. We will have one or two questions just for the next session. So Parandaram sir கேட்டல எனக்கு படபடன்னு இருந்தது. சரி வாங்க.
Sir, Tirupati. Sir, that's a minute, sir. Tirupati, I have a simple practical based question, sir. So, in our clinical practice, a clinician used to say a lot of asthma, COPD, or asthma, COPD mingling syndrome. But still, there are a lot of inertia among the clinicians. Which device we want to use? We want to use either dry powder inhaler or MDI or spacer. You have to educate us.
That is a very, very important point, sir. That's what I put that slide. We need to decide based upon the individual. We need to consider the very important thing, age. Younger the age group, between the school-going age group, we can right away choose rotahalers, rotacaps, the dry powder inhalers. Whereas the age goes up in a frail Parkinson patient with COPD, definitely either an inhaler with spacer or a nebulizer will be very, very useful. Even for an infants, again, inhaler with spacer with face mask will be useful. So we need to decide upon the individual patient. Sometimes before starting the dry powder inhaler, I will ask them to take a deep breath and demonstrate. Many patients cannot understand that they cannot take the deep required inspiratory flow for a dry powder inhaler, even though it is very simple, easy to carry. If the patient is unable to take the required inspiratory flow, there is no point in giving a dry powder inhaler. So we need to check on these things, and even the guidelines are telling we need to ask the patient. So these are all the options which you prefer. Then I will suggest, okay, this is having this limitation, this is having this advantage. What do you want to choose?
So we'll thank you, sir. Thank you for the extensive coverage. For want of time, we'll go to the next topic on
Thank
a
you
very
very much.
important aspect, approach to knee pain by Dr. Saravanan Mahanovaran. He is a senior consultant in MGN Healthcare, and he is a senior consultant at Bone and Joint Hospital for 15 years. Shoulder and knee surgeon at MGM Healthcare. He specializes in complex fracture management and orthoscopy. Special interest in acetabulum fracture, sports injuries, and deformity correction. We welcome you, sir.
இல்லை முன்னாடி ம் Respected chairpersons, senior colleagues, and my dear friends,
At the outset, I would like to thank for the organizers for giving me this opportunity. And with this, we'll move on to the topic. So my topic is approach to the knee pain. So my approach to knee pain is quite simple. It's like it starts with where the knee pain starts, whether it is the front, side, or in the back. To start with anterior knee pain, this is the way which commonly people present. People present with pain in the front side of the knee. And the reason for which is, this is called the chondromalacia patella, wherein the patient presents with pain while climbing stairs, while getting up from sitting posture, they complain of knee pain on the front side. And the reason is the patellar cartilage and the femoral cartilage, they rub against each other. They become a little bit soft because of patellar maltracking. The patella, as you know, is controlled by the musculature. The vastus medialis and the vastus lateralis control them. And for those who have tight lateral structures and the weak medial structures, the patella tends to have some little bit of lateral mobility, which causes a damage on the undersurface of the patella, and that is the reason for this chondromalacia patella. And the treatment given is vitamin D, capsules and sunlight exposure. All this vitamin D exposure will be advised. And the more important is the physiotherapy. We'll advise them muscle strengthening exercises and the correction of muscular imbalance to weaken the lateral structures and strengthen the vastus medialis obliquus. So this is how we'll be able to treat anterior knee pain. And when it comes to pain at the back of the knee, we have to think always it cannot be only from the knee, it can be coming from the back as well. The sciatic knee, sciatica, which we have a low back pain, that also can present as pain at the back of the knee. And whenever a patient presents with pain at the back of the knee, we rule out spine, we'll have to do an MRI scan because these two conditions were very important, the medial meniscus root tear and ACL ganglion cyst. This is the anatomy of the medial meniscus. We have the posterior root, which is very close to the, and it can get commonly torn. And this is very common in the 50s. The probably like patient who has a mild arthritis, they'll just climb up a stairs and present with severe pain. They will not be able to keep the next step. They will have severe pain and pain at the back of the knee. And most of them will say that they heard a pop sound while they did that injury. And if we do an MRI, we will be able to find out a medial meniscus root tear, which is seen here in the MRI image. And that is an arthroscopic picture showing that the medial meniscus, from the posterior root, it has got avulsed. So whenever the patient walks over with a medial meniscus root tear, so they will have that medial meniscus get extruded, and because of that, the patient will have excruciating pain. And this is not going to heal over a period of time. But it's not like unlike the other, they'll continue to have pain, and for which we need to do a procedure. This is an animation of the procedure wherein we will take some bite into that medial meniscus posterior root, and with that we'll be able to get this pushed in. This is we'll make a crater, or we'll make a tunnel in the place where the medial meniscus has pulled off from, and we'll take a bite into it, hold it very securely, and pull it through the tunnel, so that this is exactly at the place where the medial meniscus has been attached to and from where it has got avulsed. So once we fix it, it will be all right. So this is a arthroscopic picture showing that the medial meniscus, we are seeing the meniscus which is loose. It should not be loose like this. So as usual, we'll freshen the medial meniscus tissues with the help of an instrument called shaver, and take a bite into that medial meniscus with the help of an instrument. And once we retrieve that meniscus into it, we'll be able to securely fix the medial meniscus into that root, so that that medial meniscus will become stable, and this instability is corrected, and the patient will be able to walk normally thereafter. The other diagnosis is the ganglion cyst of the ACL. As you know, we have heard about ACL, which is important for the sports injuries. So that can become swollen, and MRI will be able to easily diagnose this ACL ganglion cyst. Since it occupies a posterior part, it has a big space-occupying lesion there, and that will cause pain. And it is just a cyst. Once we expose it, and once we burst it out, the patient will have immediate pain relief. It's a simple procedure which will correct this knee pain. And moving on to the pain on the medial side of the pain. So whenever a patient comes with medial side pain, the number one is a medial meniscus tear. The medial meniscus body tear. The body of the meniscus can get torn because of a sports injury or due to a vehicular accident, and they will present with a predominant pain on the medial side. And this again needs a surgery because medial meniscus, if it is a small tear, we need just a partial medial meniscectomy. If it is a bigger tear, we might need to repair this with the help of an instrument called this meniscal cinch is there. And similarly, there are a lot of equipments there, a lot of techniques are there. This is an all-inside technique of repairing the medial meniscus. There is inside-out techniques, there outside, many techniques are there. This is the latest and the simpler technique. And this is how the case has been done. That is an animation. This is a real-time case where with the help of, we can see this is the tear. This is where the tear extends. And with the help of this instrument, we'll be able to pierce that meniscus and get it out into that capsule. And once we deploy it, that small instrument gets deployed and gets a hold onto the capsule. And once we do similarly, there will be two cinches. And once it is done, it will be able to securely, once you tighten it, it gets securely fixed, and within 6 weeks, the meniscus heal without any problems, so that the pain will go away. So the other common thing we find is a medial compartment osteoarthritis. As you all know, osteoarthritis is aging. So as we age, it is not just like it has a sequence. We divide those compartments into medial compartment, lateral, and the patellofemoral compartment. We divide this knee into 3 major compartments. And naturally, whenever there is a patient who has a varus, the gap or the medial sided joint space will gradually reduce over a period of time, and the osteophytes increase over a period of time. This is how a patient over a period of years progresses. If we take serial X-rays, we'll be able to see that there is a progression of osteoarthritis. And this is more prominent whenever the patient is having varus. So this is how there is a medial joint space reduction. If you open it, there will be medial cartilage alone is gone, but the lateral cartilage is absolutely fine. So this is a isolated medial compartment arthritis. It is before that tri-compartmental arthritis, patient will be having this medial compartment arthritis in the age group of somewhere around 45 to 50, 55. They'll have predominantly medial sided pain. They'll come with medial pain, medial sided pain, but the lateral side will be normal. There will not be lateral sided joint tenderness. And when we examine, the patient might have a varus, and the pain is because of the bone-to-bone impact. So the contact pressure will cause the pain, and the deformity or the varus is going to increase the pain as well. So this is a biomechanical thing, where it's like normally if we compare divide the knee joint into medial side and the lateral side, the forces are not equal. The 60% of the body weight force goes into the medial compartment and 40% goes into the lateral compartment. Once there is a varus, since the momentum becomes increases, so there will become like 80-20. 80% or more than 80% forces go into the medial side, and only a minimal amount of force goes into the lateral side. So whenever a patient with like at 45, 50 comes with knee pain, we'll kind of start with analgesics and physiotherapy. Sometimes they will become all right, and if the patient continues to have pain, when that non-operative measures have become like all has been boosted, and then the solution of it is going to be surgery only. And commonly if you see knee replacement is being advised for people who are less than 55 years as well, but it is better to be avoided in those who are less than at least 55 in a female and less than 65 in a male. Why? Because knee replacement usually lasts for 15 to 20 years. 20 years, it is like we can be sure that there will not be any problem. And the increased wear rate, if at all, if we do it in a younger patient, because since their activity level is more and their longevity is going to be more, so we say that the patient outlives the implant. So that is why we need to do multiple knee replacements whenever if we do a replacement in the younger age group. And obviously there are some lifestyle changes. Patient will be having difficulty in the sitting on the floor, and the feel of artificial joint will generally be there with the following a knee replacement. So, and another trend which we find nowadays is that even younger patients, I mean, it's like the medial compartment arthritis is coming in younger patients as well. So that is why we cannot do knee replacement in a younger patient. And the solution of this is a procedure called high tibial osteotomy. It is just animation of the procedure. It is also called as the tibial valgus osteotomy, wherein this, we can see that the femur, tibia, and the patella are being marked here. And whenever there is a varus, you can see that there is a normally, if we draw a line between the center of the hip and the ankle, it has to pass the center of the knee. Once there is a varus, it's like the force becomes more on the medial side, so patient starts having pain on the medial side of the joint. And if we do an MRI scan, we will find that there will be a medial meniscus degenerate tear. All these things will be there. Patient will be like 45, early 50s. They'll have keep coming with knee pain. We'll advise physiotherapy and all. And in that scenario, we can correct that varus by doing a high tibial osteotomy. And in those scenarios, doing only an arthroscopy or just doing a debridement of the meniscus will not help unless and until the osteotomy is done to correct the deformity, because the source of the pain is the varus rather than the meniscus. Meniscus is just a victim of the varus. So just doing an arthroscopy and doing a medial meniscectomy, it is not helpful. But rather, if we do a osteotomy to correct the varus, the joint forces will get neutralized and the pain will get reduced. Rather, it is a simple concept. The medial cartilage is gone. We just offload the medial joint so that the force goes through the entire knee joint rather than only on the medial side. So this is the principle by which this osteotomy will work. So basically, there is concentration of forces on the medial side. Once we do an osteotomy and apply a plate, the forces become equalized so that the patients will not have pain. So the high tibial osteotomy, is it a new surgery which many people would have heard about knee replacement, but not many people would have known about osteotomy. Is it a new surgery? No, it was invented in 1958. It was a gold standard even before replacement came in. But once a knee replacement came in, the popularity of it went down, because after a knee replacement, there is no immobilization. Patient can walk immediately, walk day 1, day 2, they can be able to. Because of the early mobilization, knee replacement became more popular. But it is nowadays, this osteotomy is again becoming popular again because of the trend of arthritis in younger patients. So who will be the ideal patient? Medial compartment arthritis in a 40 to 55 years of age group, not responding to conservative management, will be an ideal patient for this. And so it is not artificial joint. It is just realignment of the patient own individual knee. So the patient can kneel down, do whatever activities, even a patient who is even running a marathon after this tibial osteotomy, which is not possible after a knee replacement. So this is one of my patients who had a 41-year-old female. At 41 itself, she is having such a lot of osteophytes and reduction in the medial joint. So we did osteotomy on first, we did on left side and right side. So this is how the varus got corrected, and the last surgery I did around 8-9 years back. This actually worked for at least 15 years. We'll be able to postpone the knee replacement. So the high tibial osteotomy is indicated in a 40 to 55 years medial joint pain with a varus and with a normal lateral compartment. The lateral compartment should be normal, and in these patients, high tibial osteotomy gives excellent result because patient walks on his or own joint itself. It is not artificial, and it is very cost effective. It is 40% less costly than a knee replacement, and there is no restriction like sitting on floor. Everything is allowed. And similarly, if the patient presents with a lateral side joint pain, it can be again a lateral meniscal tear or a discoid meniscal tear, or it can be an isolated lateral compartment arthritis. Here we can see the reduction of joint space on the lateral side, and the medial side is fine. So again, we can see that in these patients, they will have a valgus. With the same mechanical axis line, if we draw, the line is going in the lateral compartment because the forces are getting concentrated on the lateral joint line alone. So this can be again corrected with a valgus can be corrected into a varus with a osteotomy in the femur, and with this we will be able to correct the valgus, and so that the load will go into the medial side, which the cartilage is normal, so patient will be able to walk comfortably. What about pain all around the knee? So wherever if the patient is like everywhere, front, back, side, everywhere there is pain. So that is when we'll ask a question of when is the pain maximum? In the early morning, when when the patient wakes up in the morning, or after doing activities or straining. So when the patient has early morning pain, it has to be predominantly inflammatory arthritis, and if it comes after arthritis, after straining, it is osteoarthritis. So we all know the common causes of osteoarthritis, the rheumatoid arthritis, gout, reactive arthritis, and the seronegative arthritis will cause pain predominantly during the early morning pain. And the treatment is going to be microstate with all these DMARDs for this rheumatological pain. Coming on to tricompartmental osteoarthritis of knee, wherein the arthritis is in the medial side, lateral side, everywhere there is arthritis. They will come with pain, stiffness, tenderness, grating sensation, all this swelling and all will be there. They will present with chronic pain, and usually they will have difficulty in walking like this, and they will be walking with a varus like this. And the X-ray features are like osteophytes, the tibial spiking, there will be joint space narrowing, and it's very easy to diagnose an osteoarthritis. Everybody knows this. So again, we'll start with physiotherapy. Again, the analgesics, physiotherapy will increase the blood circulation, will to reduce the knee pain to a bit. And once again, if the knee, all the conservative measures have failed, then we can give the patient a surgical option, which is a permanent treatment, which is a knee replacement. Ideally, if a patient is more than 60 years, there is no doubt knee replacement will work wonders in those patients. So you will have a metal knee replacement. We have a metal fragment, metal component of the femur, metal component of the tibia, and a plastic. So once that metal component rubs against the plastic, the patient will get relieved of the pain. So this is one of the patients where there is severe deformity and there is bone-to-bone disease. There is no gap at all. There is no cartilage at all. Once we correct the deformity and with the knee replacement, patient will be able to comfortably walk for life. So the ideal patient will be like at least 55, more than 55 years old woman and more than 65 male, and severe osteoarthritis in an X-ray, which is difficult, which produces difficulty in even daily activities. So just an animation of how a knee replacement works, wherein he can see that the cartilage is worn out in this scenario. And it's not like we'll have to totally take the knee out and put an artificial knee. It is just a resurfacing of the knee. We just remove all the damaged part, or we want that processes to fit in. So that much of bone will be removed, and that is how we'll be able to fit in the process after removing the bone with the help of a bone saw. These are fixed with the help of bone cement. And this is a plastic which goes in, and with this we'll be able to get rid of the pain because we are correcting both the deformity and the surface. So the benefits of knee replacement are pain-free life, mobility. Back to normal, the patient will be able to live a life without any restrictions. And over a period of time, in the sense that if the patient has osteoarthritis and the patient has been bedridden or restricting themselves within their room, and they are not walking too much, they will have osteoporosis. And that is why we commonly find that those patients who have been advised of knee replacement in their 60s, and they avoid, and they'll come back at 75, 80 with an osteoporotic fracture of the hip. There is a very big important relation between osteoarthritis and osteoporosis and osteoporosis related fractures, which happens at 70, 75. So that is why getting the knee replaced and getting back to them, getting back normal life to them, it is very important for bone health and mental health as well. Mind is happy only if we do our own activities, whatever which has been possible has to be done. And this is one of our patient where the patient is not able to walk because of the bilateral osteoarthritis. And once we do the replacement, this is the 24 hours after the surgery. You can see that the knee bend has been rectified. And at 15 days itself, she will be able to walk like this. So in short, in summary, the anterior knee pains needs physiotherapy and vitamin D supplements. Pain at the back of the knee, we need an MRI and further evaluation. Medial compartment knee in a younger patient are best treated with an osteotomy, and correction of the deformity cures the pain. And knee replacement is reserved for old people with severe osteoarthritis. With this, thank you for the opportunity. Thank you, sir.
Thank you, Dr. Saravanan. A beautiful illustration of knee pain, starting from the anterior to medial part, lateral aspect, and whole of the knee. So we'll have one question.
Regarding the tear, anterior cruciate ligament tear.
Yes, sir.
We do a document in sports injuries.
Yes, sir.
Recently, I had one case.
Yes, sir.
The patient underwent suture, as you pointed out. The patient could not move at all. When I contact the orthopedic surgeon, early ambulance is necessary. Within 2 or 3 months, the pain disappeared. But he is not at all able to walk even normally when he used to do previously, prior to surgery.
Okay.
What could be the reason? Can you please explain?
Yes, sir. Sir, anterior cruciate ligament reconstruction has to be, I would say it is like every surgery has its own limit, complications, So if at all, if the patient is not able to walk after that as well, there could be 2 or 3 reasons. One is like if the medial meniscus was torn, was not addressed as well. That also has to be addressed during that ACL reconstruction. Sometimes it might be missed. Or it could be because of some low-grade clinical infection that also will cause severe pain, and the patient will not be able. So, these patients are younger patients. So, a mild infection will get contained. It will not be like pouring pus and all. With mild infection, will keep lingering inside, and it can cause a little bit of cartilage damage. It can cause joint irritation. That could be the reason for the knee pain for a patient. Because after an ACL reconstruction, within 2 days, patient should be able to walk on his own leg. We advise early mobilization. On the second day, patient should be able to comfortably walk, with the help of a walker as well. But by 10 days, when the patient comes for suture removal, patient should be coming walking. If at all, if the patient is not able to walk in spite of 2 or 3 months, I can suspect probably only a mild degree of infection, which because operation theaters, it has to be absolutely sterile. And arthroscopy is one area where we don't use autoclaved instruments everywhere. It is like we need a shaver. If a hospital setup has ETO and other facilities, ETO or a plasma, they will be able to do it. Or else most of the hospitals who don't have this, they will have to use Sidex. They have to rely only on Sidex. And that is why getting that surgery done in a proper tertiary care center where all the facilities are available will be better, sir.
So we will conclude the session, session 4.
Where do you try plasma precipitate? Plasma.
Sorry, sir?
Plasma.
Plasma.
Do you try? Yes. Recently, in many newspapers, we see this type of
PRP transfusion.
PRP, sir. Sir, there are people who advocate PRP. I'm strongly against PRP. They are giving PRP injections left and right for osteoarthritis. Osteoarthritis is something. It is a pure aging-related problem. For aging, we cannot take. PRP is just taking blood here and injecting blood here. Probably we'll remove blood minus RBC is PRP. So we just take blood here and inject here. It is not going to help. So I'm totally against PRP. I have never given a single injection of PRP because I believe arthritis is an aging problem. You cannot cure aging with an injection.
Thank you. We'll conclude the session 4.
Okay, thank you, sir.
Thank you, sir. We now move on to the fifth session of the day. I welcome the chairpersons for the session, Professor Dr. K. Venkatakrishnan, sir, Senior Consultant Physician and Diabetologist, SIMS Hospital, Chennai. Dr. M. Jai Ganesh, sir, Consultant Diabetologist and Physician.
Start, sir. So we'll go to the session 5. So first of all, I call upon Dr. Sabanayagam V, He is the director of multidisciplinary ICU, MGM group of hospitals. His area of interest is adult intensive care, ECMO, and also mechanical cardiovascular support. Sir is going to talk about hyponatremia. Hyponatremia, we all know, it is a very, very crucial part in intensive care. Sorry. So, speaking on hyponatremia, I welcome you, doctor. Please go ahead.
Good afternoon, everyone. My name is Dr. Sabha. I'm an intensivist working in Chennai over here. So it was a fantastic talk, the previous one from Dr. Saravanan. Unfortunately, I do not have too many nail-biting clips of that sort, or I don't have pictures of any of my pretty patients over here as well. But what I do have is one of the bread and butters of both general practice as well as inpatient setup, which that is hyponatremia, which is one, it is grossly under-recognized, and a lot of times because of the under-recognition, it's not well treated as well. So just jumping into the topic. The next 20 minutes, I would like to get into the definition of hyponatremia, how it is classified, how do we diagnose hyponatremia, there are different varieties of hyponatremia, and based on the diagnosis, treatment, and some of the pitfalls, in spite of having lots of mechanisms to diagnose the condition, we still have certain pitfalls. Some of the facts are that it's one of the most common electrolyte disorder, and in general practice, almost 10% of the patients you would encounter with hyponatremia, and in hospital practice, it's up to 30% of hospitalized patients can have hyponatremia, to the extent that when we see sodium levels of around 130, 127, 128, we almost like brush it aside, saying that, oh, that's fine. You know, it's become so common. And the other problem with hyponatremia is the varied presentation is one thing, and it also occurs in varied conditions. So it is not a particular set of patients who you encounter hyponatremia with. And the other factor is that, on the contrary to what most of us believe, it is not a disorder of sodium, it is a disorder of water. And what you would see in these patients is, it's just the imbalance between the water and sodium levels. You would expect in homeostasis to have equal amounts of water and sodium in a body. But what happens here is, there is excess water. Almost always there is normal sodium in the body. So it's a problem with the water, not a problem with the sodium. And a lot of times it's caused by imbalance in antidiuretic hormone. So the definition of hyponatremia is based on various different factors. The most common one based on the value of sodium is, we all know the normal sodium, we say somewhere around 135 to 145 is normal. Mild hyponatremia is 130 to 135. We call it moderate hyponatremia, and it's 125 to 130. And anything less than 125 is severe hyponatremia or profound hyponatremia. And based on how quickly hyponatremia happens, commonly it's called as acute hyponatremia if it happens less than 48 hours, and it's chronic hyponatremia if it happens more than 48 hours. And how do we understand that? It's mostly from the clinical picture we get to know whether it is acute or chronic, because when a patient comes and gets admitted in the hospital or comes to the outpatient, we never know what the previous value was in the last 48 hours. So it's almost always based on the clinical history. So just to give you a few examples, it can be a post-operative phase. The patient could have just had a major surgery and could have possibly come to you with a hyponatremia. And a patient could have had a major exercise or some sort of physical activity, following which polydipsia and secondary dilutional hyponatremia. So there are various conditions, clinical conditions, from which you can diagnose whether it is an acute or a chronic hyponatremia. Now what happens is, most of the manifestations of hyponatremia are neurological. There are very few non-neurological manifestations which would concern us, but most of them are neurological. And what happens is, there is an edema of the neurons in the brain. And as a compensatory mechanism, brain tries to increase the osmosis inside the cells and tries to push out the excess water. And this compensation, it normally tries to do it within the 48 hours period. And that is the reason we have quantified the 48-hour period to differentiate between acute and chronic hyponatremia. If the brain had tried in the last 48 hours to correct the CNS effects of hyponatremia and still not able to do that, then it moves on to the chronic phase. So that's the reason we have this 48-hour period. And some of the other important definition on how hyponatremia is quantified, because it is based on these definitions of hyponatremia that we decide how urgently the intervention has to be done. Okay. Now, if the patient has got a moderately severe hyponatremia, then the symptoms would be mostly non-neurological. There could be nausea, there could be vomiting, sometimes confusion, headache. You would see that this is not as severe symptoms, but these are moderately severe symptoms, and these patients have a very high chance of going into a severe hyponatremia and thereby being severely symptomatic. So when would you call it a severe hyponatremia or the symptoms are severe? When the patient has major neurological findings like severe encephalopathy, seizures, comatose patient coming with a cardiorespiratory distress. So these are some of the major symptoms or severe symptoms, and these would prompt you that this patient requires an inpatient admission and an immediate intervention for the hyponatremia. So, and then the next group of definitions or classification is to try and give you an idea what could be the possible cause of the hyponatremia. What we saw until now tells you the severity and the acuity, and that helps you decide on the intervention, how urgently it has to be done. Now, the classification from this point onwards will give you an idea about the cause. So hyponatremia can be hypertonic. So what we always tend to do is try and understand what is the serum osmolarity. Now, if the osmolarity is normal, it's an isotonic hyponatremia. If it's high, it's a hypertonic hyponatremia. And if it's low, it's hypotonic hyponatremia. And based on this, we try to identify the cause of hyponatremia. And then finally, the condition is also classified based on the patient's volume status. And it is purely based on the clinical examination. You really need to go to the bedside, assess the patient, and understand the volume status. Is the patient grossly edematous? It's hypovolemic hyponatremia, hypervolemic hyponatremia. If the patient is euvolemic, then it's euvolemic hyponatremia. And a lot of times the euvolemic hyponatremia, as it starts with the E, the conditions are endocrine reasons. So euvolemic hyponatremia would see in endocrine disturbances like SADH, you would see in adrenocortical insufficiency, you would see in hypothyroidism. These are some of the common endocrine abnormalities. So that's how I remember euvolemic endocrine. And hypovolemic hyponatremia, where you know that on your bedside examination, your patient is clinically totally dehydrated. So it means that patient has not just lost salt, patient has also lost water. That's why they are hypovolemic. And where can the loss be from? It's usually from the gut, GI loss, a severe vomiting or a severe diarrhea, or it could be from the kidneys. So these are two conditions, the two areas through which patient can lose both the salt as well as water. That's hypovolemic hyponatremia. And hypervolemic hyponatremia, as I said, the patient is totally edematous, and in this condition, it's all organ failures. It could be a heart failure, it could be a renal failure, it could be a liver failure, it could be a hypoalbuminemia, it's a tongue twister for me, due to nephrotic syndrome. So all failures will cause a hypervolemic hyponatremia. Now, to get to know what is the cause and to treat the cause, these are the diagnostic steps. Number one, thorough clinical history and examination. Number two, measure the serum sodium levels. You have a high index of suspicion, prove it by doing the sodium levels. But when you do the sodium levels, also do a serum osmolarity. The next thing is, when you're doing your clinical examination, try to assess the volume status of the patient, because that's one important step which helps you identify the cause. And then a urine osmolarity and a urine sodium. Now these four parameters, a serum osmolarity, serum sodium, a urine osmolarity, urine sodium, these four parameters will help you understand what is the cause of it. Clinical presentation, again, as we saw before, it's predominantly neurological, And usually those patients who present with severe neurological symptoms would be acute hyponatremia, which would occur in the 48 hours. Usually the chronic hyponatremia patients, they try to compensate as much as possible, and the symptoms a lot of times could be very subtle. It could be simple gait disturbances, it could be an ataxia, it could be memory loss, it could be a simple confusion, it could be nausea, vomiting. So a lot of times it could be misleading towards some other problems. But then even chronic hyponatremia, when it becomes severe enough, you can have encephalopathy, coma, and seizures. And it's very important to try and understand what are the pre-existing medical problems. As we saw before, if the patient has got a cardiac failure, it could be a hyperolemic, renal failure, liver failure, nephrotic syndrome, hypoalbuminemia conditions, hyperolemic hyponatremia. Patient has got on thiazide diuretics, it could be a renal loss. Patient has got some sort of a renal problem, it could be one of the renal conditions which could have led to a hypovolemic hyponatremia where there is loss of salt and water. Some GI problems could be a nasty vomiting or a diarrhea, could be a GI loss, hypovolemic hyponatremia. History of hypothyroidism, history of patient having got some sort of a CNS tumor, a recent surgery, could be an SAADH. It's an endocrine clause, so it's a euvolemic hyponatremia. So history is very, very important here. And again, these are some of the clinical signs, bedside symptoms, signs and symptoms that you would use to try and understand the volume status of the patient. Now moving into the algorithm over here. So what you see is, as we discussed before, the first thing you do is a serum sodium and a serum osmolarity. Okay, and then the most important question which comes over here is, what is your serum osmolarity? Any serum osmolarity which is less than 275, it's a hypoosmolar or a hypotonic hyponatremia. And then the next question that you want to ask yourself is this an acute or a severely symptomatic patient? If that is the case, you don't have to worry about the cause of hyponatremia at all. You just directly go into treating the patient with hypertonic saline because it's a severely symptomatic. I'm talking about neurological symptoms. But just in case, if the patient does not have severe symptoms, you have time to treat the patient, you have time to treat the cause. You just go and look at the urine osmolarity. Is the urine osmolarity greater than 100 or less than 100? If the urine osmolarity is less than 100, which means that you have a dilute urine. So basically you're talking about the patient has had a primary polydipsia or a condition called as a beer potomania where people just drink a lot of beer, and it could be a low solute intake, which means a low sodium intake. So this is an important determinant, the urine osmolarity, which will give you an idea what the cause could be. If in case the urine osmolarity is greater than 100, the next thing is you look at the urine sodium concentration. 30 is the magic number over here. If the urine sodium is less than 30, it technically means that the patient is probably having an organ failure, which is the conditions causing hyperolemic hyponatremia. It could be a heart failure, it could be a liver failure, it could be nephrotic syndrome, provided the patient is hypervolemic. Whereas if the patient has got a hypovolemia, as we saw before, and the urine sodium is less than 30, then it could be some sort of a loss. Usually it's a diarrhea or vomiting or some sort of a diuretic that the patient has had, usually thiazide diuretic. And then the next arm, where your sodium concentration is greater than 30 millimoles, it is usually there is a loss of salt as well as water. So what you should consider is it a renal loss or is it an extra renal loss? So there is a loss of sodium. That's why the sodium in the urine is greater than 30, and then there is loss of water as well. So it could be diuretics, that's a thiazide, or it could be a kidney disease. And if in case the urine sodium is not greater than 30, then you're looking at extra renal loss. It could be GI loss. So it's very important that you have this algorithm to your mind so that you try and understand with the help of those 4 parameters, your serum osmolarity, serum sodium, urine osmolarity, urine sodium. These are 4 important parameters which we tend to use to try and identify the cause. Now, what can be confusing is a diagnosis of SIADH. As I said, SIADH is more than 50% of hyponatremias that we deal with as an inpatient setup could be because of SIADH. So there is a separate diagnostic criteria to diagnose SIADH. There is a set of essential criteria. There is a set of supplemental criteria. It is very important that the patient meets all essential criteria to be diagnosed as SIADH. It's usually a diagnosis of exclusion. You should have a euvolemic patient. You should have a serum osmolality less than 275, and you should have a urine osmolality greater than 100 milliosmoles. And you should have excluded an adrenocortical deficiency. You should have excluded hypothyroidism. That is when your patient fits into SADH. The supplemental criteria, they add on, they boost your diagnosis of SADH, but the essential criteria should all be met. And before you go on, most of the hyponatremias that you face in the hospital are hypotonic hyponatremias, which technically means that you're ruling out the isotonic and hypertonic hyponatremias. This is the slide which gives you an idea of what are the common causes of isotonic and hypertonic, but a lot of these are clinically not very relevant. And one important pitfall is that you have to check your patient's blood sugar levels when you're looking for your sodium. There is always a correction for sodium according to your blood sugar. If your blood sugar levels are high, your patient's sodium might be falsely low. So this is a table which gives you the corresponding blood sugar and the sodium levels, which is the correction. Now, goals of treatment is, number one is you have to, the most important thing is if the patient has got a severe hypernatremia, patient needs rapid stabilization, patient needs hypertonic saline. And the second thing is, where are you going to admit the patient? Are you going to treat the patient as an outpatient or as an inpatient? So a lot of times if there is a neurological symptom, and if it's severe, patient always requires an admission for two reasons. One is for monitoring, other reasons is to ensure that your correction goes at the optimal rate, you're neither overcorrecting nor undercorrecting. There is not many treatment modalities available to treat hyponatremia. The most important being treating the cause, irrespective of what it is. Hypotonic, hypovolemic, euvolemic, hypovolemic, irrespective of the cause, the most treatment is treating the cause. The next important treatment is fluid restriction. Only then comes all the drugs, the medications that we use. What we commonly use in an inpatient setup is, for emergency purposes, we use 3% saline. Sometimes normal saline if the patient is hypovolemic, so that we give both fluid as well as salt. And then in the hypervolemic group, we use diuretics, the renal failures, cardiac failures, and all those patients. And tolvaptans, there is a mixed opinion when it comes to recommendations. Not many guidelines recommend tolvaptans, that we will see. And then management, okay, right. Now this algorithm gives you an idea of how to manage the patient. If the patient comes in with severe symptoms, there is no doubt, immediately the first hour is treated as an emergency management. You end up giving 3% saline as a bolus, 150 ml of hypertonic saline given over 20 minutes. The idea is to try and ensure that you bring your sodium levels by at least 5 millimoles from the baseline value in the first hour. You prevent further cerebral edema and you prevent further neurological complications, because cerebral edema for a protracted period of time can cause permanent neurological damage. And then the other common ones that you can, once you give the 20-minute bolus, then you can repeat the serum sodium and you can give further boluses of hypertonic saline as well. Obviously, this has to happen in a highly monitored environment, either in your emergency department or the intensive care unit. It cannot happen at a ward level setup. The other common ones is that do a detailed assessment to try and understand the cause, and whatever offending medication or whatever has caused possibly the hyponatremia has to be stopped. The golden rule for treating these sort of severe patients is get the sodium levels by at least 5 millimoles in the first hour with the help of hypertonic saline boluses. And then try not to cross more than 10 millimoles in the first 24 hours. And try not to cross more than 8 millimoles every 24 hours thereafter until you reach a point of 130. That will be a target. If my patient comes in with a sodium level of 105, I want to get it up to 130. So my target is 25. In the first 24 hours, I increase it by 10. I take it up to 115. And then from next day onwards, I only want it to go up by 8. So for me to get to 130, I take almost 3 days. And beyond 130, I'm not even targeting. I'm stopping all my treatment which I've been giving to increase the sodium levels, but I will continue to treat my cause. So that is very, very important irrespective of the cause of hyponatremia. And then The next subset of patients that we see here is those patients who come in with moderately severe hyponatremia, pretty much the same. These patients who come in with a moderately severe, they already have neurological symptoms, which means that they are running a high risk of going into the severe category. Here, you do end up giving hypertonic saline, 3% over a period of 20 minutes, 150 mLs, and then reassess your sodium levels, and the same again, like 5 millimoles over the first 1 hour, and then not more than 10 millimoles in the first 24 hours. And then the next category is those patients who come in with acute hyponatremia, which is developed in less than 48 hours, but do not have symptoms. So here you have time. Here you have time to assess the cause and then treat the cause. You're not in a rush here. But then when you are actually monitoring the sodium, if it drops by 10 millimoles, your patient comes in with 125, and then in the next few hours, it's 115. Here, there is an acute drop, so you have to treat this patient with hypertonic saline so that you prevent further drop. Chronic hyponatremias, again, are the major problems. I think I'm going to overshoot my time. Sorry, not much, probably a couple of minutes. Sorry. These are major problems. These are more difficult to treat, but then what is very, very important in treating chronic hyponatremia is these patients, they usually do not come in with severe symptoms. A lot of times they come in either asymptomatic or with very subtle symptoms. So here, a lot of times you do have enough time to identify the cause, and if it is a mild hyponatremia without major symptoms, do not rush to give hypertonic saline or any form of sodium. A lot of times what they require is treating the cause, maybe fluid restriction, maybe diuretics if it is hypervolemic, depending on the cause. A lot of times they do not require any aggressive treatment. What they require is identifying the cause and treating the cause. The next category, again, as we saw before, in hypotonic hyponatremia, there are 3 categories: euvolemic, hypervolemic, and hypovolemic. The first category that you're seeing here is reduced circulating volume, where the salt is low, water is also low. Treatment is easy. You can give normal saline. Instead of hypertonic saline, here you give normal saline, which gives both salt as well as water, depending on what the patient's fluid status is. Here the priority is to try and normalize the fluid status, irrespective of whether you're going to increase the sodium or not. But then, end of the day, do not increase it more than 10 millimoles in 24 hours. The next category is the increase in extracellular volume. It's a hypervolemic hyponatremia. So typically, the organ failures, as we saw, cardiac failure, liver failure, renal failure, and a lot of times identification of the cause. Diuretics can help in this subset of patients. Tolvaptans do not help. Most of the recommendations are against it. Demiclocycline do not help. Almost all the recommendations are against it. The last subset is the endocrine basket, usually SAADH. Again, the treatment here again is straightforward: fluid restriction, nothing more than that. And try and identify what could be the possible cause of SAADH. There are 2 guidelines, and there is an American guidelines and there is a European guidelines. And only in the American guidelines, there is a very soft recommendation for tolvaptan, saying that if in case you are not able to achieve an improvement in hyponatremia in SAADH with just the fluid restriction alone, you can think about tolvaptans. In the European guidelines, they recommend against using tolvaptans, both in SAADH as well as in other forms of hypervolemic hyponatremia. And the most important reasons is, when you give tolvaptans, you lose control over the increase in sodium levels. Now, as we said before, hyponatremia can cause cerebral edema, can be quite damaging to the neurological system, but at the same time, the correction of hyponatremia, if done rapidly, can also be equally detrimental. It's very, very important that you do not cross the 10 millimole per 24 hours period. And if in case you feel that you're about to cross, you have already crossed, you have to stop your active treatment and you have to reverse the treatment by giving free water, either through your nasogastric tube or IV, most likely IV. So IV free water is what I'm talking about is dextrose, 5% dextrose. Typically, that's what we use. And if in case even that is not helping, you might end up using IV or subcut desmopressin to try and reverse the sodium correction so that you don't cross that 10 millimoles per 24 hours. As I said before, the role of Vaptans is quite controversial. Yes, theoretically it sounds like a very good drug, but unfortunately the recommendations are not there. Not at all. The European recommendations recommend against it. The American recommendations give a very soft recommendation that it can be used if fluid restriction has failed as a first-line therapy. So the take-home points here is that most of the hyponatremias are chronic. Most of them are mild, asymptomatic. There is no rush in giving any form of salt, try and correct it. The most important thing over here is identify the cause and treat it. And if the patient has got a severe hyponatremia, then it's very important you jump in and ensure that you correct the sodium levels so that you don't cause any further neurological problems, simultaneously ensuring that you monitor the sodium closely, you don't cause central pontine myelinolysis, which is caused during rapid correction of sodium. And these patients have to be monitored in a HDU or an ICU setting whilst you give hypertonic saline. And again, these are points that we have already seen. In the interest of time, I'm going to skip through. And so during the diagnosis, it's very important that you exclude isotonic and hypertonic hyponatremia, because these are not the ones that you commonly see. What you commonly see is hypotonic hyponatremia, or the osmolality is low. It's very important you assess the volume status. It's only based on your volume status you treat the cause. And lastly, monitoring of serum sodium is very important, because both low as well as high or rapid correction can cause damage. Thank you.
Thank you very much, sir, for wonderful deliberation on hyponatremia, which is a very critical point. The mortality is very high if you don't treat properly or identify the cause. And hyponatremia, as you rightly mentioned, it is a sign of neurohormonal activation. 3 hormones, angiotensin 2, vasopressin, and certain catecholamines are released. That is the one causing arrhythmias and the common cause of cerebral edema. Thank you very much, sir. What one doubt is that because the mortality is high with this hyponatremia, is there any way to identify it clinically early, even before the patient develops symptoms? Once develops symptoms, later in ICU, mortality is high. If you are having an idea to early recognition, like hypoglycemia and other conditions, if you are able to identify it, you can prevent the severe form of hyponatremia. Is there any way?
Good question, sir. It's high index of suspicion, I guess. I can't think of anything else, because there is a particular subset of patients who are prone for hyponatremia.
Absolutely.
And as a clinician, I think we should have a very high index of suspicion for these patients. Try and ensure that at least these patients are regularly monitored for hyponatremia, so that before they get to that, that severe symptomatic part of it, we can try and intervene. When we see a lot of patients who come in the borderline, like 125 and above and all that, they have low values, but they are not symptomatic. Maybe if we catch them at that level also, we can prevent further worsening of hyponatremia and thereby further damage. I guess.
Parkinson. Actually, what we found was in study, 100 patients, early loss of appetite is a early symptom of hyponatremia. Any person, elderly individual, comes with a loss of appetite, fatigability, tiredness, no other symptoms. Look for sodium. You give sodium solution, become all right. That's what we observed in 100 patients. Out of 100 patients, 80 patients gave this history.
Understood. A lot of these elderly patients, especially, the symptoms that they present with the chronic hyponatremia are quite non-specific. As you correctly said, GI symptoms are quite prominent in these patients. Even the neurological symptoms, they are not overt because they are not able to express themselves in Parkinsonism. They come in with very subtle signs, like, as I said, ataxia, gait disturbances, not being able to focus, not able to concentrate, memory, dementia. All these can be symptoms. Unfortunately, a lot of them are non-specific.
Thank you very much. Thank you very much, sir, for wonderful deliberation.
Can be, madam. A lot of times it's directly associated with the SAADH. Can be one of the reasons. Encephalitis too can cause SAADH, you're right.
Sir, for interest of time, please, we conclude. We have a lot of things earlier.
Since algorithm is available, will there be any role for artificial intelligence in identifying those who are about to develop hyponatremia, so that early substitution of treatment can be done immediately?
Okay. Okay. So, sorry, sir, I'm not aware of it.
Due to lack of time, we'll proceed to the next talk. Thank you, sir. So, next topic, we will move on to the urology topic. So, regarding ureteric colic, we call upon Dr. D. Venkata Subramaniam. He is from Ainu. He has did his MCH from Sri Ramachandra University. He has done a lot of work for past 10 years in the urology. Please give him a big hand. Yeah. So he's going to talk about management of urinary colic. Over to you, sir.
Thank you, sir, for the kind introduction. At the outset, I would like to thank Dr. Natarajan, sir, and other distinguished members of the D Club for this wonderful opportunity. It's a pleasure that we're given an opportunity the third year in coming. I at least make sure to come to see all the consultants in their super dapper attire, and they look fabulous as usual. So it's a very practical topic that has been given to be discussed, management of urinary colic. Because not only as urologists do we see it day in and day out as bread and butter, I'm sure as clinicians we all come across this in our day-to-day practice. So this is my area of territory, the genitourinary system, and in particular, the ureter, which connects the kidneys and the bladder. And when a stone comes and lodges, the pain is going to be unbearable. So we'll look at the topic in detail. So it's the most common, by and large, urological emergency case that we see in the ER. And I think the word colic is a misnomer because the pain is continuous and quite intense. So depending on the location of the pain, one can vaguely tell where exactly the stone is present. So typically, it's a flank pain that the patient describes. So more often than not, upper ureteric calculi present with flank pain. And if the stone migrates into the mid part of the ureter, the pain radiates typically from flank to the anterior abdomen. The more distal the calculi is there, in the distal ureter and the vesicoureteric junction, the symptoms are more like urinary tract infection. They get a sense of urgent sensation to pass urine. They feel that the urine is blocked. So all those symptoms set in when the stone is in the vesicoureteric junction. And typically, the pain can also radiate to the genital region when the stone is more distal. Hematuria is often associated with ureteric colic. As much as 85% of the patients do have this symptom. Fever with chills. Now, if the patient with ureteric colic comes with this particular symptom, we have to be very cautious, as there can be an underlying UTI and more significantly, urosepsis, in particularly immunocompromised diabetic individuals. And more often than not, a ureteric colic is always often associated with nausea and vomiting. Right, so what are the common sites of obstruction in the ureter itself? So as we all know, there are three physiological narrowings in the ureter. The first is the pelvic-ureteric junction. The second is the site of the iliac vessel crossing, where the ureter is crossed by the iliac vessels near the pelvic brim. And the third and most common area where ureteric stones get lodged is the vesico-ureteric junction, because the intramural ureter is the most narrowest part. So majority of the ureteric colic occurs when the stone gets obstructed in these areas. Now, what is the mechanism of ureteric colic? So whenever the ureter is blocked by a stone, there is going to be an increase in the wall tension, and this rising pressure causes local release of prostaglandins. The prostaglandins cause vasodilatation, which induces diuresis. So basically, it's a reflex mechanism to push the stone forward. So when that happens, if the stone is going to be impacted, it further increases the intrarenal pressure. The prostaglandins also act directly on the ureter and causes spasm of the smooth muscle. So all this results in intense severe pain. And because the GI and the renal capsule share the common splanchnic innervation, the stretching of the renal capsule causes nausea and vomiting. Now, it is very important to know a few differential diagnoses that can mimic a ureteric colic. Acute appendicitis, acute cholecystitis, pyelonephritis, torsion. So again, like I said, sometimes the stone pain can be referred to the genitals, but in reality, it could be a pathology of the testis, something like a torsion. In females, it could be a torsion of the ovary or an ovarian cyst rupture. Sometimes an abdominal aneurysm rupture can also cause intense back pain and can mimic a ureteric colic. So these differential diagnoses should definitely be borne in mind before making a diagnosis of a ureteric colic. So we should also be aware of some of the atypical presentations of ureteric colic. Like I mentioned, somebody can present with primarily a testicular pain, but when you examine the testis, there may not be any signs or symptoms, but when you do an ultrasound, they may be having a ureteric calculi, and this could be a referred pain. We have seen some patients present with urinary retention. So they would have no prior history of lower urinary tract symptoms. They would have just presented to you with urinary retention. And on evaluation, they could sometimes be having a ureteric colic or a ureteric calculi, which could have precipitated the urinary retention. So sometimes they'll present with UTI-like symptoms. So sometimes they can have severe pain in the urethra. So this patient I came across very recently. He was managed as UTI. He was an elderly gentleman as BPH with UTI. But this gentleman just did not respond to any medications. His ultrasound was normal, urine routine was normal. Very reluctantly, I just asked for a CT KUB, which revealed a vesico-ureteric junction calculi. He didn't have any abdomen pain. He just said, I'm having intense pain in the urethra. Now, sometimes a urethral calculi can also present with such symptoms. The patient will not be able to pass urine, will have severe pain. But this particular gentleman had a stone in the vesico-ureteric junction, which presented with severe urethral pain. And again, when a patient has a lower ureteric or vesico-ureteric junction calculi, he'll have frequent bowel movements as well. So one should have their mind open, because a ureteric colic need not always present typically with a flank to loin pain. Loin to groin pain, yeah. So how do we evaluate a patient with suspected ureteric colic? Investigations is very, very essential. Hemogram to check the level of infection. If a patient is diabetic, please check the sugar levels to make sure the sugars are under control. RFT is very important before we give the painkillers liberally. Uric acid and calcium, particularly if the patient is a recurrent stone former. A urine routine under culture, again for diabetics, and even otherwise to make sure there's no underlying UTI. And CRP if there is suspected urosepsis. Imaging, ultrasound KUB by and large is the first line of investigation. Non-contrast CT KUB is the gold standard. IVU was quite widely practiced in the yesterday era, but hardly being done. It is replaced by CT urogram. But again, I would like to emphasize that for diagnosis of a ureteric stone, a contrast study is not essential. A non-contrast CT KUB is more than enough, and that's what the evidence also says. Non-contrast CT is used to confirm stone diagnosis in patient's acute flank pain, as it is superior to IVU. In case if it's a renal calculi or a large PJ stone which requires a percutaneous procedure like a PCNL, then you might need a CT urogram, because it's going to give you a three-dimensional orientation and multiple other information which will be required to have access into the collecting system. X-ray KUB again is not routinely used as a first-line evaluation investigation, but is useful for follow-up of radio-opaque stones. So as we know, calcium oxalate is the most radio-opaque stone. The other stones are not that radio-opaque, particularly uric acid and xanthine stones, which we don't see quite commonly. So they're all quite radiolucent as well. So non-contrast CT KUB evolves as the investigation of choice for confirmation of a ureteric calculi. The sensitivity and specificity is quite high. The merits being, it can even detect radiolucent stones. It gives you an idea about the hydroureter nephrosis, the parenchymal thickness, the calyceal anatomy, and we can also diagnose other pathologies. Even a gallstone can be picked up, and appendicitis can be picked up. So a non-contrast CT of the abdomen or KUB is the gold standard investigation. Right, so what is the management principle? Our main intention is to manage the pain, vomiting, and the dehydration if present. Now, I would like to emphasize here that a forced diuresis is not practiced anymore, and rather it is contraindicated, because it does not facilitate stone passage, but if it's an impacted stone, it's going to worsen the obstruction. It can even cause a fornicial rupture and result in an urinoma formation. So the idea of fluid management is just to replace the vomitus and to give a maintenance fluid. That's the idea. So giving Lasix or a forced diuresis is not to be practiced. Medical expulsive therapy that we all practice commonly. So it's basically the treatment which uses medication to facilitate stone passage. Less than 4 mm stones are going to pass spontaneously most of the time. So the role of MET comes for stones between 5 mm to 10 mm. But more often than not, if the stone is larger than 6 mm, they don't usually pass spontaneously. So even if we are giving medical expulsion therapy, let's make sure that the duration does not exceed more than 6 weeks. Because beyond that, if the stone does not move from one location to the other, it's going to get impacted and the possibility of spontaneous expulsion is almost nil. So what are the choice of drugs that we have? Analgesics, paracetamol, NSAIDs, opioids. Calcium channel blockers, which was believed to relax the ureteric smooth muscle, but it's not routinely used, it's hardly given up. Alpha blockers, by and large, is the most important medicine that is used for medical expulsion therapy in addition to analgesics. Because the alpha receptors, the distal ureter, the intramural ureter, the bladder are all very rich in alpha receptors. So alpha blockers inhibit the basal tone, decrease the peristaltic wave frequency and the ureteric contraction, thereby resulting in pain relief and, more importantly, expulsion of stones. Now again, corticosteroids is believed to reduce inflammation and ureteral edema. But let's see what the evidence says about all the drugs that we discuss. So yes, medical expulsive therapy is very efficacious for treating patients with ureteral stones. The greatest benefit is for stones more than 5 mm in the distal ureter. Stones less than that is going to pass spontaneously even otherwise. The data is not sufficient to support the use of PDE5 inhibitors or corticosteroids in combination with alpha blockers. And alpha blockers is efficient in causing stone expulsion, particularly in the distal ureteric stones more than 5 mm. As far as pain management is concerned, NSAID is the first drug of choice. Opioids should be avoided because the patient will also be having vomiting, but it's the second line of choice. And if the pain does not respond to NSAIDs or opioids, then decompression or ureteric stone removal should be advised. So before giving NSAID, let's just make sure that the baseline renal parameters are normal. So most of the ureteric colic can be managed as outpatient. So what are the indications for admission? If the pain is very refractory to analgesia, refractory vomiting, if there's underlying UTA or urosepsis, if there is acute kidney injury, solitary kidney or stones in bilateral ureters. These are all indications for immediate decompression or removal of the stone by means of ureteroscopy. Or if the patient is quite sick, at least a double J stent should be passed to relieve the obstruction, or a percutaneous nephrostomy in much sicker patients. Right, so let's look at some of these procedures that we do for removal of ureteric stones. Ureteroscopy and DJ stenting, by and large, the most common procedure that we do to remove the ureteric stones. So commonly performed for stones larger than 6 mm or when medical expulsive therapy fails, and DJ stenting is done following ureteroscopy or for any emergency procedure. So that image shows a conventional ureteroscope. Earlier, the size of these ureteroscopes were about 8 to 10 French. Now, scopes as small as 4 French is available, which is what we use in tight ureters. So this is just a video of a ureteroscopy being done. So we pass the scope into the ureter, and we use a lithotripter. It could be a pneumatic lithotripter, or these days we use laser to fragment the stones. The advantage of laser is that the precision of stone breaking is there and retropulsion. So the stone does not move into the kidney that easily when you use laser. And following lithotripsy and removal of stone, we pass a double J stent, and all this is being done cystoscopically. Right. In case of a upper ureteric stone, we do a retrograde intrarenal surgery. So the image on the right shows the flexible ureteroscope. So the start of the video, what you saw was the ureteral axis sheath, which was placed in the ureter. So that helps in decreasing the intrarenal pressure and reducing the chance of pyelonephritis and other infection that can happen. The stone is then retrieved after laser lithotripsy through the axis sheath. So that's for stones which migrate into the pelvic calyceal system. That's called RIRS. So these two are the common procedures that we do for management of ureteric stones. Now, what are the complications of ureteric stones? So if the stone is not managed in time, 1, it can cause urinary tract infection leading to urosepsis. 2, it can cause urinary tract obstruction leading to renal failure. More importantly, the site of impaction can become a nidus for developing ureteric stricture. So even after the stone removal, the site becomes narrow and acts as a site of obstruction. And if the impacted stone remains for a significantly longer period of time, there can be gross hydronephrosis, thinning of renal parenchyma, and ultimately loss of the renal unit itself. So this is a short video of a patient who presented with urinoma. You could see that there's a collection around the kidney. Almost in the initial parts of the CT, you couldn't see the kidney outline. and he also had an obstructing stone. So in such cases, the idea is not to remove the stone because these patients are going to be quite sick. So in this particular patient, the urinoma was drained by placement of a percutaneous nephrostomy tube by ultrasound guidance, and we placed a double J stent, and you can see some turbid efflux coming. Once the urinoma settles down and the infection settles, we go ahead and do a procedure to remove the offending stone. Now, this is a CT image of a patient with bilateral ureteric stones. This particular patient I operated yesterday. So this was a young female who presented with bilateral obstructing stone. You could see the on the right side, there's an large upper ureteric stone, and on the left side, a lower ureteric stone, both which did not pass with medical expulsive therapy attempted outside for a period of 4 to 6 months. So as a result, you could see that there is significant hydronephrosis on both sides. Again, if the stone gets impacted for a long period of time, there can be ureteric stricture at the site of impaction. So this is a ureteroscopic video. You can see that the scope passes up to a point, and beyond that, the scope is not negotiable because there is a upper ureteric stricture. You can see that in the RGP image on the right side, where the arrow is indicated that there's a significant stricture. So once the stricture develops, it's a very big thing because DJ stenting may not always relieve it, and you may need complex reconstructive procedure in the form of robotic surgery depending on the level of obstruction. If it's a lower ureteric stricture, you will need a ureteric reimplant or a Bovary flap procedure. If it's an upper ureteric stricture, you will need something like a buccal mucosal graft ureteroplasty. So basically, we harvest a buccal graft and do a ureterotomy and augment the ureteric wall. So earlier we were doing for small segment strictures an end-to-end anastomosis, but now the literature says that the vascularity and success rates of these procedures is slightly less. So the buccal graft ureteroplasty is slowly replacing such procedures. But having said that, these are all quite complex reconstructive procedures, and we don't want a stone to end up in such procedures. So timely attention to stones is very, very important. Now this CT image shows a gross hydronephrosis due to a impacted stone. So you can see that hardly there was any parenchyma, and there was a large obstructing stone. So in such cases, when there's hardly any parenchyma, there's no point just removing the stone. It's going to remain as a bag of pus, and it's going to cause subsequent pyelonephritis and repeated UTIs. So in such cases, we do a DTPA renogram, and in this particular case, it was hardly functioning. So we commonly do remove such kidneys because they can be a source of sepsis. It's not uncommon that we had to remove kidneys because of stone-related non-functional status of kidneys. So this is a short video clip of a laparoscopic nephrectomy being performed for the same patient that we saw. So this is the artery and the vein that is being divided. The blood supply to the kidney is divided, and ultimately the kidney is mobilized, the specimen is bagged and removed through a small incision. So this is the specimen, and that was the offending stone. So there's hardly any parenchyma left, and this was done by laparoscopy with a small scar. So a brief note on ureteric colic when we manage ureteric colic in pregnant ladies. It's the most common non-obstetric cause of acute abdomen. It carries a risk of premature labor. Now, we all know that there's going to be physiological hydronephrosis in pregnant lady, which starts in about 24 weeks and increases till 32 weeks. And it's more common on the right side than the left side due to the dextrotation of the gravid uterus. And the left ureter is protected by the sigmoid colon. So in general, pregnant women are prone for urinary tract infection and stone formation. So what I generally advise young ladies is if they have a history of ureteric or renal stones, it's better to get evaluated before a planned pregnancy because our options get very limited once the patient develops a ureteric colic. A low-dose CT theoretically can be performed, but we hardly advise it in pregnant ladies. So we have only ultrasound if required an MRI to diagnose these patients. And the medications are also quite limited because NSAIDs, by and large, we try and avoid, and we try to manage them with paracetamol. Morphine can be given, but again, not routinely used. Alpha blockers like tamsulosin can be given. So most of the stones, because of physiological hydronephrosis, do pass spontaneously in these patients. If required, if the patient has got significant urosepsis, we just try to place a double J stent and do the definitive management of stones once the delivery is complete. Again, a quick note in pediatric patients, the principle is same as in adult management. The size of the stones that we manage conservatively is pretty much the same. CTKUB, again, is the gold standard in pediatric as well, but we try and limit the radiation. We use the principle of ALARA to limit the radiation exposure. So ESWL, ureteroscopy, RIRS that we use for adult patients are all safe and reliable treatment options for pediatrics as well. And if the patient presents at a very young age, we do metabolic evaluation even at the first presentation and a stone analysis as well. I once again thank the organizers for the opportunity. Thank you.
Thank you very much, sir. Very clear and elaborate presentation about a common problem what we face in day-to-day practice. You emphasized on the forced diuresis not indicated because it causes nephrosis and kidney enlargement. And the use of alpha blockers is very useful. And regarding the NSAIDs, which NSAID is preferable? Because no patient having severe acute pain. Which you prefer, which NSAID?
So diclofenac is the most efficient, sir.
Diclofenac.
Followed by ibuprofen or ketorolac. But one dose of diclofenac usually settles the pain.
That settles. And what about the use of potassium citrate? Because citrate, hypocitraturia is one of the common condition which predisposes to stones.
Correct, sir. I intentionally avoided the chemolysis part because it's a very debatable part. Yeah. But in selected uric acid stones, chemolysis can be effective. But when a patient comes and asks you, sir, the kalla karakka mudiyuma appadina, I definitely tell them it's not possible. Because most often the composition, the mixed compositions, sir. But uric acid stones do respond to potassium citrate.
Wonderful. Thank you very much.
One question can I ask?
Yes.
Sir, it was a really brilliant presentation, sir. And
thank you, sir.
I was just interested in one case, sir, which you showed that young female, recently you operated that she had bilateral. What was the cause of the renal calculi in that patient, sir?
Sir, in most patients, when the patient asks, yeah, in the stone, we are most often not able to tell the cause. Of course, we do a baseline blood evaluation, calcium, uric acid, everything is normal. But still, stones are stones. We just blame on the lifestyle conditions and, not drinking enough water and so on. So we're not able to give a particular cause to it. But once, we remove the stone or we manage them conservatively, the most important is the follow-up. We give potassium citrate syrup as we follow them frequently and ensure that repeated procedures are avoided. So for example, if a patient forms a stone again, lithotripsy option is there for even a 1 centimeter stone if it's diagnosed when it's inside the kidney. So follow-up is a very crucial part of the management.
In our hospital, in past 2 years, sir, we collected all the patients who are less than 30 years who have came. And we found out that the patient who are coming, mainly in the males and females, we found out that one cause was Crohn's disease. One patient was having the Crohn's disease. One was having the renal tubular acidosis secondary to Sjogren's syndrome. Another was this endocrine axis. Since residents are there, always I think after giving the treatment, the cause also should be emphasized because after you do wonderfully surgery.
Absolutely. So we do all these evaluations most of the time. But what I'm trying to say is most of the patients don't have any of these underlying conditions.
Very true, sir. Thank you, sir.
Thank you. Sir.
In the case of ureteric obstruction, the calculus, it's the anatomical site
Sir, I'll just answer.
size of the stone.
Sir, can I just
answer? Hydronephrosis.
Sir, can you please come again, sir?
In the case of ureteric colic, where the obstruction takes place, is due to nature of the calculus or the anatomical site that matters most, as far as the hydronephrosis cause is concerned.
Sir, I would say the size of the stone is what matters the most, sir. More than the site is the size of the stone that matters the most. So, certainly, sir. So, it's not a rule that stones up to 5 or 6 mm is going to pass always. Sometimes even a 4 mm stone can cause significant hydronephrosis, and we become very cautious when we operate on such a small stone, because more often than not there is going to be an underlying narrowing or your question, sir. No, sir. Okay, sir. Okay, sir. Okay.
Very valid point, sir.
Okay. Thank you, sir. Thank you.
Next, we'll call upon Dr. Navinath Mohan. Our secretary, sir, will honor him first. So he is working as a consultant nephrologist. Dr. Navinath Mohan, please give him a big hand. At INO Institute, he is a consultant nephrologist and transplant physician. His special interest in renal transplant. Urine analysis, although seems to be a very INACUS test, very small test, but it is of very huge value. So over to you, sir. Thank you.
So thanks a lot, sir. So it's always a pleasure to come back to these meetings of D Club, because the discussion is very rich and we get to learn a lot. And I think I'll always reiterate this. Speaking, for a physician to speak after a surgeon is always a very difficult task, right? So they show all these CTs and these great videos of the surgeries which they do, and unfortunately we don't have any such thing to show. So, but I this time have got a very interesting topic, that is the liquid biopsy of the kidney. So I always start by thanking my alma mater, Madurai Medical College and AIIMS New Delhi. So let's quickly jump into the topic. So the urine. So it's a very simple thing for many of us, but I think the kidney is the only organ which gives you a simple, non-invasive and easily accessible thing. So you have like the CSF or the bile, and all these things are usually not accessible. But the urine is easily accessible and it gives you an insight into the kidney. So no other organ really has it. And it's not only useful in diagnostic purposes, like what is the problem which is going inside the kidney and all those things, you can just find out from a simple urine analysis. So Dr. Venkat was talking a lot about the stones and how the CT and all those things help. But many times, even a simple urine analysis, like seeing the crystals in the urine, can give you what the stone is, rather than doing any great investigations. And the most important thing, so nowadays, if you see, most of the whole body health check will always include a urine analysis. So many patients who are absolutely asymptomatic have no problems at all. Every other test is normal, but only thing might be there's a small abnormality in their urine. And that many times can be an harbinger of picking up a diagnosis. So I'm talking about microalbuminuria over here. And urine analysis also is of great help in prognostication and following up the patient. So you can do urine analysis in many ways. So nowadays, the bulk of the work is being actually done by the automated mechanisms. So you have automated analysis, which most of the big corporate hospitals have. It has its own advantages and disadvantages. The advantages far outweigh. The biggest advantage is that the volume. So you can process even hundreds and thousands of samples within a short period of time and give you a crisp and succinct report. So these are some of the automated urine analysis methods you have. But the time-tested gold standard would always be a complete urine analysis by the nephrologist or by the lab person. Most of the time it's done by the lab person. But even in a primary health center or in a periphery setup or even in your own OPD practice, if you want to pick up some important things, clues regarding the renal problems, you can simply do a dipstick analysis. A dipstick analysis can give you many clues and it's almost instantaneous. So what urine sample should you take for analysis? So this is a question which we get often asked. So the recommendation is always to use the first void sample, but most of the times the first void sample you're not going to get. The patient would have got up at his home and he's not going to come to the clinic right in the morning, and it's almost impossible to get that role. So for practically speaking, many times any early morning sample, even the second morning sample is supposed to be good enough. And you always try to take the midstream sample. So the patient is supposed to leave some of the initial few drops and maybe try to catch the midstream sample. So lots of emphasis I see is being kept on the 24-hour urine sample, but to be very honest, we nephrologists, many times nowadays we don't ask for this 24-hour sample at all because it's very cumbersome for the patient to really collect. You'll have to give a written instruction to the patient how to collect, and he should not miss any sample. So it's really not feasible. So many times we don't really do this. We have now replaced it mostly by the spot urine protein creatinine ratio or the albumin creatinine ratio. One other important thing is always try to take this history. So if it's a planned elective thing, so let us say the patient is going to take a whole body health check, you should advise him to not have any strenuous activity or exercise the previous day, because many times physiological proteinuria will also be a problem. And many times, in females especially, your urine analysis will show microscopic hematuria. You go ask them a simple history of, are they having their periods now? The answer is yes. Then again, interpreting the reports become a difficulty. So this history is of very good importance. And instructing the patient on how to collect the urine sample is of equal importance. So they are supposed to wash their hand, and if it's a female, they are supposed to separate their labia. And for men, you are supposed to ask them to retract their foreskin and only then catch the urine. The other important thing for inpatients and especially patients who are catheterized. So many times we see the urine sample from the back being sent, which should always be avoided. Unless and until it's a very difficult situation where you're not able to get the sample, you should always try to avoid this. Many times what you can do is try to clamp the catheter and take from that, but even then, we really don't recommend that also, because if you're going to disconnect the urobag, it becomes a problem. So many times we use a syringe in the Foley's and then slowly collect how much of urine you can get, especially for culture samples. So how to transport? Now that's the next question. So a fresh urine sample needs to be analyzed as early as possible. So this is not as easy as it sounds, because many times the urine is collected in the ward, and by the time it reaches the laboratory, it's multiple hours, and then analyzing the sample again becomes a problem. So the biggest problem is that the WBCs will start to lie, so it might give you a false report. So if you have to store it for a long period of time, the simplest thing would be refrigeration. You refrigerate it at a temperature of 4 to 8 degrees of centigrade, and then you analyze. It's usually not a problem, but there are some pitfalls. Like there might be some precipitation of the phosphates and urates. So if you really want to look at this, then refrigeration might not be a great thing. There are some chemicals which can be added, but again not very commonly practiced, but again very important for MCQs in PG exams. So what are some of the urinary characteristics? So the stark characteristic which every patient will beautifully tell you would be the urine color. So the commonest color with which the patient will come immediately alarming to you would be the red colored urine. Sir, red color urine poche. So that is one of the commonest things which we get. And obviously there are many causes for a red urine, and the commonest one would obviously be a hematuria. And we need to separate this from a hemoglobinuria or a myoglobinuria. I have a flowchart in the next slide, I'll show that. There are certain other colors which I'm sure many of you all would have seen. So we did have an ICU physician talking over here. One alarming thing which we can see is this purple bag urine syndrome. So many of us would have seen this. So this is predominantly a benign condition. It's because of a bacterial infection, that is sulfatase producing bacteria like Propionibacterium or even E. coli. And it breaks down the metabolites of tryptophan, leading to production of certain dyes which looks like a purple color. But otherwise it's usually many times an infection due to chronic catheterization, and treatment of this infection or just simple change of the catheter will just change this urinary black color. So this is again for the completion's sake. One other important thing which I wanted to bring over here was rifampicin. So any patient whom you are putting on ATT, make sure you tell them that there's a good chance that all their body secretions, not only the urine, even the tears and all their body secretion can become slight reddish orange. So if you don't tell this to the patient, the next day they're going to pass a very reddish orange colored urine and get really worried about it. So this needs to be told to the patient. So that's the image you see over there. And if you have a red colored urine, many times it's usually hematuria, but there's no other clinical significant history, then you can follow this simple flow chart. So all you need to do is spin the urine. If it's the sediment is red, it's many times going to be a hematuria, but if the supernatant is red, then you do a dipstick. If the dipstick is positive, it's going to be either myoglobin or hemoglobin. And if it's negative, then some of the benign causes like bituria and phenoxypyridine and all those things. But more often than not, it's either hematuria or a hemoglobinuria is what we see in our day-to-day practice. And various drugs causing different colors, I've said, they are not very common in clinical practice. But if you see such abnormal colors, you can take this history and then try to correlate clinically. So urine turbidity and odor, again, it's a very misunderstood concept. So many patients do come to us complaining, sir, the urine is very turbid or the urine is very frothy and all those things. So especially with social media, and we keep telling the patient that these things they should be very careful about. So they have become very concerned about this. But many times it's just maybe a UTA or a pyuria which usually comes up. The smell, again, it's a very subjective thing. Many times patients feel they are passing a very smelly urine. Most of the times it's just a UTA which we find. These conditions, those have given it for completion, they are not very commonly picked up just by the urine smell and all those things. One thing which is really of great help, especially in the medicine ward, so my teachers in Madurai Medical College used to commonly say that it's this fruity odor. So a patient who is having a fruity odor urine is many times going to be a DKA. So especially near the diabetic wards, you see this smell quite commonly, and many times it's because of DKA and urine. The other thing, we had a topic on hyponatremia just recently. So he was talking about the urine osmolality and serum osmolality. So again, a very, very important test, especially in the evaluation of hyponatremia, would be urine osmolality. So it tells you about the passage of concentrated materials in the urine. So whenever you are passing a very concentrated urine in a patient who's having hyponatremia, that's very abnormal. So probably an SAEDH or it needs further evaluation. So many times in the labs, whatever urine osmolality they give you is many times actually a calculated one and not a measured one. So very few labs really have a measurement of osmolarity. For that you need some special equipment, but otherwise many times it's just calculated based on the urinary concentration of sodium, urea and glucose. So this is the area which I wanted to focus a bit more on, because I think as general physicians, and it's the most easily available and easily usable one. All you need to get is that dipstick container, and you can do it at your own bedside, and it's really a very, very useful thing. It's simple and very cheap. But whenever I say this, something which is very simple and cheap, it will always have some downsides. The downside is about the false negative and the false positive reports which you can get with the dipstick. So this is quite common. I do commonly face this. So many times you do a dipstick, there's something abnormal, people get really very flustered, there's no clinical correlation, but then it would be a false positive or a false negative report. But one thing which I want you to understand, the downside of the dipstick is that, especially with regard to dipstick protein, the dipstick only picks up albumin. It cannot pick up non-albumin, right? And microalbuminuria is not picked up by dipstick. So if you want to pick up microalbuminuria, dipstick is not sufficient. Only macroalbuminuria is picked up by dipstick, and it will pick up only albumin. It will not pick up non-albumin proteins. So that's why this famous MCQ question, dipstick negative proteinuria is seen in which condition? Multiple myeloma is the answer. So that is a very, very, very commonly asked question, and that's something which is seen clinically also very commonly. So urine pH is very important, because if the pH is abnormal, many of these interpretations become problematic, because I had shown in the first slide also, many of them will lead on to false positive results. So you need, whenever you start interpreting these urine dipstick reports or the urine routine report, you have to look at the urine pH. If the urine pH is abnormal, interpreting many of these reports really becomes a problem. So always, any talk of mine, I always talk about this part, and I'm really happy that nowadays many of the physicians do this urine protein analysis. They do either albumin creatinine ratio or a protein creatinine ratio, which is really great, and it's a very, very important tool in the management of a patient with a kidney disease. But please understand, protein creatinine ratio is a ratio. A ratio can be high either if the numerator is high or if the denominator is low. So before interpreting a PCR, the first thing we need to see is if the ratio is high because the numerator is high or because the denominator is low. That is, a falsely low urine creatinine also will give you a falsely elevated PCR value. So you cannot interpret such reports. Many times it's a lab error or maybe a sample collection error. So the urine PCR is of valid report only if the urine protein is also high. It should not be high because of a low urine creatinine. So that point you need to understand. So this is what I was talking about. It's almost replaced 24-hour urine protein completely. And most of us use the urine albumin creatinine ratio or the protein creatinine ratio. So the KDIGO, which is the nephrology body, also really promotes only ACR nowadays. And it's very good for prognosis and for follow-up. And as many of you all might know, it is a marker of endothelial health and gives you a good understanding about the cardiac endothelium as well. So even if you have microalbuminuria, whether you look at the kidney or not, make sure you look at the heart. Never forget that. Some other things which I'm sure all of you all do use in your day-to-day practice, like for infections, presence or absence of nitrite and leukocyte esterase, etc. So regarding urine microscopy, so now microscopy is an art. So this is a manual examination of the urine, and many times it can give you some curveballs and surprises and give you some really unexplained diagnosis. So how do you prepare the slide? I'm sure all of us have done this in our MBBS days. So you have to take the urine and then do a centrifuge, take the sediment and put it in the cover slip and have a look at it. So even if you might not see it, all those things, all these cells, but there are a few things which I want to share over here. So whenever you have a hematuria, so who handles this patient with hematuria? Is it the urologist or the nephrologist? So this is a question which we'll have to answer, because the prognosis, the management, everything varies. If you have an obvious cause, like say a tumor or a stone, we all know it's going to be the urologist who's going to handle. But many times the patient will come with just an isolated hematuria and you don't find anything else in the imaging. So a simple test by which you can find out whether this is a nephrological cause or a urological cause would be just urine is somewhat dysmorphic, there's a percentage to this. More than 5% of the RBCs are dysmorphic. It's more like, because the bleeding is below the level of the glomerulus. So
persons for the session, Professor Dr. K. Venkatakrishnan, sir, Senior Consultant Physician and Diabetologist, SIMS Hospital, Chennai.
many times urine analysis will give you some beautiful diagnosis. So this is the picture which I wanted to show. So we had a patient, like Dr. Venkat was talking about that patient. Actually, we had a pediatric patient who had recurrent stones. Actually, our surgeons were brilliant enough to say that when they were bursting that stone itself, that this would be most likely a cystine stone because it has sulfur and it produced some bubbles. And this patient's urine analysis showed hexagonal crystals. So presence of hexagonal crystals in urine is a sign of cystinuria. And again, this envelope-shaped crystals is the commonest one, which is calcium oxalate. So even though you might not be able to do a stone analysis in all your patients, even a simple urine analysis and analysis of the crystals can give you some clues, like the coffin lid appearance in the triple phosphate stones. So this is just the envelope-shaped crystals of calcium oxalate, which you can see easily in a urine analysis. So this was an interesting case where they had given sulfadiazine IV and caused this blush kind of a picture. Ciprofloxacin, all these are not very common, but urine analysis can show these things. So every time when the urine analysis shows these findings, you need not be very worried, but many times the drugs which we can give can produce such crystals, and if clinically correlated, you might have to give them importance. So this is just a list of what we had seen earlier. And urine organisms. So many times the question which we ask is, sir, the urine routine shows bacteria, should we treat them? So just the presence of bacteria in a urine routine does not mean it's UTI. Many times you can also have commensals, so you need a urine culture and more importantly, clinical picture. So if the patient is having a clinical features of UTI and a urine culture positive or showing RBCs, then it's of importance. But where it can be of importance would be a schistosoma hematobium, again not common in our part of the world. It's common in Egypt. It's schistosomiasis. So there it's of importance, not over here. So as a transplant nephrologist, this is another one thing which we try to see in our urine. So in our transplant patients who are very much immunosuppressed, and we are suspecting a condition called as BKV infection, we need to do a PCR to really diagnose the condition, but there's something called as a decoy cell, which is an easier and simpler test which can give us the clue. So finally, a question which I was asked previously was, so what would you vote for? Would you go for an automated analyzer or try to do a manual thing everywhere? Practically speaking, I don't think it will be possible to do a manual analysis of every urine sample which you get. So automated analyzer is the way to go forward. So whenever you get an abnormal report or report which is not correlating clinically and you feel it needs a closer look, maybe then you can go for the manual thing, and then I'm sure you'll be able to come to a conclusion. I think I come to the end with it. Yeah, so the simple thing, always make sure all your patients with, whenever you want to evaluate the kidney, make sure you look at the urine. So it's just not about the creatinine value, it's more importantly to look into the urine. And it's very cheap and reliable to use a dipstick. And never forget to order for a urine PCR or an ACR. And glomerular hematuria is a sign of nephrological involvement. And whenever you see this, many times patient might need to be evaluated for glomerulonephritis. So I thank the D Club team, and I finished this with this saying. So this was Dr. Thomas Addis. So what he said is very true, isn't it? So when the patient dies, the kidney must go to the pathologist. But while he lives, the urine is ours. And it can provide us day by day, month by month, and year by year with a serial story of the major events within the kidney. And I don't think any other organ has this. Thank you.
Thank you very much, sir, for wonderful deliberation. A simple urine test guides us a lot of information about the kidney and the systemic involvement. Wonderful. So how frequently you have seen the nematuria? Some people say, I am passing gas in the urine. Yeah. That's one thing. But I've seen 2-3 patients that finally turn out to be emphysematic pyelonephritis. Yeah. And the most common doubt in the practice vision is, we have heard the precipitate, those who are having catheterization for longer duration, elderly, a lot of white precipitations are there. Yeah. The white precipitate, where it coming from? Is it damaged papillary necrosis, something like that? Or any protein precipitation, something? Yeah. That's, yeah.
So it is many times concretions, sir. So what happens is in a long time catheterized patient, these minerals like calcium deposit, the patient will be on some supplements. So all these concretions, they bind to the foreign object, which is the Foley's catheter, and they form concretions. So even recently we had a patient who was on a long-term catheter. They had even formed stones within the bladder and had all these concretions. So for patients whom you cannot avoid the catheter for a long period of time, the only thing is regular changing. Like the spinal injury patients where you cannot do much and they need to be on a long-term catheter. So once every 3 weeks or something like that, we might have to change. So if you're using a silicone catheter, maybe you can have it for a longer period of time. But unfortunately, you'll not be able to escape from these concretions. And the chance of infection is again very high. So there is no simple answer to this. So if they have systemic features and they are infected and having fever and all those things, you will have to treat them. But otherwise, giving them antibiotics would not be a great idea.
Is it need to wash the bladder in those individuals?
So the problem is, sir, whenever you try to do that, you introduce infection.
Okay, that's
and that becomes even more deleterious many more times. Yes, sir. Normal shedding also will be there, but sir was talking about the concretions, like the white deposits which you see. It's many times the minerals and all those things which get said. The urine always has these minerals, the calcium and all those things. So they usually get deposited and lead on to these concretions. So usually they say up to 6 to 12 weeks is what people say. No, ma'am. So that needs separate chemical analysis. So I had put that, but I didn't talk about it. So the BJP, so you need to do a separate test for the Benz-Jones protein. But to be very honest, again, nowadays we have gone for the evaluation of the blood, the M-band and all those things. So many times we don't even look for the BJP, but we have many other clues by which we can pick up. So we don't have a simple test or a urine analysis by which you can say that this is a Benz-Jones protein. So you need to do a heating and cooling test for that. Sir? Yes, sir. So that's why I said we have much more sensitive tests nowadays for multiple myeloma, so we don't go for the Benz-Jones protein nowadays. So we go for more like a urine protein electrophoresis or a serum protein electrophoresis, serum-free light chain assay. So they are much more sensitive than the urine Benz-Jones protein to diagnose multiple myeloma. Again, I might not be the right person to answer that, ma'am, because I'm a nephrologist. I don't see many patients with multiple myeloma, to be very honest. I think we'll have to ask the medical oncologist. Maybe they'll be able to tell in a better way.
Due to lack of time, thank you, sir. Thank you for very great presentation. We'll give a big hand. We'll conclude the session. Thank you.
Thank you, sir. We move on to the last session for the day. I request Chairperson Dr. M. Swami Kannu, sir, Senior Consultant at MGM Hospital, and Dr. A. Natarajan, sir, Senior Consultant Diabetologist, to come up on the stage.
we'll go to the last session, and the speaker is going to be A.M. Karthikesan. He's going to use talk on clinical uses of ABPM and Holter monitoring. This morning only we were talking about time in range for the hypertension. So ABPM is going to be one of the tools to diagnose masked hypertension and white coat hypertension. So it will be a good tool, and also confirm that sometimes you check the blood pressure in the clinic, it is normal. When they check, it is outside, it is abnormal. So all these problems can be solved with the use of ABPM. And also he's going to talk on Holter. Without much ado, we'll go to the topic straight away. Over to you.
So, respected chairpersons and my dear colleagues, good evening one and all. At the outset, I would like to thank the organizers for this wonderful opportunity to share my thoughts on this topic. It's a very, very basic topic which is very, very useful for practicing physician as well as the cardiologist. So, clinical uses of ambulatory BP monitoring and Holter monitoring in our practice. So just I'll make it very simple. I'm not going to talk about how do you manage hypertension or anything. So how do you utilize these devices so that how it will help us to better management of hypertension. So first of all, what is it? So many of you are aware of that, but it is still lack of awareness is the main, even the survey conducted recently in India. So the lack of awareness among the physicians is the major hurdle to utilize this optimally, these devices. So what is it? Why should we use it? When should we use it? These ambulatory BP monitoring devices. Ambulatory BP monitoring is nothing but a BP monitoring technique by oscillatory method, the duration of 24 hours or more. Usually we use it for 24 hours. It records every 50 to 30 minutes. By an average, usually it records every 20 minutes, probably every 30 minutes during night time to avoid little disturbance. So at least you should record properly, 70% of the recording should be proper. And so at least 20 valid awake measurements, 7 valid sleep measurements should be good to say that the appropriate recording has been done. This has been time and again shown that ambulatory BP monitoring is superior and more precise in terms of actual BP measurement rather than office measurement of blood pressure. All over the world, not only in India, the entire world is most of the time it is diagnosis, therapeutic, hypertension has been managed, diagnosis established and treatment initiated and followed up, everything with office BP measurement. We know that the limitation of office BP measurement out of office BP management, that is real life BP measurement, has a real value in terms of diagnosis as well as the therapeutic control when you initiate antihypertensive medication. So why should we use ambulatory BP monitoring? Hypertension is a major thing, so I need not emphasize on that. Hypertension emerges as one of the leading cause in globally is the premature morbidity and mortality. And it is a major risk factor for coronary disease, cerebrovascular disease, chronic kidney disease, heart failure. And, but one important thing, it is a modifiable risk factor. When you diagnose it and pharmacologically or non-pharmacologically, if you are able to control the hypertension, you can reduce these risks significantly. So the diagnosis and appropriate medications and confirmation of that our medication is working, it is very important to use these ambulatory BP monitoring devices so that you can reduce the significant impact on this, all those end organ damages and complications of hypertension. So office BP measurement is a snapshot BP, so many times even patients themselves, they don't accept it, so somehow they come to denial, it is only when I come to the hospital, only the BP is high, doctor. This is a common statement made by every patient. So it is, in reality also, it is not reflecting their day-to-day activities. There is a diurnal variation when they expose to their work or family, environmental things. Their BP always fluctuate. BP never going to be a constant things. So we always measure the real life scenario rather than emphasizing on one BP measurement, what we measure it in office, and then initiate the treatment and follow up the treatment during that one BP recording. So it avoids the false BP measurements, and it is also gives a diurnal variation, circadian variations. All those things can be measured when you continuously monitor for 24 hours. In clinical practice, ambulatory BP monitoring gives not only diagnosis and prognosticate and therapeutic utility is there. So I will just highlight subsequent slides. How do you utilize these devices for not only for diagnosis and also prognosticate and therapeutic utility in these devices. So why should we use this ambulatory BP monitoring? Why we should not just every clinic we have the BP apparatus, just measure the BP and forget about it? Why we should do it? And the common thing is patient also asks, another thing is I have a home apparatus at home, let me measure the BP also. So why should we use this ambulatory BP monitoring and the pain of wearing the cuff for 24 hours and recording it and analyzing it and go through that? Most important thing is white coat hypertension. The patient comes to the office, BP is high, in-house, out of office, his BP is normal. There is a common scenario, we see it. And that's what the patient also tried to tell us. It's commonly we hear from the patient itself using the terminology of white coat hypertension. When you say BP is high, this is a white coat hypertension, doctor. How do you prove it is a white coat hypertension? So you have to prove it the other BP is normal, in out of office BP is normal. Then only you can accept this is a white coat hypertension. And out of office BP also high, then you cannot call it as white coat hypertension. So that is only possible by, even though you can use it home monitoring devices, but if you use ambulatory BP monitoring devices, your value will be more precise and it's for the diagnostic utility. Other Dr. Chairperson mentioned masked hypertension. In-hospital BP is normal. So you have some clinical evidences of hypertension, so some symptoms or the echo shows or ECG shows evidence of LVH or something, you suspect that that patient might be having hypertension. So, but when your office visit is normal, unless you do the ambulatory BP monitoring, then you pick up the masked hypertension. The recent data published in India also shows that there is a significant number of masked hypertension there in India. So it's not that only white coat hypertension is there, it's a significant number of masked hypertension also there. So the clinical suspicion should come from the physician based on this clinical evaluation of the patient to pick up this masked hypertension only by using these ambulatory BP devices. Not only this diagnosis point of view, and treated patient, hypertensive patient on medication, when they visit us and follow up, again BP is high. Is it really controlled at home and white coat uncontrolled hypertension? So how do you prove it? So his BP is on medication, out of office BP is under control, then only we can say is when you come to the office only BP is high, so you can white coat uncontrolled hypertension we can say. Similar way, masked uncontrolled hypertension. First of all, you should pick up the masked hypertension, then that masked hypertension is under control or not, you should have to monitoring the devices at 24 hours, then only you say that is controlled or uncontrolled. These things are important. All four things, masked hypertension, masked uncontrolled hypertension, white coat hypertension has a significant impact on the cerebrovascular, cardiovascular impact. It has increases the cardiovascular diseases and cellular diseases. So it is very important for the physician, those who are managing the hypertension, to use these devices and appropriately maintain this hypertension, adjust the therapeutic medications. Most important is resistant hypertension. Patient who was on 3 or more drugs on antihypertensive medications, instead of keep escalating the medications, put these devices and ensure that the patient really needs more medication or not. So it is without confirming it, keep on going and escalating the medication. Only on the office to visit BP is not recommended. So you want us to use these ambulatory BP monitoring devices before escalating the medication beyond 3 medicines. Nocturnal hypertension is a very huge impact on the cerebrovascular events. So the patients, normally our BPs are expected to be 10 to 20% lower than the daytime awake BP during sleeping time. But instead of that, the opposite happens. During sleep, it is escalating or is rising. It has a huge impact on the cerebral damage. Other important thing is, this is impossible to measure nocturnal hypertension during sleep. It's not possible. Even home monitoring devices, you cannot use it to monitoring these things. So only by ambulatory BP monitoring, only you know that during sleep, what is your blood pressure. Early morning surge of blood pressure. After awake, first 2 hours of BP, what is your blood pressure? So compared to the lowest blood pressure of the previous night. If that has a surge, it is very classically correlated with early morning stroke and intracerebral hemorrhages. So it's and cardiovascular events as well. So these things not possible. No one is going to get soon after getting up, keep monitoring the home monitoring device is not possible to use it. So these are all the things which is not possible by any other methods. In hospital visit not possible. Soon after getting up, nobody is going to, unless the patient is admitted, you cannot do it. So these are the practical things which is picked up, important values which has a correlate with cerebrovascular and cardiovascular events is given by the ambulatory BP pressure monitoring events. Other important is what happens to nighttime blood pressure. There's nocturnal dippers, non-dippers, reverse dippers, extreme dippers. Let me show the things. Normally you can see that the patient's blood pressure during sleep 10 to 20% 10 to 20% dips, both systolic and diastolic. That is normal phenomena. They are called dippers, which is not happen. The dipping is less than 10%. It is all non-dippers. Non-dippers are likely to have more cerebrovascular cardiovascular events. It is proven. Sometimes extreme dippers, more than 20% dip. There is nocturnal hypotension can happen sometimes. This is also increased cerebrovascular episodes and hypoperfusion. Reverse dippers, nocturnal surge of blood pressure. Again, that is during sleeping time, BP is more than the awake time, which is also increase the risk of all other cardiovascular impact. So how is this? The sleeping pattern of blood pressure is not at all possible by any other methods except using this ambulatory BP monitoring. All those things are very important to avoid the end organ damage and cerebrovascular and cardiovascular events. And adjusting the medication to avoid all those things will definitely have the huge impact on the complications. This is what normally you get the report and you advice for the ambulatory BP monitoring. How many hours are recorded? That's what you see, that this total duration of recording is 24 hours. And then you can see that how many daytime recording, how many nighttime recording. So 16 hours of daytime recording, 8 hours of nighttime recording has been done. What is the quality of recording? More than, as I mentioned it, the quality of recording here is 94%. So to say the valid report, the quality of recording should be more than 70%, good recording. All the recordings may not be good in ambulatory because of so many circumstances, but at least more than 70% recording should be good. In this patient is 94% recording. If you have split it out, it is 93 and 100%. During sleep, because the patient is not much mobile, it is perfect recording, you will get it. This is what you will get, average recording. Average recording, the goal is, as per the guidelines, below 130 by 80 is the goal in average blood pressure ambulatory BP monitoring. And this patient is perfectly maintaining. And that is daytime is 130 by 85 and nighttime is 120 by 70 current guidelines. All those things this patient is achieving. Suppose if you see these are all erratic, then the nighttime is not achieved, daytime is not achieved, all those things you will see. And then you see this dipper and non-dipper. So systolic is the BP is not going down, is non-dipper, and diastolic is a dipper, but systolic is a non-dipper. Systolic blood pressure is still, it is less than 10% is only dropping, so it is a non-dipper. So this has an impact. So this has some value in, so you can analyze it. It gives a recording, but each BP systolic, diastolic will be given, and during awake time, sleeping time, again awake time, then the early morning surge, you can see that after getting up, the surge is happening. All those things you have to talk to the patient, you have to any possibilities of fine-tuning the medication. The graphical record has been given, awake, sleep, and during sleep. You have to see that, and heart rate chart also given during sleep. You can see the stable heart rate during sleep and daytime, the fluctuating heart rates. All those data will be given a graphical format in ambulatory BP recording so that one has to analyze it. So, and it's not necessary to react to each and everything, so, but certain modification needs to be done. Say the patient is a reverse dipper or hypertensive or nocturnal hypertension or early morning surge, where you need to adjust a certain bit of medications, one has to react to it. Other most important thing is the home monitoring. Even the guidelines recommend home monitoring device. So home monitoring device should be recorded 2 measurements at 1 minute interval in the morning and evening, at least for 7 days as an initial diagnosis, and later on follow-up. It's more useful for long-term follow-up. Once you established by using this ABPM, and you can use tell the patient to know you can weekly once or monthly once or twice, you can keep monitoring with your blood pressure. That is useful. But what is not possible home monitoring is this circadian variation, nocturnal deduction of blood pressures, and true resistant hypertension. All those things are not possible with the ambulatory BP monitoring. So you can detect the whiteout hypertension, masked hypertension, to certain extent you can detect it, but the most important thing is nocturnal BP recordings are not possible, which has a huge impact on the outcome. So that's as we ambulatory BP monitoring be used. It's more of used for the long-term maintenance once you confirm it. So when should you use it? So for diagnosis, as I mentioned, whiteout hypertension and masked hypertension will be diagnosed in this patient. Pregnancy-related hypertension, instead of over-treating it, patients can be monitored, and then if really necessary to treat it, they can detect it. And evaluate the effect of antihypertensive treatment. That is very, very important. Once you start the medications, are they responding it, or we need to escalate it, or you need to change the combination, or the timing of the medicine to be adjusted. All those things, can be taken decision based on this ambulatory BP monitoring. And the cardiovascular risk assessment, instead of office BP measurement, so out of office BP measurement has a huge cardiovascular impact. As I said, nocturnal the variation and all, it's prognosticate not only a cardiovascular risk, but also prognosticate the value. Instead of the patient, every hospital visit is BP perfectly normal, but if you do that, these things, nocturnal early morning surge, nocturnal reverse dippers, all those things are there, then nocturnal hypertension is then documented, which is closely correlated with the obstructive sleep apnea. All those things to be diagnosed and treated appropriately to avoid the complications. So the current guideline says that the average BP when ABPM should be 130 by 80, below that. Daytime should be below 135 by 85, nocturnal should be below 120 by 70, and early morning BP should not be more than 135 by 85. We have to get all those recordings correct in ABPM. These are all possible: daytime, nighttime, average BP, early morning BP, all those things, nocturnal dipper or non-dipper, all those things are possible by ambulatory BP monitoring. It's not possible by office visit or home monitoring devices. What are the challenges? Why we are underutilizing it? So because lack of availability, lack of awareness, and there's a huge number of master hypertension, vital hypertension still there in India, and less acceptance due to cost. Even Chennai city, it is anywhere cost about around 6,000 to 10,000 rupees for 24 hours recording. So when you have the hypertensive patient very decline, immediately they'll propose that I have the apparatus at home, I will let me monitor it. So as a physician, we should know that what we are going to get it from ambulatory BP monitoring, how it differs from the home monitoring devices, which is very important. So the patient discomfort, operational difficulties, these are things, even I am sure that it's in Tier 2, Tier 3 cities, it is, ambulatory BP is not available. So it is only major metro cities are available. So these are the limitations we are facing it. Let me proceed to a few minutes about the Holter monitor and extended Holter monitor. And Holter monitor is which much more awareness is there among the physicians because it's very widely used as compared to ambulatory BP monitor. Holter monitoring device is a ECG recording tool which is connected, traditionally connected with the multiple electrodes, which gives many of the Holters will give 3 channels. But we have the up to 12 channels. Regular ECG itself can be recorded. 12 channel Holter is also available, and it is multiple electrodes to be fixed and connected to the body. Patient can be commonly we should encourage the patient to be out of the hospital only. There is no point in doing Holter at in hospital except some circumstances, because we should know that during activities what is the pulse and other things. And nowadays, because of the multiple wires, any one wire disconnected, sometimes recording will not be proper, all those things, problem, patient is not comfortable during sleeping time. So nowadays we are using these patches. Patches can record as a Holter or 1 day, 2 days, 3 days, 5 days, 7 days, 2 weeks. All those things can be extended. Just one battery has to be changed, then otherwise it's continue to record it. Then disconnect it and put it on the computer and analyze it. Or sometimes it can be paired with the mobile phone. Through the mobile data, it can be transferred to the server. Even if it will get the live recording also every few hours. These are the technologies available nowadays freely in every city in India now. Let me share some case examples, how to utilize it. This is a gentleman, 82-year-old male, post my atrial replacement, came with, brought to the emergency with a staring look while lying and was unresponsive for 1 to 2 minutes with the stiffness. And his echo showed some moderate AS. This was the ECG. This is RB with the LHP with the PR of 180 millisecond. So anybody is losing consciousness in lying position within 1 or 2 minutes, completely come back to normal and talking to perfectly as it is, nothing happened. We have to think of first is a very high risk of cardiac syncope. That's what we emphasize. So when we connected the Holter monitor, this is what you see, complete heart block is a sinus rhythm, sometimes goes into complete heart block, and long asystole, 5 seconds of asystole happens. That's where the patient gets into stiffness, what we call Stokes-Adams or convulsive syncope. It should not be treated like a seizure disorder or anything. It is a convulsive syncope due to asystole. Another patient 10 years back, undergone bypass surgery, just walk into the OPD saying that I'm feeling palpitation suddenly lasting for a few minutes, then I feel giddy, but then it becomes normal. Then we said, okay, so let us connect the Holter. The Holter showed, even though it's perfectly adequate LV function, bypass surgery, old infrared MI, and so it's non-sustained VTs keep happening. It is good to feel lucky enough to this is what I was meaning, 12 channel Holter, you can see all the 12 channels you can see. This helps us to, it is where is this ventricular tachycardia is coming from. Being electrophysiologist, we emphasize on 12 channel holders because any arrhythmia picked up, we can localize it where it is coming from. So from there we can see it is coming from the left ventricle, from the inferior, where it's got an inferior wall MI. From there only this VT is coming, it is a scar ventricular tachycardia. So it established a diagnosis and we took him for ablation and corrected it. So he is doing almost more than 10 years, he is doing well. Not only ventricular tachycardias or bradyarrhythmias, and we can see this patient, you know, 16-year-old male palpitation, ECG shows couplets. One sinus rhythm, two couplet, one sinus rhythm, couplet. This commonly every practitioner will see some patient comes with the palpitation or misbeats. You take ECG, you will see some bigeminy, trigeminy, some pelvises. Many times we will reassure and tell them on a patient, but it is not. We always emphasize on do the Holter monitor and pick up what is the burden of that PVC. We can see this burden PVC is almost 11%. This burden plays a very important role. Too many PVCs sometimes weaken the heart. What you call PVC-induced cardiomyopathy can happen. That's what this is very important. Either you medically manage it or ablate it, where you find out the source and ablation with the radiofrequency ablation can eliminate the PVCs if they are symptomatic or very high burden. Not only that, the Holter shows not frequency alone is not important, where it is coming. You can see this PVC, even though it's not many PVCs, that PVC is coming almost close to the T wave of that previous P wave, previous complex. This is called Arante phenomena. You can see classically it is coming this PVC falling on the peak of the T wave, which induces VF. Arante phenomena is classically taught on our MD days. It creates ventricular fibrillation. That's what this happened to this patient, discharged to the primary PCI, and then got giddiness and evaluation. You can see this PVC creates polymorphic VTVF. So these, not only this frequency, timing of the PVC is also very important. If it comes to very close to the previous complexes, it can trigger PVC. And this patient's recurrent syncope, Holter was normal, but getting multiple syncope and injuries. When you connected the ELR, that's what I meant, extended monitoring. This extended Holter monitoring yield is much higher than the regular 24 hours monitoring. 24 hours Holter monitoring yield is very less. We always, so the patients will go for a more than 24 hours, like 3 days, 7 days monitoring. So it's picked up the long passes with sinus node dysfunction. That's why he was losing conscious. Another old man, you can see perfectly normal ECG, narrow QRS ECGs, recurrent syncope with injury, multiple Holters, 2-3 Holters were normal. When I said to just go for 2 weeks, monitor and come back, then he came with a high-grade AV block. Okay, so these are all things. Extended monitoring yield will be very high in a syncope patient. Even the palpitation patient, this girl, repeated palpitation lasting for a few minutes only, not able to document it. You know, even to the extent that the family took her to the psychiatrist because she's keep complaining something which is not able to do anything. So then the extended monitoring shows that SVT is going on, lasting for 5 minutes, then stops on its own. When we took her for ablation and then once for all the problems solved for ever. So these are the problems. This lady continuously antiepileptic medication, antidepressant medication due to syncope, repeated syncope. Nobody nothing documented. Then my neurologist called me saying that this patient is a psychogenic thing. When we monitor the 1 week during the episode, atrial tachycardia, atrial fibrillation was happening. When we ablated it, now almost 3 years, no episode, no medications, he's doing only on beta blockers, doing well. So these are the possible, to the extent that we can record the ECG for 3 years. That's what I would like to emphasize. 1 week, 1 month also, we can 3 years also. When the clinical suspicion is strong, you can go for extended monitoring. This repeated syncopation, when we put the monitoring, it will come with the complete heart blocker, then we implemented the pacemaker. That's why we launched the syncope clinic a few years back. The recurrent loss of consciousness, not able to pick it up optimally. When should you use the Holter monitor? When should you use the extended Holter monitor? When should you use ILR monitor? When should you use ABPM? Is it orthostatic hypotension is causing the problem? When should you do tilt table test? When we should do the autonomic test? All those things can be decided by the specialist unit. We can be specializing in evaluating this loss of conscious patient. So the last, it's what are the clinical uses of these monitoring devices? Any patient complaining of palpitation, to rule out arrhythmias, tachybradyarrhythmias, you can do the Holter monitoring or extended Holter monitoring. Always preferable to use the extended monitoring for at least for a week. The yield will be high. And our syncope evaluation, it will be very commonly used. And we use for antiarrhythmic medications. Suppose somebody having frequent PVCs, I'm initiating medications, the PVC burden has come down or not. Follow-up Holter only will tell us, and post-ablation follow-up we do the Holter monitoring and ear monitoring. And less commonly used for dynamic STD changes, ischemic changes, QT interval monitoring, heart rate variability. It's less commonly used in clinical practice, but initially commonly used for these three indications only. Thank you very much for.
Thank you. Very short and sweet. Excellently, you said all about ABPM and Holter monitoring. Silent ischemia and diabetic is another indication we do. Do we do it for a silent ischemia?
That's what the Holter shows STD changes, silent ischemias can be used for STD changes monitoring during this thing. Holter monitoring will help us for the silent ischemia.
You rightly said, the availability of ABPM in many of the hospitals it is not available, and only in selected hospitals available. But there are a lot of agents doing it outside. Sometimes free of cost also they're doing.
A lot of pharma companies have come out with that, so they're able to help us.
It is available. It is only you have to take a forward step and do it.
Find out the appropriate channel and refer the patient. So it is freely also available now.
And it is very useful in picking up paroxysmal AF if you do a long extended
monitoring. That's why I showed one patient, paroxysmal AF, where I ablated it also. And stroke patient, unexplained stroke, but MRI imaging showed it's embolic stroke, like multi-territorial stroke. The suspicion of cardioembolic stroke due to atrial fibrillation is very high, but your Holter is not picking up. It's a Holter of no use in those patients because 24 hours AF is not pick it up means it's not going to rule out the problem. If our MRI already showing that it's likely to be of embolic stroke, then we have to go for a long-term monitoring, like at least 1 or 2 weeks monitoring, or the patient's ILR monitoring. Again, ILR is very commonly thing, but it is in our population, we are not able to use it. It is very expensive. That ILR itself cost about 2 to 2.5 lakhs rupees. Our people is not able to afford for that diagnostic tool for 2 to 2.5 lakhs rupees. So at least we go for 2 weeks CLR monitoring, extended Holter monitoring for 2 weeks to pick up any paroxysmal atrial fibrillation, anything that contributing for stroke, so that we can document it and start anticoagulation for them. Because without documentation, starting anticoagulation is a double-edged sword. So tomorrow something happens, medical legally you are answerable. So documentation is very important.
Very true. Are there any questions from the floor?
What for event underwent Holter monitoring?
He came with the palpitation and giddiness. He came with the palpitation and giddiness as outpatient. We connected the Holter.
Did the ECG reveal any abnormal findings before the patient was admitted?
Old inferior MI. ECG showed sinus rhythm of the old inferior MI.
You was treated for it.
Already CABG has been done.
This is second incident. The incident has been extended for the further.
No, sir. His patient suffered inferior MI, angiogram done, triple vessel disease, 5 bypass grafts has been given 10 years back. He was on regular medication, standard optimal medical treatment. One fine day, he came into OPD saying that I'm getting palpitations since few days and some giddiness that moment. Then we fixed the Holter monitor, just picked up the ventricular tachycardia. Otherwise, patient is doing well. The CT angio has been done. All the bypass grafts are working well. LV function was adequate. So he underwent ablation. Your question, T-wave alternance, so T-wave alternance is again important tool for prognosticate sudden cardiac death and other things for many conditions. That also can be used in, Holter monitoring can be analyzed in T-wave monitoring. So that is a very important tool, but certain conditions we ask for it.
One patient who had a complete heart block. He remained unconscious with upper limb weakness. What happened to this patient? This is actually, what is
They'll recover immediately. This is called convulsive syncope. Many patients take anti-epileptic medications also. It's called convulsive syncope. Stroke attempts. People may not able to differentiate stroke attempts attack from the convulsion. The body becomes stiff and rigid, and they few seconds, then it will become perfectly normal. So the witness will tell the doctors that they become stiff and agitated. So immediately the diagnosis is made as a seizure disorder and anti-epileptic initiated. So unless the suspicion is very strong to underlying conditions, so that's the thing. So just because stiffness or anything incontinence, one cannot label it as a seizure disorder. So underlying other things thoroughly evaluated, especially if the patient recovers promptly, unable to converse to you immediately, and we should think of cardiac syncope will be the first priority. scar and ventricular tachycardia. Like the patient what the thing is, even a few years, 3 years, 5 years, 10 years, 15 years, 20 years after MI also the scar, the left with the myocardial infarction can create a ventricular arrhythmias to the maybe stable monomorph VT like this patient, which can be picked up with a Holter. And maybe sometime maybe the patient come to the emergency, the unstable ventricular tachycardia. Many may not even reach the hospital. But the sudden cardiac arrest can happen. So this
is very common.
Very common. So this is very important. That is why the EF is less than 35% after all revascularization. We recommend them to go for a primary prevention AACD implantation because these people are highly prone to develop sudden cardiac arrest due to VTVF.
One last question. You were talking about the burden of VPCs. Does suppressing the VPCs increase the survival rate?
It's a very important. Survival is the one thing aspect to it. The PVCs, so no longer, the concept is people idiopathic PVCs, all PVCs are benign. This blind statement cannot be made by these people, So the PVC has to be analyzed. And the PVCs, as I said, frequency, timing, and site of origin, everything makes very, very important. The Holter says all those things. If I connect the 12-channel Holter, where it is coming from, how frequently it is coming from, is it, what is the risk of the patient is dying because of the PVCs? They say one 10 PVCs comes like that aren't a phenomena. The patient come to me with one episode of syncope and I see only 10 PVCs and I think other days I neglect that PVCs, but this sort of 10 PVCs which is close to the QRS complex, the underlying syncope episode, out of that syncope could have been due to VTVF, polymorphic VTVF rather than due to any other cause. So it's very important, those patients should be picked up and should be evaluated. Some patients we go for ablation, sometimes we go for ICD implantation. Those patients, the survival makes impact. But benign idiopathic PVCs, unless it goes a long period of time, it causes PVC-induced cardiomyopathy, LV function goes down, they come to us with the heart failure. Then we eliminate the PVCs by medication or ablation. Then the EF comes back. Now it's a reversible cardiomyopathy, it will come back to normal. But by and large, many of the PVCs, the burden, we go by the burden. Less than 5%, we can wait and watch. More than 5%, irrespective of the symptoms, we initiate medication. More than 10%, we carefully tell them to every 6 months or 1 year, you do the echocardiogram. If you are not symptomatic also, get the echocardiogram done, the LV function deteriorates or not. More than 10%, we will be very, very careful. We emphasize on the regular monitoring. If they are symptomatic, more than 10%, not responding to medication, we will go for ablation.
He's the head of the critical care department at Apollo Main Hospital. He's a AB certified internal medicine and critical care and neurocritical care. He has got a lot of accolades and publications. So he's going to discuss about arterial blood gas analysis and its implications. Over to you.
Thank you, sir. It's never easy to be the last speaker, and more so if it's related to acid-base disorders. So it's going to be a very tough talk. So my plan for today is just brief physiology about what we need to understand about acid-base analysis, anatomy of how an ABG looks, steps in ABG interpretation, and I'm going to give you a parallel example for each step so that it's hopefully easier for you to grasp. So simplistically, acid is any substance that donates a hydrogen ion, and base is any substance that accepts a hydrogen ion. This is something that we have learned in basic chemistry. Our body has only two kinds of acids, volatile acid and a non-volatile acid. The only volatile acid we have is carbonic acid, which is converted to CO2 and then it's exhaled, and the lung predominantly handles the homeostasis. So any alteration in the carbonic acid, we call it as a respiratory disorder. All other acids in our body are not volatile. So they are all predominantly handled by the buffer system and the renal system, and we call them as a metabolic problem. Since there are innumerous number of non-carbonic acids, we can't measure every non-carbonic acid. It's easy to measure the carbonic acid by measuring PCO2, but it's impossible to measure every single non-volatile acid. So what we do instead is, we need to understand how these acids are managed. So whenever there is a spillover of an acid in the blood, the first defense is the buffering system. Immediately somebody comes and mops it up. That mopping system is the buffering system that is predominantly done by the done by the bicarbonate in the extracellular fluid. Second response is, as I had showed you in the previous slide, whenever there is an H plus added, you see the equation going towards this side, it increases the CO2 and the lungs try to excrete some of the acid, preventing from acid accumulation that happens. The third is kidneys take time to excrete this acid by various mechanisms, which I will not go into for the sake of this particular talk. The predominant buffers are bicarbonate, extracellularly. Intracellularly, it can be protein, phosphate, and hemoglobin, and bone acts as a buffer. Problem again is we can't measure every single buffer like we can't measure every single acid. So what we do instead is we only measure the bicarbonate because it is extracellular, it is easy to measure, and any reduction in bicarbonate means there is more acid in your body, because any non-carbonic acid is immediately mopped up by bicarbonate. So if there is an acid, bicarbonate will go and mop it up, therefore the bicarbonate level goes down. For every 1 unit of acid, 1 unit of bicarbonate goes down. So by just measuring the bicarbonate, we know that there is an excess acid, which we call as metabolic acid, since we don't know what that particular acid is. So with that in background, we know that there are two acids, carbonic and non-carbonic. Carbonic is the respiratory component of the PCO2. The non-carbonic is all other acids in our body. We can't measure all other acids, so we measure the only buffer system, which is the bicarbonate. If there is a reduction in bicarbonate, we call it as a metabolic acidosis. When we actually look at ABG analysis, the traditional approach, and there are three approaches to acid-base analysis. I am going to discuss only the physiological approach, which is centered around this H plus and bicarbonate for the sake of this talk. Any increase in acid is called acidemia. That increased acid can be a volatile acid, in which case it's going to be carbonic acid, and we call it respiratory acidosis. If the increased acid is because of a non-volatile acid, we detect it by drop in bicarbonate, and we call it metabolic acidemia. The opposite is going to be called as alkalemia, depending on respiratory and metabolic. Again, understand that both these are connected in the sense that if I increase my CO2, my bicarb will go up, and vice versa. Therefore, both will go in the same direction. If I have an acid, it will go this side, my PCO2 will get excreted. If I have more PCO2, the reaction will go in this side. Therefore, both PCO2 and bicarbonate go in the same direction to try to compensate if there is increased acidosis. So that is something that we need to remember. So now that we understand the basic physiology, let's look at how an ABG looks. This is how the ABG looks. I just want to tell you that we measure only three things. The ABG machine measures the pH, the ABG machine measures the PCO2, the ABG machine measures the PO2. Everything else is not measured. Very importantly, we put in the temperature, so obviously it's going to be corrected for the temperature. There is no clinical significance at the physiological ranges that we operate that we don't need to really worry about temperature. All this is calculated. The bicarbonate that is provided by the ABG machine is not a measured bicarbonate, it is a calculated bicarbonate using some equation that I will show you later. We put in this data, hemoglobin, temperature, and the FiO2 that the patient is getting. We punch in all this data, and the machine spits out this kind of a report. Understand that we measure only three things, and we are extrapolating bicarbonate based on the measurement. So how do I then know? So here we have the Anderson-Hasselbalch equation that we have actually read in our physiology textbooks, which connects how the PCO2, bicarbonate, and the pH of a solution are connected. In our ABG, we measure the pH, which is basically the H plus concentration. We measure the PCO2, and using this kind of an equation, the bicarbonate is given out by the machine, right? So that is something that we need to understand very clearly. So now that we understand what an ABG is, the first step is to make sure the ABG is valid, that the machine is actually doing what it's supposed to do. If it is not doing what it's supposed to do, then I'm going to be interpreting wrong values. So the first step is ABG validity. I have the PCO2, I have a bicarbonate, I'm going to plug it into this equation, and then I'm going to see whether it matches with the pH of the ABG that I show. There is a formula. For example, depending on the H plus concentration, the pH changes. You can look it up in any of the textbooks. But the usual rule is always confirm the validity using this formula. 80 minus the H plus you get will be the decimal after the 7. I'm going to show you the example here so that makes it slightly easier. Let's take this gentleman here, 25-year-old gentleman admitted for a fissure in anal surgery. For whatever reason, somebody wanted an ABG for a pre-op evaluation, and the ABG is done. So if I normally look at the ABG, I will say pH is less than 7.4, therefore there is acidemia. And I'm going to say that the PCO2 is slightly low, but my bicarb is also very low. So since my bicarb is low, I'm going to call it as a non-volatile or a metabolic acidemia or metabolic acidosis. And I will go on to treat this patient like a metabolic acidosis based on this ABG if I do not look at the validity. I told you the easy way to look at validity is your H plus concentration is equal to 24 into PaCO2 by bicarbonate based on the previous equation that I showed you. So the H plus should be 24 into 37 divided by 22, and that gives me a H plus concentration of 40 if I do the math. For a H plus concentration of 40, 80 minus 40 is 40, so the pH should be 7.40. If it is not 7.40, that means this ABG is wrong, and I should not be interpreting this ABG and making any decision based on this ABG. So the first step of every ABG is going to look at the validity of the ABG. So now that we know the validity of the ABG, now what is the next step? We are going to see whether the pH is acidemic or alkalemic. If it's less than 7.35, we are going to call it acidemic. If it is more than 7.45, we are going to call it alkalemic. If it is within the range, we are going to say it's normal. Next, we want to know whether this acidemia or alkalemia is related to the volatile component or the non-volatile component. If there is a problem with PCO2, we call it respiratory component. If there is a problem with the bicarbonate, we call it as the metabolic component. So that's something that we need to do. In carbonic acid, respiratory component, increase in PCO2, non-carbonic acid, all other acids, we look at by decrease in the bicarbonate. Second example, elderly gentleman was transferred for profound weakness and areflexia, has not been eating and drinking well for a long time. This is what the pH shows. First step is validity. From now on, let's assume that all the ABGs are valid. Let's not look at the validity. Second step is pH is more than 7.45. Therefore, there is alkalemia. Third step is this alkalemia related to the volatile component or the non-volatile component? PCO2 is 50. If there is an alkalemia, PCO2 should be lower because the acid load should be lower. So this is not related to respiratory. However, bicarbonate is 44. Normal bicarbonate is 24. So there is a lot more bicarbonate than your body should have, which means it's a metabolic alkalemia. So the second and third step are, is there acidemia or alkalemia? Is this a metabolic or a respiratory alkalemia? So again, we went back to increase acid, increase alkali. I told you that these two are connected using this equation. Therefore, if PCO2 goes up, bicarbonate should go up, and vice versa if the body is trying to compensate. So the next question in the ABG is the ABG valid? Is it acidemic or alkalemic? Is it a metabolic problem or a respiratory problem? The next I want to know is, now that there is a problem, is your body compensating normally or not? And we know that the body compensates. If the PCO2 and bicarbonate are going in the same direction, it is compensating. If they are not going in the same direction, your body is not compensating. It's very straightforward. Second, it is compensating, but is it compensating appropriately? Is the level of change in CO2 and bicarbonate proportionate to each other? That's what we need to do. Is there a compensation? If there is a compensation, PCO2 and bicarbonate should go in the same direction. Then I need to know, if there is compensation, is the compensation adequate? So there are several tables. If you look at the textbook of medicine, there are several tables that will tell you what the compensation formulas are. I will tell you, do not bother remembering them. It is very difficult for any human being to remember. Use them. There are a lot of online calculators you have nowadays. You can just pull out your phone and use it rather than wasting time remembering these formulas. Okay. So again, the same patient that we talked about earlier, we said pH is alkalemic. We said that it is a metabolic alkalemia. Third question is there compensation? Bicarbonate has gone up. So what should the PCO2 do? PCO2 should also go up. Normal CO2 is 40, here the PCO2 is 50. It is also gone up. So bicarbonate and PCO2 have gone up in the same direction, which means there is compensation. Now the next question is the compensation appropriate for the level of bicarb? Bicarb has changed from 24 to 44, so there is alkalemia, and you're trying to hypoventilate so that the pH will come back to neutral. Is this hypoventilation appropriate to the level of bicarbonate? I'm going to use the formula that I showed you in the previous table. Expected PCO2 should be 0.7 times bicarb plus 21 plus or minus 1.5. So if you plug in bicarbonate of 44 into this formula, the expected PCO2 should be 50 to 53. I'm right around there. My PCO2 is 50. So if I just use the formula, it looks like my PCO2 is appropriately correcting for the metabolic alkalosis I have. There is no excess PCO2, nor there is incomplete PCO2 rise. So there is no other problem. The body seems to be compensating appropriately well. So it's a compensation is appropriate. Again, go back, ABG valid. Is the pH acidemic or alkalemic? Is the primary disorder respiratory or metabolic? Is there compensation? Is the compensation adequate? The fifth step is, what is the anion gap? Here, I want to insist that traditionally we have been taught that the anion gap should be calculated only if there is metabolic acidosis. I'm going to tell you today that calculate anion gap in every single ABG, irrespective of the pH, because there will be a hidden acidosis sometimes, even when the pH is alkalemic. Therefore, always measure the anion gap. The next question comes, what exactly is anion gap? Why am I even measuring it? So you have cations which are positively charged. Sodium is positively charged, potassium is positively charged. Chloride is negatively charged, bicarb is negatively charged. These are the 4 ions that we commonly measure. It looks like if I add sodium plus potassium and subtract it to chloride plus bicarbonate, there seems to be an excess of positive charge in your body, right? Sodium is 140, potassium is 4, so 144. Chloride is 110, bicarb is 24, so 134. 144 minus 134 is 10, which means there are 10 positive ions in our body. All of us in this room are electrically neutral. Otherwise, we'll be shocking each other every time we rub into each other, right? So the body does not have any positive charge or negative charge, just that we don't measure all the positive charges, we don't measure all the negative charges. Therefore, between the charges we measure, there seems to be more positive than negative. That's all there is. And that is what we call as the gap. This gap is called as the anion gap, because there seems to be a gap, but in real life there is not, but because we don't measure all the ions there. So this is the normal anion gap. Now what happens is I am adding an extra anion like a ketone or a lactate to the blood. As I am adding acid, for every 1 unit of acid, my bicarbonate will go down by 1 proportionately. Correct? So now, when I add chloride and bicarbonate, my sodium and potassium has not changed, chloride has not changed, but my bicarb has decreased because I have added more acid. Therefore, if I add this and subtract with this, it looks like the gap has gotten bigger because my bicarbonate has gone down and my gap has gotten bigger. Therefore, we call it anion gap metabolic acidosis, because there is increase in anion gap. On the other hand, I give you a lot of normal saline. Nothing has changed. Bicarb, chloride has increased, bicarb has decreased proportionately for the acid, but the chloride plus bicarb is the same, because the chloride has increased, bicarb has decreased, overall it's the same. Therefore, the anion gap has not changed. So if the acidosis is from increased chloride, the anion gap remains normal, and we call it normal anion gap acidosis. What we need to understand is, anion gap is predominantly made of protein and phosphorus. If you are hypoproteinemic and hypophosphatemic, your normal anion gap will be lower, and therefore the anion gap has to be corrected for protein and phosphorus of the patient. We obviously don't do protein and phosphorus every time we do an ABG, but if there is a recent protein phosphorus or the last protein phosphorus, if you have, then it is good. If you do not have, then obviously you can't correct it. The easiest way is corrected anion gap is twice the albumin plus half the phosphorus. Normal albumin is 4. Twice the albumin is 8. Normal phosphorus is 4. Half the phosphorus is 2. So 8 plus 2, normal anion gap will be 10. If you are hypoalbuminemic and hypophosphatemic, your normal anion gap will be 6. So even 10 is abnormal for you. So that is important, especially in patients in ICU where they are hypoalbuminemic and hypophosphatemic. I am not going to go through the table looking at the causes of metabolic acidosis and alkalosis. Now let's look at this particular patient here. First step, pH, acidemia or alkalemia. pH is less than 7.35, therefore it is acidemia. Now, second question is going to be, is it metabolic or respiratory? PCO2 is 23. In a respiratory acidosis, PCO2 should be high. It's not high. On the other hand, bicarbonate is low. Therefore, it is a non-carbonic acid or a metabolic acidemia. Since there is metabolic acidemia, bicarb has gone down. PCO2, has it gone down in the same direction? Yes, from 40 it has come down to 23. Therefore, there is compensation. The question is there a compensation that is adequate? Pick one of those formulas. I have just calculated the formula for you. 1.5 into bicarbonate plus 8 plus or minus 2. So the PCO2 should be 27 to 31. If you go by this formula, it should be 27 to 31. However, it is 23. What does that mean? My body is blowing off more CO2 than it needs to do to compensate for this acidosis. Therefore, there is also a respiratory alkalemia. It is not only about compensation. I am blowing off more CO2 than my body needs to correct for this pH. Therefore, there is a metabolic acid raised anion. Next one I'm going to talk about is the anion gap. Sodium plus chloride. Sodium is 130. Chloride is 94, bicarb is 14, so anion gap here is 22. I told you that the normal anion gap is 10 to 12. 22 is high. Therefore, this patient has a raised anion gap metabolic acidosis, and the diagnosis would be increased anion gap metabolic acidosis. But because the PCO2 is lower than it should be, there is also a respiratory alkalosis along with that for this particular patient. Going through the same steps again. Is ABG valid? Is the pH acidemic or alkalemic? Is the primary disorder carbonic or non-carbonic? Is there compensation? Is the compensation appropriate? What is the anion gap? Then there is one last step that we need to do. Is the change in anion gap equal to change in bicarbonate? I showed you earlier that if there is an extra anion added like lactate or ketone, this is going to go up. My bicarb is going to go down. Therefore, it looks like the anion gap has increased because the total bicarbonate has come down in our body, right? And I also told you that for every 1 unit of acid, bicarbonate will go down by 1. So if my anion gap has increased by 4, my bicarb should have been decreased by 4. If everything else is normal. It is simple math, right? It's like how we sit and calculate our varavu selavu kanakku, right? That's essentially how it is. So for every increased acid, bicarb should have gone down by 1. If that is not true, there is something else affecting the bicarbonate. Is that very clear? If my anion gap change and the bicarb change are the same, then I am fine. I have tallied. Anion gap has increased by 4, bicarb has decreased by 4. My tally is done. I can close the bank and go home. If my anion gap has increased by 4, but bicarb has gone down by 8, then 4 is accounted for by the anion gap. Then there is some other factor that has decreased the bicarb by 4, right? That is going to be a non-anion gap acidosis in addition to the anion gap acidosis. So this is what we call as a delta ratio or a delta-delta gap. Basically, we are accounting for every bicarbonate change and whether that is proportional to the anion gap change. You will see it in this example here. Give me 1 second. Yes, okay. It's the right example. All right. So pH is acidemic or alkalemic? Acidemic, everybody agrees. Metabolic or respiratory? Metabolic, everybody agrees, right? Is there compensation? This is down, this is also down, so there is compensation. Is the compensation appropriate? The same example, I used the same numbers from last time. No, the PCO2 should be 27 to 31, it's lower than 27, which means this body is trying to blow off more CO2 than what it should. So there is a respiratory alkalosis. Last step, calculate the anion gap. In this patient, sodium and chloride have changed 130 and 100. So here you can see the anion gap is 16. Normal anion gap is 12. This patient's anion gap is 16. Therefore, how much has the anion gap changed? 4. How much has the bicarb changed? 10. It's come down from 24 to 14. Anion gap has changed by 4, but bicarbonate has changed by 10. Therefore, there is another factor that is dropping the bicarb, which is not accounted for by the anion gap. Therefore, it has to be a non-anion gap process or non-anion gap acidosis, also contributing to the acidosis in this particular patient. So to conclude my talk, some basic principles. Understand acids are volatile or non-volatile. Only one acid is volatile, which is basically PCO2. We call it the respiratory component. All other acids are non-volatile. We can't measure them. Therefore, we measure only one buffer, which is bicarbonate. Anytime the buffer is low, we call it metabolic. pH is determined by PCO2 and bicarbonate for all practical purposes. Change in one will elicit a change in other in the same direction. We saw that based on the equation we have. And if they go in the same direction, there is compensation. And you have to, if there is compensation, you have to go back to that one of those tables, online calculators, and calculate whether the compensation is adequate or not adequate. And metabolic component is complemented by calculating an anion gap using sodium, potassium, chloride, and bicarbonate. Conclusion about ABG interpretation: don't treat the ABG, treat the patient, right? Ultimately, if the patient is fine, I would treat the patient, not the numbers. Always check for the validity of the ABG, because a lot of times we get a wrong ABG and we unnecessarily treat it. I've given you the rationale for the 6 steps. Be systematic the first time and then every time after, so that we don't miss any particular issue related to the ABG analysis. Look at the degree of compensation. If the compensation is exceeding or is it inadequate, then there is a second acid-base disorder. We saw that in the patient with respiratory alkalemia. Always calculate anion gap in all patients, not only in metabolic acidosis. Correct the anion gap if possible for albumin and phosphorus to avoid any fallacies. Account for all the bicarbonate. So every drop in bicarbonate should be accounted for by the change in anion gap. If that does not happen, then there is a metabolic alkalosis or a additional metabolic acidosis from a non-anion gap component. Thank you so much.
Thank you, Ramesh. I think the current generation of ABG machines did show the anion gap, calculated anion gap, and the electrolytes too.
Great.
That's what I used to see. Every day I see the anion gap is calculated.
Anion gap is calculated, but it is never corrected for the albumin phosphorus by any of the machines that I know of, unless there are new machines in the market. But anion gap is automatically calculated by the ABG, but the correction for albumin phosphorus has to be done at the bedside by us.
So every time you have to pull out the phone?
No, I don't check the albumin phosphorus every time. I go for the most recent, because albumin doesn't change every day. So I just look at the most recent albumin, most recent phosphorus, and approximate. And that amount of variation is not going to really affect in our clinical decision making. So that's what I do practically. It's not possible to do albumin phosphorus every time we do an ABG, sir.
And as a clinician, we do ABG in the clinical settings. Whenever we think of type 2 respiratory failure, we check for the PCO2, things like that. Maybe in the critical care, you do all these things. Hypoxia, gross hypoxia, we can pick up in the OPD itself with the currently available pulse oximeter.
Yes, sir.
Very useful for us as a clinician in the clinical setting, the type 2 respiratory failure, with the COPD patients dropping in, or asthma patient coming in with the hypoxia, severe hypoxia. So it is very useful for us. Remembering all these equations is going to be very difficult for a physician. Is there any shortcut for this? I'm asking question on behalf of you.
So the commonest all of us are going to see is, like you said, type 2 respiratory failure with respiratory acidosis, no doubt about it. But there is something else that precipitated the type 2 acidosis in most patients. Most commonly, it's infection in a COPD or pneumonia, or pulmonary embolism, or cardiogenic shock with they're already hyperventilating because of other things that are happened. And when they are coming sick enough needing an ABG, there is usually another etiology that is going to contribute to another acid-base disorder, most likely metabolic acidosis in those patients, either because of lactate from sepsis or dehydration, whatever it is. So I agree, respiratory acidosis, at least if we can pick up acidosis, most likely respiratory, I think we have done 2 steps. Third, like I said, it's easy. Is the PCO2 going up, bicarb should go up. Then that, again, nothing fancy to remember. Once that is done, I don't remember any formulas. I just open my calculator and say, okay, PCO2 is going up, bicarbonate is going up. Are they appropriate? Open the calculator, put the numbers in. It will tell you whether it is appropriate or not. That is very easy to do. Doesn't need anything. Anion gap is given in most of the ABG machines. And the only other thing that you have to do mentally is if the anion gap has changed, has the bicarb changed appropriately. So that that's why I said we probably don't need to remember all the formulas. Most of the other formulas are just to explain the rationale for why each of those steps are there. So I still feel, just looking at it, we'll get anion gap is increased, acidosis is there, PCO2 is high, then automatically you should say PCO2 is high, respiratory acidosis, but anion gap is also increased, which means there is another hidden cause. At least that much, then you know the patient is sick enough to move to some place. Then maybe a nephrologist or a ICU physician can come and figure out the nitty-gritty details of acidosis. From as a practitioner point of view, I think the first 3-4 steps to identify who needs to be triaged to an acute care setting, I think would be very helpful. I don't have any other easy formula other than that, sir. Poisonings. CKD.
Is the current the ABG machines give the sodium and potassium. Whenever we suspect hyponatremia or hypokalemia or hyperkalemia, it's very useful for us. Those when you take ABG,
absolutely.
Instead of sending sample and
hemoglobin comes with it, sir. Hemoglobin, sodium, potassium. New machines give ionized calcium. So there's, newer machines even give you urea creatinine. So by one snapshot, like if CKD patient comes, iStat machine gives you all those variables along with the ABG. So it gives you a snapshot of at least the electrolytes, the basic parameters that a physician would want to look at. It will be definitely helpful, sir.
Are there any questions from the floor?
Sir, in the first slide I showed you there are 3 methods to look at acid base, sir. We went through the traditional approach of anion gap and bicarbonate. So there are 2 other approaches. One of them is the base excess approach. I will tell you how it is derived. The original physiological approach was originally propagated in US. Europeans said, no, you are wrong. So obviously, as always, they have to figure out something to be wrong with America. So they basically said, we call any change in bicarbonate as a metabolic component, right? But I also showed you in one slide, every time PCO2 changes, my bicarb will change. So my bicarb is never a pure metabolic abnormality because it is also influenced by my PCO2 to some extent in the body. So the European says, how can you call bicarbonate as a metabolic component when it is not a truly metabolic component because PCO2 can also affect bicarbonate. So they had to invent something better. They said, I will use base excess or base deficit. All it means is my pH is 7.4, it is now 7.2, I am acidemic. I need to keep on adding some base to get the pH to 7.4. How much base should I add to get the pH back to 7.4 under ideal conditions, hemoglobin of 10, normal temperature and all that stuff? To get the pH back to 7.4 is the base deficit. That is how much deficit I have. If I am pH is 7.5, I need to keep on removing base till my pH comes to 7.4. So I call it base excess. So basically this is how both one system evolved, then the other system, Europeans basically said you are wrong and we need to have a better system, and they came up with the base excess and base deficit system. There are similar formulas for base excess and base deficit, but I felt anion gap is what is traditionally used, I stuck with it, sir. Plus or minus 2, because you should, base excess or base deficit means you have excess base or negative base. Ideally, you should not have anything. No, so plus or minus 2, up to plus or minus 2 is okay, right? Plus 2 or minus 2, anything more or less is considered abnormal.
The last question, when you give bicarbonate injection, whether you use bolus dose or infusion dose,
I give bicarbonate bolus only in life-threatening situations, hyperkalemia with acidosis, peri-arrest, somebody is in front of me going down, I don't know why, I don't have time to check anything, just push bicarbonate for whatever it is worth. Very rarely in a cardiac arrest with pulseless electrical activity where we feel acidosis could have been a cause of arrest. Otherwise, pushing bicarb is almost always not necessary. Pushing bicarb will immediately shoot up your PCO2. If you're already not breathing and you push up your PCO2, because immediately the equation will go in this direction and you will have PCO2, you can create a lot of harm. So therefore, we don't push bicarbonate at all in real life unless we have one of these 3 conditions. In all other conditions where there is acidosis, we almost always use an infusion of bicarbonate. The target pH would be 7.3. If I have achieved 7.3, I stop the bicarb infusion. You don't have to keep on giving it till 7.4. If it's below 7.3, we start bicarb infusion, reached up to 7.3 and stop, mainly because patient will get hyperkalemic. And as you correct the PS, they'll go into hypokalemia, hypocalcemia, all those things. So at 7.3, we stop. That's what the studies have shown. So venous sample, if you think about it from a logic point of view, blood flows to the organs, organ metabolize, that blood is collected by the venous and comes back, right? At the end of metabolism, you produce more CO2 and you utilize oxygen. That's how your body metabolizes. So the PCO2 will be higher in the venous sample than the arterial sample, and the PO2 is a venous sample. So we are not going to look at oxygenation in a venous sample, you're only going to look at acid base. PCO2 is higher in a venous sample by about 5 millimeters mercury. So if arterial is 40, venous will be 45 normally. Anything above than that is abnormal.
Thank you, Ramesh. I can give you one good news where both the American.
Yes, sir. No role. Bicarb. Thank you, sir. Thank you so much for the opportunity.
Thank you so much, sir. Now I welcome Dr. Jayakumar, sir, Scientific Chairman, to give the vote of thanks.
Good evening, doctors. I thank our D Club founder president, Dr. Dhanamitran sir, our Dr. Natarajan sir, our organizing secretary, Professor Dr. Parandaman sir, our organizing chairman, Professor Dr. Swami Kanu sir, senior physician who is there with us throughout this conference, Dr. U.V. Mohan sir, who is the organizing joint secretary, scientific committee persons, Dr. N. Kannan sir, Dr. Jay Ganesh sir, Dr. Arvind Babu sir, food committee, Dr. Kamal Kannan sir, Ram Kumar sir, reception committee, Dr. Vetrivel sir, Dr. Sarath Babu sir, our senior D Club member, Dr. Murugan sir. I thank all our delegates who have joined the conference. I also thank the event management and the staff, AV. I thank the sponsors. I thank the hotel's management staff. Again, I welcome you all delegates for our next conference, D Mantra, to be held in November 2025. Thank you all. Have a nice evening.
Thank you, sir. I request all of you to stand up for the national anthem.
Janagana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे